VWD, is a bleeding disorder characterized by a deficiency or dysfunction of von Willebrand factor, VWF. In the vast majority of cases, VWD is an inherited disorder caused by mutations in the VWF gene. VWF is involved in platelet adhesion and prevents degradation of factor VIII, PVESL. Epidemiology. The most common congenital bleeding disorder scent prevalence, estimated to affect approximate 1% of the U.S. population. TI epidemiological data refers to the U.S., unless otherwise specified. OOE. Etiology. Type description: Type 1, 80–85%. Inherited von Type 2, 15** VWD caused by mutations in the Willebrand disease. _29%. VWF gene, 1 Type 3, 3%. VWF deficiency that occurs acquired von Willebrand disease secondary to other medical, AVWD, conditions. 3. OVA. Pathophysiology. Deficiency or dysfunction of VWF leads to scent dysfunctional platelet adhesion, impaired primary hemostasis, reduced binding of factor VIII, increased degradation J factor VIII activity, impaired intrinsic pathway of secondary hemostasis, or AO. Clinical features. Back. Variants of von Willebrand disease, 2 etiology. Autosomal dominant inheritance. Autosomal dominant inheritance, autosomal recessive inheritance. Autoimmune diseases, example SLE, hypothyroidism. A collapse. Mild to moderate deficiency of VWF and factor VIII. Complete absence of VWF. Lymphoproliferative and myeloproliferative diseases, example multiple myeloma, monoclonal gammopathies, lymphoma, essential thrombocythemia, cardiovascular defects, example ventricular septal defect, aortic stenosis, side effects of certain drugs, example valproic acid. Clinical features. The severity of symptoms varies between the different types of VWD. Type 1 and AVWD usually manifest more mildly. Type 3 is the most severe form. ALD, often asymptomatic, symptomatic individuals may develop the following symptoms: OE mucocutaneous bleeding equals ecchymosis, easy bruising equals epistaxis equals bleeding of gingiva and gums equals petechiae, prolonged bleeding from minor injuries, OE bleeding after surgical procedures or tooth extraction. CAGL bleeding can be caused by angiodysplasia, menorrhagia, affects up to 92% of women with VWD. 5. Copyright postpartum hemorrhage - copyright severe cases, large hematomas. Hemarthrosis, life-threatening bleeding, example during childbirth. Degree. WA. Co. Diagnostics. History. Scent recurrent episodes of bleeding since childhood. Scent often positive family history. Laboratory studies. 2. Scent T bleeding time. Scent normal or TAPTT, may be prolonged as a result of factor VIII deficiency. Scent normal PT and platelet count. Scent factor VIL-Co. Scent VWF antigen levels, aristocetin cofactor assay, failure of platelet aggregation or aristocetin cofactor level. Go. OO. BQO Shano. Treatment. Treatment is only indicated if symptoms occur or as prophylaxis before surgical procedures. 2. Inherited von Willebrand disease. Desmopressin, DAP, stimulates VWF release from endothelial cells. Copyright best initial treatment for mild or moderate symptoms, typically type 1 and, sometimes, type 2. Copyright not effective for type 3. 1 * concentrates containing VWF and factor VIII, indicated for severe bleeding, as prophylaxis for surgical procedures, and if DAP treatment is ineffective. Scent other treatment options, antifibrinolytic drugs, i.e., aminocaproic acid, tranexamic acid, oral contraceptives for menorrhagia. Acquired von Willebrand syndrome. Desmopressin and VWF/8 concentrates are often less effective than in inherited VWD. Plus, patients may benefit from intravenous immune globulin, IVIG, treatment. Scent treatment of the underlying cause. Copyright, platelet aggregation inhibitors, example aspirin, NSAIDs, clopidogrel, and intramuscular injections are contraindicated in von Willebrand disease because they further increase the risk of bleeding. XGO Y and Sources. Last updated October 31, 2022. Back collapse fine text outline. Euro_von Willebrand disease, 1/1. Adhesion. Bernard-Soulier syndrome IES27NVL, damaged vascular /S$ equals 2Y endothelium of 4s, X von Willebrand, smiley face, 16 GPBRA at YY, expose Lagen disease opposed collage. Aggregation fibrinogen sent Glanzmann, /thrombasthenia GPLLB/IILA-R. /WYLAA. 3. W7. Congenital disorders affecting primary hemostasis VV red indicators link syndromes with their associated defective or absent molecules, according to which phase of primary hemostasis is affected, i.e., adhesion or aggregation, copyright Boss. Iron deficiency anemia. Iron deficiency anemia, IDA, is the most common form of anemia worldwide and is caused by inadequate intake, decreased absorption, example atrophic gastritis, inflammatory bowel disease, increased demand, example during pregnancy, or increased loss, example gastrointestinal bleeding, menorrhagia, of iron. Prolonged deficiency depletes iron stores in the body, resulting in decreased erythropoiesis and anemia. Symptoms are nonspecific and include fatigue, pallor, lethargy, hair loss, brittle nails, and pica. Routine screening is only recommended for certain groups. IDA typically manifests as hypochromic, microcytic anemia, but it may also be normocytic. If diagnostic confirmation is needed, a low ferritin level indicates an iron deficiency, but additional iron studies may be necessary. Once IDA is confirmed, the underlying cause must be determined. In adults, this typically involves a gastroscopy and colonoscopy or, in women with abnormal uterine bleeding, a gynecologic workup. In children, a thorough history and review of symptoms, including a comprehensive dietary history, can help direct any further diagnostic evaluation. Patients with anemia severe enough to cause cardiopulmonary instability, or pregnant patients with a HB. VA. OE. Epidemiology. * most common form of anemia worldwide. 3% of the general population in the U.S. is affected. 2% African American and Mexican American populations in the U.S. are at increased risk. Plus prevalence is highest in 3. Copyright children up to 5 years of age, see IDA in children and adolescents, copyright adolescent and premenopausal adult females, due to menstrual blood loss, pregnant women, see IDA in pregnancy, epidemiological data refers to the U.S., unless otherwise specified. FO Red. Etiology. Based on age LL. The most common causes of IDA in different age groups include, sent older adults 50 years or resource-rich countries, colon polyps/carcinoma copyright resource-limited countries, hookworm infections, example Ancylostoma duodenal, Necator americanus e adults. In resource-rich countries, adults aged 50 years who present with IDA should have colon polyps/carcinoma ruled out as a potential underlying etiology. Based on underlying mechanism/LCL. Iron losses. Sent bleeding copyright gastrointestinal bleeding equals occult gastrointestinal malignancy, example colon cancer, hookworm infestation, example Ancylostoma species, and americanus, equals peptic ulcer disease increased risk with NSAID use 7O menstruation, particularly for individuals with heavy menstrual bleeding. Copyright hemorrhagic diathesis, example hemophilia, von Willebrand disease, St. Meckel diverticulum. St. dialysis-dependent renal failure. St. frequent blood donation. Decreased iron intake. St. chronic undernutrition. St. cereal-based diet. Back collapse. Find text outline. SS decreased iron intake. St. chronic undernutrition plus cereal-based diet, asterisk strict vegan diet 1. Decreased iron absorption. Asterisk achlorhydria/hypochlorhydria, example due to autoimmune or Helicobacter pylori infection-induced atrophic gastritis, 4. St. inflammatory bowel disease, celiac disease. St. surgical resection of the duodenum. Asterisk bariatric surgery. Increased demand. St. pregnancy. St. lactation. St. growth spurt. St. erythropoietin, EPO, therapy. Exo. Pathophysiology. St. iron deficiency. J. binding of iron to protoporphyrin, last reaction in heme synthesis, production of hemoglobin. St. For more information about the different physiological roles of iron and associated laboratory parameters, see iron in trace elements and iron studies in laboratory medicine. OO. OE. Clinical features. Frequently asymptomatic fatigue, lethargy. Pallor, primarily seen in highly vascularized mucosa, example the conjunctiva, a cardiac, tachycardia, angina, dyspnea on exertion, pedal edema, and cardiomyopathy. In severe cases brittle nails, koilonychia, spoon-like nail deformity, hair loss. Pica, dysphagia. Angular cheilitis, inflammation and fissuring of the corners of the mouth/atrophic glossitis, erythematous, edematous, painful tongue with loss of tongue. Papillae, smooth, bald. Appearance, IDA can be associated with Plummer-Vinson syndrome, PVS, 9. Copyright triad of iron deficiency anemia, post-cricoid dysphagia, and upper esophageal webs, equals thin membranes of normal esophageal tissue protrude into the esophagus causing symptoms such as dysphagia, odynophagia, and food impaction. Equals acquired esophageal webs are much more common than congenital webs and are mainly observed in Plummer-Vinson syndrome. Associated with an increased risk of esophageal squamous cell carcinoma and glossitis. Copyright etiopathogenesis unknown. QB diced plum, dysphagia, iron deficiency anemia, carcinoma of the esophagus, esophageal webs in Plummer-Vinson syndrome. References. IL 101. X. Screening. Indications 1. Recommendations for screening vary between medical bodies. St. Consider screening in the following circumstances. Back collapse. Find text outline. Copyright individuals with a history of IDA. Copyright individuals with risk factors for IDA. Copyright anticipated high blood loss surgery 1.50 infants and children, see IDA in children, O pregnant individuals, see IDA in pregnancy. Recommended intervals, 11. Non-pregnant women. Copyright with any risk factor for IDA, excluding menstruation, or previous IDA, annually. FN copyright without risk factors for IDA, excluding menstruation every 5 to 10 years. Sent pregnant individuals and children, see special patient groups. Screening for IDA is not recommended in asymptomatic men and postmenopausal women if they have no risk factors. FL. OES. Diagnostics. Approach. Sent initial investigations. Copyright routine studies, CBC, plus blood smear, to check HB and HCT. Copyright iron studies, to confirm the diagnosis of iron deficiency. Evaluation for underlying causes of iron deficiency, recommended in the majority of patients. Sent empiric iron therapy can be initiated if, copyright the patient's history points to a clear explanation for IDA, example history of multiple blood donations or inadequate nutritional iron intake. 1. Copyright no pathology is found in a young, otherwise Healthy patient after the initial investigations. Routine studies, 1I16I17. Plus CBC. O hemoglobin. The WHO definition of anemia is a hemoglobin level less than 2 standard deviations below the mean, adjusted for age and sex, i.e., 107 equals men. Equals can help distinguish IDA from anemia of chronic disease and certain types of thalassemia, in which the RDW is usually normal, 20. Equals see also serum laboratory findings in microcytic anemia. Plus peripheral blood smear, anisocytosis and hypochromasia, hypochromasia, increased zone of central pallor, equals 21. 9 degree 30 at IA at, 9% degree OE 3 degrees and OE at degree 5 me at 2 asterisk 006 registered K1A. Diagnosis of iron deficiency ML4 LL171 I22. Back collapse fine text outline. Diagnosis of iron deficiency ML4 LL171 I22. St. Laurent Studies Copyright Best Initial Test, Serum Ferritin, 21 asterisk. 6. In combination with an elevated TIBC, low ferritin and iron levels are diagnostic of iron deficiency anemia. 6. Increased ferritin does not rule out iron deficiency anemia. It can be increased in response to simultaneous inflammation. Evaluation for underlying cause, 1L22. Evaluation for underlying causes of iron deficiency 1622 suspected etiology indication studies all patients, colonoscopy with EGD consider celiac serology. Normal endoscopy or endoscopy declined. All men non-menstruating women history or signs of bleeding, example melena, epigastric pain, hematochezia, asterisk signs of malabsorption copyright H. pylori, urea breath test, asterisk risk of GI malignancy 22 copyright select patients gastrointestinal pathologies. A copyright age 50 years equals video capsule endoscopy degree history of polyps or inflammatory bowel disease equals fecal occult blood / fecal immunochemical test. Origin from or recent travel to resource limited subtropical or tropical area Yemen. Ions, 241 eosinophilia on CBC examination of stool for ova and parasites, C. hookworm infections. Degree. Gynecologic workup for menorrhagia C. Diagnostics in abnormal uterine bleeding for more information. Gynecologic pathologies menstruating women with abnormal uterine bleeding. Urinalysis renal and urinary tract ultrasound C. Diagnostics in nephrotic syndrome for more information. Hematuria renal pathologies clinical features of nephrotic syndrome. Hemoptysis Laurent staining of sputum sample chest imaging as appropriate pulmonary pathologies, ongoing productive cough. S. Treatment. Treatment of the underlying condition. Examples include, abnormal uterine bleeding, example hormonal therapy, OCPs, tranexamic acid, gynecologic surgery St. GI pathology copyright H. pylori eradication therapy copyright GL bleeding, example polypectomy, treatment of GI malignancy, example colon cancer, NWOC also treatment in PUD, IBD, celiac disease. Scent hookworm infection, antihelminthic scent malnutrition or malabsorption, identification and treatment of underlying causes, example eating disorders, and nutritional supplementation dietary modifications for IDA. Scent encourage the consumption of, copyright irontic foods, especially heme iron, to meet the recommended daily dietary iron intake - HO foods with vitamin C, to enhance oral iron absorption, 25. Scent counsel patients to limit intake of substances that reduce iron absorption. FYH 7 degree select foods, example tea, cereals, dairy products, some soy products, 26, copyright select medications, example calcium, antacids, PPIs. Back collapse fine text outline. Scent counsel patients to limit intake of substances that reduce iron absorption. 117. Copyright select foods, example tea, cereals, dairy products, some soy products. 26. Copyright select medications, example calcium, antacids, PPIs. Copyright C. Prevention of IDA in children for the additional dietary recommendations for infants and children. Iron therapy. Oral iron therapy is effective, inexpensive, and is typically the initial treatment for most patients with IDA. Parenteral iron therapy is beneficial in certain cases. Iron therapy for iron. Oral iron therapy. Asterisk. Individuals with asymptomatic IDA who do not have indications for parenteral indications. P. Iron therapy. Dosage is based on elemental iron equivalents. Common agents include copyright ferrous sulfate, copyright ferrous fumarate. Dosage and administration. Copyright ferrous gluconate 725 enhance absorption of oral iron by giving it. 117. Copyright on an empty stomach simultaneously with vitamin C, example with orange juice. See dietary modifications for IDA. Phe-scent. Gastrointestinal discomfort, nausea, constipation, black discoloration of stool. Adverse effects. Blood transfusion. 30,131. See transfusion for further information. Scent. Consider PRBCS in EO hemodynamically unstable patients with anemia. Copyright severe anemia, HB. Scent. Avoid PRBCS in hemodynamically stable patients with mild or moderate IDA. 4. Ongoing management of IDA, 1L4. Scent. Obtain monitoring studies to assess response to treatment. 11,017. Copyright check CBCO adequate response. After 1 month, hemoglobin should have increased by equals 1 g/dl. Copyright reticulocyte count may also be used for monitoring. 2. 21. Parenteral iron therapy. H7. Intolerance, non-adherence, or contraindications to oral iron therapy. 4. Intestinal malabsorption. Patients who decline indicated blood transfusions. Chronic bleeding refractory to oral therapy. Patients with renal anemia who are on EPO treatment, need for rapid iron correction. For severe anemia in the second or third trimesters, see iron deficiency anemia in pregnancy. 13. Common agents include copyright iron dextrin, copyright iron sucrose, copyright ferrous gluconate. Scent. Thrombophlebitis *, myalgia, arthralgia, and headaches within 1 to 2 days of infusion. Scent. Rare anaphylaxis, typically from iron dextrin. * Patients receiving oral iron therapy, continue treatment for 3 to 6 months to replenish iron stores. I7 Italt. On. Differential diagnoses. See diagnostics in anemia. Enormocytic anemia. Copyright acute blood loss anemia. Copyright occult bleeding. O. Anemia of chronic disease. EO hemolytic anemia. O. Chronic kidney disease. O. Aplastic anemia. Scent. Microcytic anemia. O. Thalassemia equals laboratory studies reveal hemolysis, haptoglobin, T. Indirect bilirubin, T. Reticulocytes. WV. A. Find text. Al. Outline. CDE microcytic anemia. O. Thalassemia equals laboratory studies reveal hemolysis, haptoglobin, 1. Indirect bilirubin, T. Reticulocytes equals confirmed on HB. Electrophoresis equals Mensur index, MCV/RBC ratio. A ratio 13 suggests IDA. O. sideroblastic anemia, serum ferritin levels and transferrin saturation levels are normal or increased. O. Lead poisoning, especially in children, equals erythrocytes show characteristic basophilic stippling on peripheral smear. Equals high levels of lead in blood. E. Anemia of chronic disease, may coexist with IDA. Serum ferritin levels and transferrin saturation levels are usually normal. Iron deficiency anemia. Anemia of chronic disease. Ferritin AP normal to TF. Iron EP normal to transferrin/TIBC. T slightly 1. Transferrin saturation LT normal to slightly 1. RDW1. Normal soluble transferrin receptor, STFR, if normal. References 32. The differential diagnoses listed here are not exhaustive. OY. 8 shared. Complications 41. Scent heart failure, scent increased infections, scent restless leg syndrome in pregnancy, copyright increased maternal and neonatal mortality, copyright preterm labor, copyright low birth weight, scent in children, copyright developmental delay or low educational attainment. We list the most important complications. The selection is not exhaustive. OOFOXO. Prevention. Recommended daily dietary intake of iron 33111. The recommended daily intake of iron is calculated based on age, sex, and, in female individuals, gynecologic history, i.e., menstruation, pregnancy, breastfeeding. Most individuals achieve adequate intake through the consumption of iron-rich foods, e.g., O red meat, O legumes, O dark green leafy vegetables. Copyright iron fortified foods, including fortified formula for infants. Vitamin supplements are indicated in individuals unable to consume the recommended amount of iron-rich foods or who have risk factors for IDA. OOFOs. Special patient groups. Certain patient groups are at increased risk of both developing IDA and complications resulting from it. Back collapse. Find text outline. SNS iron deficiency anemia in children and adolescents. Rapid periods of growth increase the body's demand for iron, putting children and infants at risk of anemia. Children who develop anemia have a higher risk of developmental delay and infections. 4. Risk factors for pediatric IDA 261-251-11. Plus prematurity 138, small for gestational age, i.e., low birth weight, poor dietary intake of iron fortified or iron-rich foods, e.g., exclusively breastfed infants 4 months of age not receiving iron prophylaxis early, i.e., 24 ounces/700 ml per day, intake of non-fortified cow's milk restrictive diets, malnutrition, mainly in resource-limited countries, eating disorders, including pica, picky eating, GL bleeding, example Meckel diverticulum, heavy menstrual bleeding, intellectual disability, low socioeconomic status, including living in areas with a high prevalence of IDA. Copyright IDA is a risk factor for pediatric lead toxicity. 25. Copyright cow's milk has a very low concentration of iron and also disrupts iron absorption. 39. Clinical features. Clinical features of IDA in children are similar to those in adults. Commonly asymptomatic, 40. Plus young children can present with irritability or pica. 40. Children with anemia have an increased risk of infections and developmental delay. For screening, 12. Screen children with risk factors for pediatric IDA at set intervals. 126L 121L 41 plus consider screening all infants at the 12-month well-child visit. 1J. Diagnostics 26IL 12. Plus serum CBC to confirm anemia, according to the WHO definition of anemia. Copyright. Management 251I11I4. Severe anemia. Copyright significant symptoms, example hemodynamic compromise, PRBC transfusion, admission. Copyright all other patients, for iron or oral elemental iron plus mild or moderate anemia, oral elemental iron. 4. Prevention of IDA in children 25111. All children, encourage the recommended daily dietary intake of iron. 2 cent 1L25. Copyright ensure formula or breast milk until 12 months of age. 125LL4 LOE at around 4 to 6 months of age, introduce age-appropriate iron-rich foods, example iron-fortified cereal, pureed meats. At equals 12 months of age, limit low iron milk, example cow's milk. In children with risk factors for pediatric IDA, start iron supplementation, example in 251-26 LL 11° term breastfed infants 4 months of age elemental iron until there is an adequate intake of iron-rich foods, e.g., iron-fortified cereal, 1,251,261 Copyright Premature breastfed infants, elemental iron until 12 months of age 1261L25. At, do not introduce low iron milk, example cow's milk, before 12 months of age. 26. O. Do not routinely start iron prophylaxis in children who receive frequent blood transfusions, because of the risk of iron overload. 26. Iron deficiency anemia in pregnancy. Back collapse. Find text outline. Copyright Premature breastfed infants, elemental iron until 12 months of age, 2#1L25. At, do not introduce low iron milk, example cow's milk, before 12 months of age. 26. Do not routinely start iron prophylaxis in children who receive frequent blood transfusions, because of the risk of iron overload. 26. 7/OE. Iron deficiency anemia in pregnancy epidemiology. Plus 30 to 50% of pregnant individuals worldwide have an iron deficiency. 47129, plus IDAS the most common type of anemia during pregnancy. 2. Etiology sent increased fetal iron requirements for RBC production and fetoplacental growth plus increased RBC mass 148 cent. See also etiology of IDA. Clinical features. Sent clinical features of IDA do not significantly differ in pregnant individuals. Sent for effects on the fetus, see complications below. Screening for IDA in pregnancy, 141 491 111 13 114. Asterisk recommended screening times, 2, SLL 11L 14, O first prenatal visit and again at 24 to 28 weeks gestational age. Copyright consider screening once during each trimester. Diagnostics, 13 IL 4. Sent routine studies. Copyright CBC plus blood smear to confirm anemia, if not already obtained during screening. 2, 4LL 13. Copyright iron studies to confirm the diagnosis of IDA, recommended, example ferritin level. In pregnant individuals with non-severe microcytic or normocytic anemia and nothing to suggest an alternative cause of anemia, IDA can be presumed and empirically treated. The diagnosis is confirmed with an appropriate increase in hemoglobin concentration within 2 to 4 weeks of initiating iron therapy or with confirmatory testing for IDA. SILT/50. Management, 131 I111 I45. Severe anemia. Increased risk of adverse maternal/fetal outcomes, example low birth weight, neonatal anemia, premature labor, sent impaired fetal neurodevelopment prevention, 131-14. Plus encourage patients to consume the recommended daily dietary intake of iron 13,111. 7 * and. Tips and links. Sources. Back collapse. Find text outline. Iron deficiency anemia, 4/4. Esophageal web VV. Endoscopic view of the esophagus. A thin, semilunar membrane, esophageal web, projects into the esophageal lumen. Esophageal webs usually occur in the upper esophagus and do not involve the muscle layer. Along with iron deficiency anemia and dysphagia, cervical esophageal webs are part of the classic triad of findings in Plummer-Vinson syndrome. Source: Endoscopic image of esophageal web by Samir, Wikimedia Foundation, licensed under CC by SA 3.0. Angular cheilitis. Multiple linear cracks of the epidermis, circled, approximate 0.5 centimeters in length, are located at the corner of the mouth. The occurrence of these fissures is called angular cheilitis and has many possible causes, example iron deficiency, mechanical irritation, or infection. Source: Angular cheilitis by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Iron deficiency anemia, 2/4. Koilonychia, spoon nails, VV. Fingers, A, and thumb, B, of the right hand of a 22-year-old female patient presenting with weakness, weight loss, and reduced appetite. The nails are centrally concave and bend upwards distally, resulting in a characteristic spoon shape. The most common cause of koilonychia is iron deficiency anemia, as was the case here. Source: Fig 1, A and B, in Spoon Nails, Still Seen in Today's World by Moise B. Wiley Online Library, licensed under CC by 4.0. Modifications, Part C of image cropped. Iron deficiency anemia, 1/4. Pallor VV. The conjunctiva appears pale, possibly indicating anemia. Source: ID #6900, CDC/Dr. Lyle Conrad, Centers for Disease Control and Prevention, licensed under public domain. And iron deficiency anemia, 1/3. Suspected iron deficiency anemia EHB. Obtain serum ferritin. IT ferritin 500 ng/ml. Comorbid chronic yet inflammatory state no, example CKD, CHF. V. Get iron, transferrin, plus TIBC, TSAT, total iron binding TIBC, cent TSAT, low serum iron capacity, transferrin high serum iron sinuain, TSAT. Any other result. F. Obtain soluble plus STFR transferrin receptor STRL, STFR. Normal STFR. Obtain serum T-free erythrocyte protoporphyrin, FEP, protoporphyrin, FEP, TFEP not elevated but high clinical suspicion. VVV. Iron deficiency decreased/absent. Consider bone normal. Iron deficiency anemia. Iron stores. Marrow biopsy. Iron stores. Anemia unlikely. Evaluation of suspected iron deficiency anemia. Copyright Boss. Ural iron deficiency anemia, 2/3. VV. AEWY, 000. Copyright 96, A. AR. S60. 0. CO 309, 0 ad. S65. 0 do registered OBAPE. 6004, 0, Q Copyright Co. Iron deficiency anemia VV. Photomicrograph of a peripheral blood smear, may Grunwald-Guillem's stain, erythrocytes with different sizes, anisocytosis, and, in some instances, abnormal shapes, poikilocytosis. Examples indicated by green overlays are shown. Many erythrocytes have an increased zone of central pallor. There is a lymphocyte in the center of the image, large purple cell, red overlay, and multiple platelets throughout, smaller purple cells, examples indicated by black arrowheads. These findings are characteristic of iron deficiency anemia. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: Copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, PD Dr. Alberto Perez Buza. Ural iron deficiency anemia, 2/3. WWCAO. NECE, 59 degrees 00 copyright X06 degree copyright 00 copyright OCO of 00 registered 000 ons. JI at OA. 08%. J. 9090 to 0. 09 and Co. 00. 00. Copyright 6. Copyright SE5s. At 0. Degree. Percent 0. 08, E-Day. 0. 99.6. Org OE00QO degree 8006 year 000 S6080 degrees. ESCO copyright A00000 do as, 000 degrees, 0 MN Borzo, 0 CF0. Iron deficiency anemia VV photomicrograph of a peripheral blood smear, may Grunwald-Guillem's stain, erythrocytes with different sizes, anisocytosis, and, in some instances, abnormal shapes, poikilocytosis, examples indicated by green overlays, are shown. Many erythrocytes have an increased zone of central pallor. There is a lymphocyte in the center of the image, large purple cell, red overlay, and multiple platelets throughout, smaller purple cells, examples indicated by black arrowheads. These findings are characteristic of iron deficiency anemia. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: Copyright Smart Zoom, Smart in Media. Image and annotations in Digital Microscopy, PD Dr. Alberto Perez Buza. X Smart Zoom Viewer. D by Smart Zoom. Copyright 2023 Smart in Media. USP %-49G%. S05 86 at 6 copyright equals copyright 1's W equals O N Fe A equals Q O degree we registered O 4 over S00 cent OO underscore AA 0.960 NA 002 BA on X OO 1379 OA OM O O number 9 00 of a 6 oak. Copyright 0p 14% E degree. Copyright X Smart Zoom Viewer. Annulocytes are central pallor, comprises more than a third of the WW strongly hypochromic erythrocytes. A QO0,0 Q00 copyright QO at PEX 00009OXOPA 09.500 596 VO at *RE 289% OESSOS ** OS 29 6% 069 copyright OSOO 2 end copyright 0000.002.0028 equals 42 Q at P0 degree %6 Smart Zoom Viewer A degree 9 at 2 degrees 2695 P9909 SC Bobos P0090 degrees 2000 MO May Jo.2900992 9,900 copyright OMO registered of 9% 0% COOO as 0050,9 02 show O 06 and Q underscore OFP 0 Q0% 0 $4000 $210,2290 boss 0888P000 copyright 0000.96006 to 2 plus 000202 299 SPO00S099 degree % copyright 2C9 090V0 0090 so cosent edits 00042.0 F degree 0000 90 degree G0 degree are registered 2 plus of 090 20% 0000 on O as COCS AE WY asterisk WY asterisk overlay iron deficiency anemia VV photomicrograph of a peripheral blood smear. Most of the red blood cells are small, microcytic, and contain a central zone of pallor, hypochromasia, examples indicated by blue overlay. There are also cells with abnormal morphology, poikilocytosis, examples indicated by arrowheads. In the center of the image, a distinctly basophilic lymphocyte, example indicated by yellow overlay, is visible, which can be used to compare cell sizes. These findings are characteristic of iron deficiency anemia. Source: iron deficiency anemia, peripheral blood smear by Ed Uthman, Flickr, licensed under CC by 2.0. Equals. Overlay. Iron deficiency anemia VV. Photomicrograph of a peripheral blood smear. Most of the red blood cells are small, microcytic, and contain a central zone of pallor, hypochromasia, examples indicated by blue overlay. There are also cells with abnormal morphology, poikilocytosis, examples indicated by arrowheads. In the center of the image, a distinctly basophilic lymphocyte, example indicated by yellow overlay, is visible, which can be used to compare cell sizes. These findings are characteristic of iron deficiency anemia. Source: iron deficiency anemia, peripheral blood smear by Ed Uthman, Flickr, licensed under CC by 2.0. Why anemia? 1/1. Anemia hemoglobin. Measure MCV. Microcytic MCV. Ferritin. LTIBC. Normocytic MCV 80 to 100 FL. Reticulocytes/T reticulocytes. Macrocytic MCV 100 FL. Megaloblastic changes on blood smear? No 4 yet, Y. Abnormal basophilic stippling. 1 CRP/HB electro and/or ring JEPO-8B, signs of hemolysis. ESR pheresis arrow residential pancytopenia haptoglobin plus LDH sent indirect bilirubin. No yet, reticulocytosis YY equals Ti plus liver disease alcohol use, anemia of *B thalassemia. S sideroblastic chronic, plus myelodysplastic folic acid and/or BAEIS chronic *I, seponemia kidney opit blood loss patiebs endian vitamin B2 art disease isonii, pie disease, lead poisoning disease plus multiple myeloma deficiency. Anemia of chronic disease and iron deficiency anemia may also manifest as normocytic anemia. Hemolytic anemias may also manifest as microcytic anemia with normal iron studies. Diagnosis of anemia VV. Copyright Boss. X thalassemia. Thalassemia. Thalassemias are a group of hereditary hemoglobin disorders characterized by mutations on the A or B globin chains, resulting in alpha or beta thalassemia. Thalassemias can be further classified according to the specific genotype. The A chain is coded by 4 alleles, resulting in 4 possible variants depending on the number of alleles affected, while the B chain is coded by 2 alleles, resulting in 2 possible variants. The number of alleles affected is directly related to the severity of the disease, minor/intermediate/major. Thalassemia mutations are generally more frequent in areas where malaria is endemic. Alpha thalassemias occur most commonly in individuals of Asian or African descent, whereas beta thalassemias are predominant in individuals of Mediterranean descent. The key feature in all forms of thalassemia is microcytic hypochromic anemia, which may be very mild in minor forms, but more severe forms may also manifest with hemolysis, splenomegaly, delay in growth and development, and skeletal deformities. The diagnostic workup for suspected thalassemia includes a blood smear, hemoglobin electrophoresis, high performance liquid chromatography, HPLC, and, possibly, genetic testing. Minor forms of thalassemia usually require no treatment, while patients with thalassemia intermediate/major typically require regular blood transfusions and management of disease and treatment-related complications, example chelating agent for transfusion-mediated iron overload. Ma. Ola Taur. OS. OOXE. Overview. Overview of thalassemia type mutated gene clinical features silent carrier SENT1 defective allele, A/A, SENT typically no anemia. Moharthal's semnia *2 defective alleles, A/A or -A, nor mild anemia. SENT jaundice and anemia at birth alpha E** chronic hemolytic anemia, that may require transfusions, H-lobin H SENT 3 defective alleles, */A, secondary hemochromatosis hepatosplenomegaly. Hemoglobin BART SENT 4 defective alleles, intrauterine ascites disease * consists of 4 Y chains, Y tetramers, plus hydrops fetalis. Beta thal. I. Assigning *1 defective allele, B/ * or B/B degree, plus no or mild anemia. Beta thalassemia *2 defective alleles, 8/B or B*/B2, or co-inheritance of other *variable anemia that may require transfusions during periods of stress, example intermedia variance surgery, infection, pregnancy. Severe hemolytic anemia, that requires frequent transfusions, beta secondary hemochromatosis IgA low RI, NE plus hepatosplenomegaly major *2 defective alleles, 8°/8, cent growth retardation skeletal deformities transient aplastic crisis. Combination of 1 defective B globin allele and 1 defective sickle cell. Beta 0 sense features of sickle cell disease thalassemia HBS allele, 8*/HBS or B°/HBS. WA/A. Epidemiology. Cent beta thalassemia, most commonly seen in people of Mediterranean descent, plus alpha thalassemia, most commonly seen in people of Asian and African descent. Cent thalassemia provides partial resistance against malaria. And alpha thalassemia is common in Asia and Africa. Epidemiological data refers to the U.S., unless otherwise specified. OE. Etiology. Back collapse, find text outline. Etiology. General, 11L2. Cent cause, gene mutations. O beta thalassemia, usually due to point mutations in promoter sequences or splicing sites. Equals B globin locus, short arm of chromosome 11. Copyright alpha thalassemia, usually due to deletion of at least one out of the 4 existing alleles. Equals the A globin gene cluster is located on chromosome 16E. Inheritance pattern, autosomal recessive alpha thalassemia. In a normal cell, the A globin chains are coded by a total of 4 alleles. Thus, there are 4 forms of the disease. The severity of alpha thalassemia depends on the number of defective A globin alleles. Cent silent carrier, minima form 1 defective allele, A/A, cent alpha thalassemia trait, minor form, copyright 2 defective alleles, A/A or -A, copyright cis deletion is common amongst Asian populations, whereas trans deletions are more common in African populations. Copyright children of parents with a 2 gene deletion in cis are at higher risk of developing HB-Bart. Hemoglobin H disease, intermedia form 3 defective alleles, --/A, results in excessive production of pathologically altered HbH. Hemoglobin Bart's disease, major form 4 defective alleles, --/-- results in excessive production of pathologically altered HB-Bart, consists of 4 Y chains, Y tetramers. Beta thalassemia/LL41. In a normal cell, the B globin chains are coded by a total of 2 alleles. Thus, there are 2 main forms of the disease. Cent beta thalassemia minor, trait 1 defective allele. Cent beta thalassemia major, Cooley anemia 2 defective allele. Cent sickle cell beta thalassemia, a combination of 1 defective B globin allele and 1 defective HBS allele. Hemoglobin E/beta thalassemia, a combination of 1 allele with a hemoglobin E, HBE, variant and 1 defective B globin allele. Produces a highly heterogeneous clinical spectrum, and in severe cases patients present with features of beta thalassemia major. 5 cent hemoglobin E disease, a condition characterized by homozygosity to the HBE variant. Patients can present with mild features resembling beta thalassemia minor, i.e., mild anemia. OSE. Pathophysiology. Anemia results from a combination of inefficient erythropoiesis and increased hemolysis. The degree to which both mechanisms contribute to the severity of the disease depends on a patient's exact genotype. 6. Cent inefficient erythropoiesis anemia. O beta thalassemia minor and major, faulty B globin chain synthesis. B chains TFY-6 chains THBF and TFHBAZ2. Equals HBF protects infants up to the age of 6 months, after which HbF production declines and symptoms of anemia appear. O-alpha thalassemia intermedia, HbH disease, and alpha thalassemia major, Bart's disease faulty A-globin chain synthesis A chains impaired pairing of A chains with B chains and Y chains 1 free B dash, Y chains THBH, THB Bart's copyright in minor and minima forms, production of the affected chain is reduced, but enough is produced to prevent severe anemia. Increased hemolysis, one of the chains, either A or B, is reduced compensatory overproduction of other chains excess globin chains precipitate and form inclusions within RBCs erythrocyte instability with hemolysis anemia 7 erythropoietin bone marrow hyperplasia and skeletal deformities. A. OROA. Clinical features. Beta thalassemia. Cent minor variant copyright nor mild anemia O low risk of hemolysis or splenomegaly E major variant O severe hemolytic anemia that often requires transfusion secondary iron overload due to hemolysis, transfusion, or both secondary hemochromatosis 17 O hepatosplenomegaly O growth retardation. Back collapse find text outline. Cent major variant O severe hemolytic anemia that often requires transfusion secondary iron overload due to hemolysis, transfusion, or both plus secondary hemochromatosis, A17EC hepatosplenomegaly E growth retardation O skeletal deformities, high forehead, prominent zygomatic bones, and maxilla, copyright transient aplastic crisis, secondary to infection with parvovirus B19, and sickle cell beta thalassemia O features of sickle cell disease O severity depends on the amount of B globin synthesis. Alpha thalassemia. Cent silent carrier, typically no anemia cent alpha thalassemia trait, no or mild anemia cent hemoglobin H disease O jaundice and anemia at birth O chronic hemolytic anemia that may require transfusion secondary iron overload due to hemolysis, transfusion, or both secondary hemochromatosis 7O hepatosplenomegaly copyright skeletal deformities, less common, EO compared to thalassemia beta, symptoms in adults are generally less severe. HB Bart's hydrops fetalis syndrome, most severe variant of alpha thalassemia, O intrauterine ascites and hydrops fetalis O severe hepatosplenomegaly copyright often cardiac and skeletal anomalies copyright incompatible with life, death in utero or shortly after birth. 7v0. E. Diagnostics. Pre-test probability, 91L10L. The presentation of thalassemia is highly variable, ranging from incidental findings to life-threatening forms. Thalassemia is more likely to be diagnosed in patients with the following, suggestive clinical features copyright in infants, usually aged 6 to 24 months consider beta thalassemia major. Copyright in children, usually aged 2 to 6 years consider beta thalassemia minor or alpha/beta thalassemia intermedia. Cent demographic factors O family history of thalassemia copyright Asian, African, or Mediterranean ancestry Cent incidental diagnostic findings copyright microcytic hypochromic anemia not explained by other causes or not responsive to supplemental iron 5. O antenatal ultrasound showing hydrops fetalis copyright detection of abnormal hemoglobin chains in newborn screening A9. Family history plays an important role in diagnosing patients with clinically silent thalassemia. Consider the possibility of minor form/traits if a family member is diagnosed with a more severe form. Initial investigations, 1I101. CBC copyright characteristic finding, microcytic hypochromic anemia, i.e., MCV. Back collapse find text outline. Cent peripheral blood smear findings include, copyright target cells copyright teardrop cells MS anisopoikilocytosis HBH inclusion bodies degree erythroblasts. Degree. CBC parameters can help differentiate thalassemia minor/trait from iron deficiency anemia, IDA, which is frequently associated with a high RDW, low RBC count, and low MCV, typically occurring once HB is low. Ferritin suggests iron deficiency anemia and patients should receive iron supplementation. Suspect thalassemia if there is no significant response after 3 copyright months, 91L10. Confirmatory diagnostic studies /9LL10. Scent detection of hemoglobin variants EHB electrophoresis, qualitative analysis, automated HPLC, qualitative and quantitative analysis, copyright findings, vary depending on the subtype. 4. Hemoglobin A, and subtypes hemoglobin A2 values are helpful to determine the diagnosis, i.e., to distinguish alpha from beta thalassemia. Hemoglobin F, may be elevated in some children and adults with thalassemia. See hemoglobin variants for findings of other hemoglobinopathies. Interpretation of HB electrophoresis results for thalassemia FOROF1213 alpha thalassemia beta thalassemia minor/intermediate/major. Minor, intermediate/HBH disease. MCV/MCH normal/low HbA2 normal/low high HbF normal/high 1 HbH may be present absent. Genetic studies, PCR based to determine specific diagnosis and mutations * bone marrow aspiration, not routinely indicated, usually performed to rule out other hematologic conditions. Copyright findings in thalassemia are nonspecific, example reactive hyperplasia. Beta thalassemia minor should be strongly suspected if HbA2 is 3.5%. 12. Imaging. Imaging is not routinely indicated or required for diagnosis. It can be useful in the evaluation of suspected craniofacial abnormalities and extramedullary hematopoiesis. Scent skull X-ray, AP and lateral, copyright indication, assessment of craniofacial abnormalities. Copyright findings include, high forehead prominent zygomatic bones and maxilla, referred to as chipmunk facies, hair on end, also known as crew cut, sign 1CXR. Copyright indication, suspected extramedullary hematopoiesis in the thorax. Copyright findings include, mediastinal or pulmonary masses subperiosteal extension in the ribs, also known as rib within a rib. 4. MRI spine, helpful to evaluate mass effect symptoms due to extramedullary hematopoietic pseudotumors. 1. OE. Management. Back collapse. Fine text outline. Management. Sent all patients. Copyright patient education and genetic counseling. Copyright screening tests for relatives. Scent thalassemia minor. Usually no treatment required. Copyright episodic folic acid supplementation may be indicated, example during pregnancy, acute infections. Scent thalassemia major and intermediate. Copyright transfusion therapy, erythrocyte concentrates, indication, for transfusion-dependent thalassemias HB. 9 to 10G/DL. Copyright surveillance and treatment of complications iron overload diseases, chelating agents, example deferoxyrox, indicated when iron accumulation reaches toxic levels. Other complications, example gallstones, asplenia, extramedullary hematopoietic pseudotumors. Scent select patients. Splenectomy. 4. JE potentially curative treatment stem cell transplantation, allogenic HSCT gene therapy. References, 1L10. OSAO. Special patient groups. Thalassemia in pregnancy, 761 170 178 19. Scent overview. Copyright. Most patients with thalassemia may suffer from infertility and require assisted reproductive technology to achieve pregnancy. Spontaneous fertility may occur in patients who have successfully undergone iron chelation therapy and blood transfusion. 4. 20 Copyright pregnancies in patients with thalassemia should be planned, as they are considered high risk for both the mother and fetus. Preconception genetic counseling, close antenatal monitoring and screening, and intrapartum and postpartum management are highly recommended. A multidisciplinary team, including a hematologist, cardiologist, endocrinologist, and gynecologist, should be involved in the management of pregnant patients with thalassemia. Fertility assessment and management. E-screening for thalassemia. Copyright hemoglobinopathy screening should be offered to women with unknown hemoglobinopathy status and normocytic or microcytic anemia. O partner screening for thalassemia. Carrier status equals no to carrier for thalassemia. Follow protocols for spontaneous conception, ovulation induction, example gonadotropins, clomiphene citrate, or in vitro fertilization. Equals carrier of alpha thalassemia, offer pre-implantation genetic testing and in vitro fertilization. Equals partner has thalassemia trait, advise patients to use donor gametes or a sperm donor. O if both partners have thalassemia or thalassemia trait, offer genetic counseling prior to conception. After successful conception, the fetus will undergo thalassemia screening using chorionic villus sampling or amniocentesis. Copyright if both partners have thalassemia major, consider alternatives including adoption. SENT preconception screening and review. The most important factors to consider during a fertility assessment are cardiac and liver function, and risk of vertical transmission of viral diseases. Antepartum screening. SENT evaluation. Copyright cardiac function tests each trimester. Copyright gestational diabetes screening at 16 weeks gestation. Copyright fetal growth monitoring, serial fetal biometric ultrasounds starting from 24 weeks gestation. Co-assessment of splenomegaly. Eulrenchylation treatment should be adjusted and closely monitored during pregnancy. Deferoxamine, used in the second and third trimesters. Copyright deferoxyrox and deferiprone, must be discontinued 3 months prior to conception. SENT transfusions should aim to maintain hemoglobin 10G/DL to prevent intrauterine fetal growth restriction. Intrapartum and postpartum management. SENT. Although vaginal delivery is possible, patients usually require cesarean delivery, as those with thalassemia have an increased incidence of cephalopelvic disproportion. Back collapse. Fine text outline. Fertility assessment and management. SENT screening for thalassemia. Copyright hemoglobinopathy screening should be offered to women with unknown hemoglobinopathy status and normocytic or microcytic anemia. Copyright partner screening for thalassemia. Carrier status equals no to carrier for thalassemia. Follow protocols for spontaneous conception, ovulation induction, example gonadotropins, clomiphene citrate, or in vitro fertilization. Equals carrier of alpha thalassemia, offer pre-implantation genetic testing and in vitro fertilization. Equals partner has thalassemia trait, advise patients to use donor gametes or a sperm donor. O if both partners have thalassemia or thalassemia trait, offer genetic counseling prior to conception. After successful conception, the fetus will undergo thalassemia screening using chorionic villus sampling or amniocentesis. O if both partners have thalassemia major, consider alternatives including adoption. SENT preconception screening and review. The most important factors to consider during a fertility assessment are cardiac and liver function, and risk of vertical transmission of viral diseases. Antepartum screening. SENT evaluation. Copyright cardiac function tests each trimester. Copyright gestational diabetes screening at 16 weeks gestation. Copyright fetal growth monitoring, serial fetal biometric ultrasounds starting from 24 weeks gestation. O assessment of splenomegaly. Iron chelation treatment should be adjusted and closely monitored during pregnancy. Deferoxamine, used in the second and third trimesters. Copyright deferoxyrox and deferiprone, must be discontinued 3 months prior to conception. SENT transfusions should aim to maintain hemoglobin 10G/DL to prevent intrauterine fetal growth restriction. Intrapartum and postpartum management. Although vaginal delivery is possible, patients usually require cesarean delivery, as those with thalassemia have an increased incidence of cephalopelvic disproportion. Breastfeeding should not be discouraged. Resume iron chelation therapy, if eligible. Deferoxamine can be resumed immediately postpartum. The use of deferoxyrox and deferiprone should be delayed until the patient has stopped breastfeeding. Continue calcium and vitamin D supplementation. Thromboprophylaxis with LMW heparin. Discuss contraception options, i.e., progesterone-only pill or barrier methods. Complications. Scent maternal copyright cardiac failure copyright alloimmunization copyright thrombosis copyright diabetes mellitus o hypothyroidism o hyperparathyroidism fetal copyright growth restriction o prematurity copyright transmission of hepatitis B, hepatitis C, and/or HIV. FO. OFO. Related 1-minute telegram. Sent 1-minute telegram 17-2021-1/3, a CRISPR-Cas miracle? Report on 2 successful attempts at treatment interested in the newest medical research, distilled down to just 1 minute. Sign up for the 1-minute telegram in tips and links below. OSAO. Tips and links. Sources. Back collapse fine text outline. 0% degree at RRA, OO. $8.09090 at percent WMO, S22 slow GF. At RMUPRIES so OVOO, Q50550082 G0 degree SOK, 99958. TE. Degree, 60F degree. Copyright 00,9 YAG copyright. 5 RO. SE- at 0. 8, plus bear, 0505 at 8 degrees 00, 9 degrees. OSEO 0 pounds 0 degrees a 20 OE. 300 copyright OEOSEE RE, 2. And RE, O%, OE 9957, 899, 09057 degree 8000 degree RO. Cade Boss 5900 M 5000 and 999905 Ono 6 copyright G9 at 920 of 09. And at 2Z0000.9, GU. 970209 SOGO O at 09% ESSVG0S asterisk 0 OE0, O at 8% 10M. OHSOS 0 LE copyright BW088Y60 BOP 02 degree roll, zeros on 0, OW 05% CO 80800 degree 9.86 Q 9% 92-.0 degree WL 0 cents. CSSS overlay Y. Target cells, Codocytes, VV. Photomicrograph of a peripheral blood smear hypochromic erythrocytes with a dark central area, a pale ring surrounding the center, and a dark outer rim can be seen, dashed red circles on overlay. Due to this bullseye appearance on light microscopy, they are called target cells. On electron microscopy, they would appear bell-shaped, overlay illustration, visual axis in light microscopy depicted in red. The finding of target cells is nonspecific and may indicate various hemoglobinopathies, such as thalassemia, liver disease, or asplenia. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urothalassemia, 1/5. EN 5 dons 0 at ES equals A, JUISS degree at IO, NS. Target cells, Codocytes. Photomicrograph of a peripheral blood smear. Copyright. Overlay. Hypochromic erythrocytes with a dark central area, a pale ring surrounding the center, and a dark outer rim can be seen, dashed red circles on overlay. Due to this bullseye appearance on light microscopy, they are called target cells. On electron microscopy, they would appear bell-shaped, overlay illustration, visual axis in light microscopy depicted in red. The finding of target cells is nonspecific and may indicate various hemoglobinopathies, such as thalassemia, liver disease, or asplenia. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urothalassemia, 2/5. Uro-OOE-VV.JVU0VJ, WYE7EOOG-DLOAE0, copyright 10,800,000008% 5 *ECEE copyright ES made 208 degree 6. 900.2% copyright. OOE copyright EAT at degree percent 0E000. 0% degree, asterisk, AE. 0 degree 0G008 degree 0000% A 008, asterisk, 00. G overlay. Dacrocytes VV. Photomicrograph of a peripheral blood smear erythrocytes with a teardrop shape can be seen throughout the image, red overlay. The majority of the erythrocytes appear round and normal. Teardrop-shaped erythrocytes, known as dacrocytes, are found in conditions that involve extramedullary hematopoiesis, example myelofibrosis, thalassemia, splenomegaly. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Ghana Y00% GS. AG. 0.8 E registered, 90 L000. 6 degrees 6.0. Copyright I, EEEE 00,06. WTEE 170%. O. YG0OA fab degree equals E at 0 degree equals 00 phi percent 7 go 09 degree YO. Pow. 9 degrees O degree at 9. Copyright degree 0% 0 copyright 09 SE so 0 degree 30. Yes. O degree CE.29 at 0 G 82 times 10 to the power of 5070 first 46, DAD. C06. O Odco E712, 3809. 97. QQ&AO by 2. 0,90. OOCO%. 00 GYO or 184.00% QoS. GA0. R plus. Degree. 7. ULHE. At 00 EMFOO. 9. EAOE 9 degree 80. OS. 0 degrees 050 E9I. 1s. 8Q00504 degrees 08 EE County ISI. 202% 9. 90 L092 degree SYFS of O phase 60,999. AELEEIVA, WWO equals New York 9 degrees, equals ISS and 00E. Overlay. Teardrop-shaped erythrocytes, known as dacrocytes, are found in conditions that involve extramedullary hematopoiesis, example erythrocytes with a teardrop shape can be seen throughout the image, red overlay. The majority of the erythrocytes appear myelofibrosis, thalassemia, splenomegaly. Round and normal. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Photomicrograph of a peripheral blood smear dacrocytes. Thalassemia, 3/5. Overlay. Hair on end appearance of the skull VV. X-ray skull, lateral view, of a child with beta thalassemia expansion of the diploic space with thickening of the trabeculae, example indicated by green overlay, is the result of extramedullary hematopoiesis. The hair on end appearance, examples indicated by red lines, produced can also be seen in other chronic hemolytic anemias. Source, WBRO 150 by W.J. Gibson, Wikidoc, licensed under CC by SA 3.0. Thalassemia, 3/5. Copyright overlay. Hair on end appearance of the skull VV X-ray skull, lateral view, of a child with beta thalassemia expansion of the diploic space with thickening of the trabeculae, example indicated by green overlay, is the result of extramedullary hematopoiesis. The hair on end appearance, examples indicated by red lines, produced can also be seen in other chronic hemolytic anemias. Source, WBRO 150 by W.J. Gibson, Wikidoc, licensed under CC by SA 3.0. Thalassemia, 4/5. Overlay. Rib within a rib sign in thalassemia VV. X-ray chest, PA view, of a patient with beta thalassemia. Major skeletal structures show decreased density and a coarsened heterogeneous appearance. The ribs are expanded and additional lines of increased density parallel the outer edges of the middle and anterior aspects of several ribs are visible, examples of double lines indicated by green lines. The appearance is the result of subperiosteal marrow proliferation and has been termed the rib within a rib sign. Source: Fig 1c, in spinal cord compression by extramedullary hematopoiesis in beta thalassemia major by Amr LB, Ferjani H., Maudala Ketal, Wiley Online Library, licensed under CC by 4.0. Modifications, letter removed. Urothalassemia, 4/5. Copyright. Overlay. Rib within a rib sign in thalassemia VV. X-ray chest, PA view, of a patient with beta thalassemia. Major skeletal structures show decreased density and a coarsened heterogeneous appearance. The ribs are expanded and additional lines of increased density parallel the outer edges of the middle and anterior aspects of several ribs are visible, examples of double lines indicated by green lines. The appearance is the result of subperiosteal marrow proliferation and has been termed the rib within a rib sign. Source: Fig 1c, in spinal cord compression by extramedullary hematopoiesis in beta thalassemia major by Amr LB, Ferjani H., Maudala Ketal, Wiley Online Library, licensed under CC by 4.0. Hemolytic anemia. Membrane, or intracellular enzymes, which is called intrinsic hemolytic anemia, or by external causes, immune-mediated or mechanical damage, which is called extrinsic hemolytic anemia. Hemolysis can be further categorized depending on whether it occurs inside the blood vessels, intravascular hemolysis, in the reticuloendothelial system, extravascular hemolysis, or both. Hemolytic anemias cause varying degrees of fatigue, pallor, and weakness, ranging from asymptomatic disease to life-threatening hemolytic crisis, although some hemolytic anemias have more specific findings, example thrombosis in paroxysmal nocturnal hemoglobinuria. Hemolytic anemia should be suspected in patients with anemia and laboratory findings of hemolysis, example elevated indirect bilirubin and lactate dehydrogenase, reticulocytosis, and decreased haptoglobin levels. The Coombs test helps to distinguish between antibody-mediated, positive direct Coombs test, and non-antibody mediated, negative direct Coombs test, anemias. Further tests should be performed to investigate the underlying etiology. Treatment involves RBC transfusions as required. Additional treatment is based on the type of hemolytic anemia and its cause. See also sickle cell disease, paroxysmal nocturnal hemoglobinuria, and autoimmune hemolytic anemia. VA. OLO. Overview. Types and etiologies of hemolytic anemia. Hemolytic anemias are characterized by an excessive breakdown of red blood cells, RBCs. They can be classified according to the cause of hemolysis, intrinsic or extrinsic, and by the location of hemolysis, intravascular or extravascular. Type definition: causes by RBC pathology. RBC membrane defects, example hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, PNH, enzyme defects, example glucose 6-phosphate dehydrogenase deficiency, G6PD deficiency, intrinsic hemolytic, A = seeing increased destruction of RBCs due to a defect within the RBC. Pyruvate kinase deficiency, PKD, hemoglobinopathies, sickle cell disease, thalassemia, hemoglobin C disease, hemoglobin Zurich. Mechanical destruction in large vessels, example prosthetic heart valves. Mechanical destruction in small vessels, I.E. MAHA example HUS, TTP, DIC, HELLP syndrome autoimmune reactions, autoimmune hemolytic anemia, AIHA, alloimmune reactions, example ABO/RH incompatibility extrinsic hemolytic anemia * abnormal breakdown of normal RBCs. Immune reactions due to infections, example mycoplasma or tumors, example chronic lymphocytic leukemia, infections causing increased destruction of RBCs, example Babesia, malaria, Bartonella bacilliformis, increased degradation by the spleen, hypersplenism. By location of RBC breakdown. Toxins, example snake bites, and oxidizing agents, example copper poisoning, 11F2G6PD deficiency antibody-mediated hemolysis, transfusion ABO incompatibility, hemolytic anemia of the newborn, cold agglutinin disease, complement-mediated hemolysis, PNH macroangiopathic anemia, mechanical destruction by, example prosthetic cardiac valves. Intravascular hemolytic * increased destruction of RBCs within the blood vessels anemia. Microangiopathic anemia, example TTR, HUS, disseminated intravascular coagulation, HELLP syndrome, systemic lupus erythematosus. Extravascular hemolytic * increased destruction of RBCs by the reticuloendothelial system RBC defects, example sickle cell disease, spherocytosis, pyruvate kinase deficiency, anemia, primarily the spleen, antibody-mediated hemolysis, warm and cold agglutinin disease. 7. CE. Clinical features. Sense signs of anemia copyright pallor o fatigue o exertional dyspnea o in severe cases, tachycardia, angina pectoris, leg ulcers sense signs of hemolysis o jaundice pigmented gallstones o splenomegaly o back pain and dark urine in severe hemolysis with hemoglobinuria, sense signs of increased hematopoiesis, mostly in severe chronic anemias, example thalassemia, bone marrow expansion, widening of the diploic space of the skull, biconcave deformity of the vertebral bodies. Back collapse fine text outline. Sense signs of increased hematopoiesis, mostly in severe chronic anemias, example thalassemia, bone marrow expansion, widening of the diploic space of the skull, biconcave deformity of the vertebral bodies copyright cortical thinning and softening of bone 7 risk of pathologic fractures o extramedullary hematopoiesis, hepatosplenomegaly. References, LL4. OI Shat. Diagnostics. Consider hemolysis in patients with acute or chronic anemia in whom an obvious cause, example bleeding, is not apparent. See Diagnosis of anemia for details on the general approach for a patient with anemia. 5. Approach, SIL 6. 1. Perform initial laboratory studies to confirm anemia and hemolysis and classify anemia by morphology. Copyright anemia workup, CBC with MCV, reticulocyte count copyright hemolysis workup, add LDH, haptoglobin, bilirubin, urinalysis, and peripheral blood smear, PBS. 2. Obtain a direct Coombs test, i.e., DAD, to narrow the differential, copyright DAD positive, antibody-mediated hemolytic anemia copyright DAD negative, non-antibody-mediated hemolytic anemia. 3. Consider further investigations of the underlying etiology based on clinical suspicion and DAD results. Add, rule out hemolysis in any patient with unexplained anemia, even if the urine dipstick test is negative for blood and jaundice is not evident on physical examination. Copyright if the patient has severe symptoms of anemia or a life-threatening cause is suspected, i.e., TTP/HUS, disseminated intravascular coagulation, HELLP syndrome, acute hemolytic transfusion reaction, proceed directly to treatment in parallel with diagnostic evaluation. In routine laboratory studies/LLE. CBC OHBHCT and RBC count 1/6 MCV equals normocytosis, typical finding for most hemolytic anemias. Consider other anemia of chronic D equals 1 MCV, can be due to severe reticulocytosis, 1. Consider other causes of macrocytosis, example megaloblastic anemia, equals microcytosis. Consider thalassemia and/or iron deficiency. OWBC count can be elevated due to inflammation or malignancy. Copyright platelets decreased in MAHA_, and in Evans syndrome. 1 cent reticulocyte count. Use the corrected reticulocyte count for patients with anemia. O reticulocytosis, most common dash. Copyright. See also basics of hematology and hematological parameters. Copyright. Iron studies are usually normal in hemolytic anemia, however, iron deficiency can be seen in chronic intravascular hemolysis. 9. Lee hemolysis workup. Feedback. While no single test can be used to confirm hemolysis, the finding of anemia in the presence of accelerated erythropoiesis, i.e., reticulocytosis, in addition to evidence of RBC destruction in serum and/or urine studies, is highly suggestive of hemolytic anemia. Typical biochemical findings in hemolysis include haptoglobin, T LDH concentration, T indirect bilirubin concentration, peripheral blood smear abnormalities, example T reticulocytes, schistocytes, spherocytes, polychromasia, and urinalysis abnormalities, example hemoglobinuria, hemosideриnuria, and urobilinogen. Back collapse. Find text. Serum studies. Evid of hemolysis in serum study SLEL. Parameter description. Features of intravascular hemolysis. Phe of LAR H lysi. Brl D from the breakdown of RBCs binds to haptoglobin 10,111. Haptoglobin decrease in free circulating SZB haptoglobin. Nonspecific parameter, indicates increased cellular UAE breakdown. OE dehydrogenase _ more prominent in intravascular hemolysis. Ne hemolysis HB release heme catabolized to, unconjugated, indirect bilirubin, C bilirubin metabolism, can be normal or slightly elevated. FT bilirubin more prominent in extravascular hemolysis. Fa. T reticulocytes spherocytes in hereditary spherocytosis and immune-mediated hemolysis, example warm AIHA, hemolytic transfusion +1 reticulocytes reactions, BSC2. Heinz bodies and bite cells in G6PD axiated BINLE used to detect abnormal RBC forms, intracellular celi rent RBC agglutination in cold agglutinin disease, CAD, as microorganisms, and Sac inclusion bodies a deficiency IOEIEMIN D5. DY * sickle cells in sickle cell disease NEPBS * schistocytes in MAHA or _ equals LLC RBC morphology. For more information on PBS and findings. Target cells in sickle cell D macroangiopathic hemolysis I sent intracellular organisms, example in malaria hemoglobin C disease A. IS, babesiosis, Bartonellosis I, sarcrop cells in thalassemia IA, HB crystals within RBCs in hemoglobin C disease smudge cells, Gumprecht shadows, in chronic lymphocytic leukemia, CLL, LAC. Haptoglobin levels can be low in both intravascular hemolysis and extravascular hemolysis and, therefore, should not be used to differentiate between the two. 9. Urine studies. Of HISIS in urine study SLL6, findings parameter description Y hemolysis 131. Scent urine dipstick is positive for heme, but no RBCs are seen on microscopy. Hemoglobinuria * degree early and transient marker of severe intravascular hemolysis 1. ASEH * usually absent 14 * brown colored urine A * mostly occurs in intravascular hemolysis. Scent filtered HB is reabsorbed by the proximal convoluted tubule plus hemic iron is removed and stored as hemosiderin. Hemosiderin containing proximal tubule cells are sloughed off into the urine. USAAN IPABSART * usually absent Hempslota inuria * late marker of severe intravascular hemolysis. GG4 scent present EVA, scent lens urine a brown color * typically seen in marked intravascular hemolysis. equals FT indirect bilirubin TT bilirubin breakdown in the gut T urobilinogen reabsorption into the enterohepatic circulation urobilinogen 15 excess urobilinogen enters the systemic circulation urobilinogen is excreted in the urine OA usually absent present asterisk mostly occurs in extravascular hemolysis AE. Your notes. Row shared notes manage. Coombs testing, antiglobulin testing. Scent description. A special reagent is added to patients' blood samples, Coombs serum, which contains anti-human globulins, AHGs, that detect and adhere, with two binding sites, to immune proteins that mediate hemolysis, i.e., antibodies, IgG, and/or complement A. If these proteins are coating the RBC surface when the serum is added, AHGs will cause multiple RBCs to adhere to each other in a process called agglutination. If no such proteins are present, AHGs will not bind to anything. RBC agglutination is considered a positive result, while the absence of RBC agglutination is considered a negative result. Back collapse fine text outline. Direct Coombs test, DAT. Scent. This is a key test in the workup of hemolytic anemia. Scent goal copyright detection of antibodies and/or complement proteins on the surface of RBCs copyright narrowing the differential of hemolysis E indications, all patients with hemolysis method. Copyright the patient's blood sample is purified so that only RBCs remain. Copyright Coombs serum is added and AHGs bind to the patient's antibodies and/or complement already present on the surface of their RBCs, leading to RBC agglutination. Scent positive result O indicates that the patient's RBCs are coated with autoantibodies and/or complement that are causing hemolysis. 17 copyright etiologies include, autoimmune hemolytic anemia, warm AIHA or cold AIHA, alloimmune hemolytic anemia transfusion reaction hemolytic disease of the newborn drug-induced autoimmune hemolytic anemia, example due to methyldopa, penicillin, cephalosporin, NSAIDs, immunotherapy, chemotherapy, scent negative result, suggests non-antibody mediated hemolysis. Indirect Coombs test, 18. Scent goal is the detection of anti-RBC antibodies in the serum of, for example, copyright transfusion recipients copyright patients with hemolytic disease of the fetus and newborn, HDFN, pregnant women at risk of developing antibodies that cause HDFNE indications any patient requiring pre-transfusion testing, example blood typing copyright patients with suspected transfusion reactions newborns with signs of hemolysis copyright screening for Rh-negative mothers to determine if anti-D immunoglobulin is indicated method the patient's blood sample is purified so that only the serum remains. The patient's serum is incubated with test RBCs. If there are anti-RBC antibodies in the patient's serum, they will bind to the test RBCs. Coombs serum is added and AHGs bind to the patient's antibodies, which are bound to the test RBCs, leading to RBC agglutination. Scent positive result. Copyright indicates the presence of freely circulating anti-RBC antibodies present in the patient's serum that may be responsible for HDFN or transfusion reactions. Copyright etiologies include, RBC alloimmunization in transfusion recipients or newborns maternal alloimmunization negative result, no detectable anti-RBC antibodies differences between the Coombs tests. Key differences between direct and indirect Coombs testing direct Coombs test 61 indirect Coombs test, 18 transfusion medicine, workup and prevention of transfusion reactions, clinical application workup of hemolytic anemia PE. RIME plus perinatal care, workup and prevention of HDFN. Location of antibodies detected RBC surface serum. Coombs serum added to, the patient's purified RBCs the patient's purified serum which has been mixed with test RBCs. AHGs in Coombs serum bind to, antibodies and/or complement already coating the patient's RBCs the patient's antibodies which are bound to test RBCs. At the direct Coombs test detects antibodies that are directly attached to the RBC surface. The indirect, or not direct, Coombs test detects serum antibodies that are not bound to RBCs. WA. OFOs. LL. Investigation of underlying causes. Perform further diagnostic workup according to the suspected etiology, specialist consultation is advised. I-719 cent HB electrophoresis, abnormal HB patterns, example in thalassemia cent flow cytometry O absence of CD55 and CD59 on RBC surface in PNH. Back collapse fine text outline. Perform further diagnostic workup according to the suspected etiology, specialist consultation is advised. 1719 cent HB electrophoresis, abnormal HB patterns, example in thalassemia E-flow cytometry O absence of CD55 and CD59 on RBC surface in PNH copyright detection of CD19, CD20, and CD23, light chain restriction, kappa or lambda, in CLL cent genetic analysis, mutations in congenital hemolytic anemia cent bone marrow biopsy copyright rarely used in the workup of anemia due to its invasiveness copyright indication, pancytopenia, presence of abnormal cells, example blasts, in CBC/peripheral blood smear copyright pathologic. Findings are most common in malignancies that replace bone marrow, example CLL. 7 * registered shared. Intrinsic hemolytic anemias. Hemolytic anemia that is caused by structural or functional RBC abnormalities can be further classified as one of the following based on pathogenesis: cent RBC membrane defects O paroxysmal nocturnal hemoglobinuria E hereditary spherocytosis O hereditary elliptocytosis E enzyme defects O pyruvate kinase deficiency O glucose 6-phosphate dehydrogenase deficiency copyright hexokinase deficiency O adenylate kinase deficiency E cent hemoglobinopathies E hemoglobin C disease E O hemoglobin Zurich copyright sickle cell disease O thalassemia. See respective articles for more detailed information. GFVOOA. Li pyruvate kinase deficiency. Cent etiology, autosomal recessive defect of pyruvate kinase E pathophysiology copyright glucose is the only energy source in RBCs copyright pyruvate kinase catalyzes the last step of glycolysis, i.e., irreversibly converts phosphenol pyruvate into pyruvate. O absence of pyruvate kinase ADP deficiency in RBC O ADP deficiency disrupts the cation gradient along the RBC membrane rigid RBCs T hemolysis, extravascular, E accumulation of 2,3-bisphosphoglycerate T release of O02 from HB masks. Symptoms of anemia cent clinical symptoms copyright seldom asymptomatic 1 copyright typically newborn jaundice due to hemolysis and history of exchange transfusions copyright splenomegaly copyright pallor, fatigue, weakness O in rare cases, hydrops fetalis E diagnosis O J pyruvate kinase enzyme activity O PKLR gene mutation O blood smear, Vercells E therapy copyright phototherapy and / or exchange transfusions copyright in the case of severe anemia or excessively enlarged spleen, splenectomy references 221 I-23 I-24. ZY. GE. Li hemoglobin C disease. V. Back collapse. A. Fine text. O. Outline. Li hemoglobin C disease. Definitions. Cent hemoglobin C disease occurs in individuals who are homozygous for the hemoglobin C mutation, HBCC. Cent hemoglobin C trait occurs in individuals who are heterozygous carriers of the hemoglobin C mutation, HBAC. Pathophysiology 25. Glutamic acid can also be replaced with a lysine, creating hemoglobin C. Cent HBC precipitates as crystals TRBC rigidity and deformability extravascular hemolysis cent B globin mutation, glutamate replaced by lysine, HBC is less soluble than HBA and tends to form hexagonal crystals, which lead to RBC dehydration, TMCHC. RBCs have reduced oxygen binding capacity and a shorter lifespan. And in hemoglobin C disease, lysine replaces the amino acid glutamic acid. Clinical features 25. Hemolytic anemia, usually mild, scent cholelithiasis e jaundice splenomegaly patients with HBsC gene mutation, 1 HBC and 1 HBS trait, have milder symptoms than HBsS patients. Diagnostics. CHIC findings INH in C-DD with hemoglobin C trait 26 hemoglobin C disease, HBCC, hemoglobin C trait, HbAc, MCVY, TTMCHC equals degree 1 MCV, TTMCHC CBC scent mild anemia, T reticulocyte CL usually no anemia or reticulocytosis. ETII. Anisopoikilocytosis target cells and microspherocytes * usually normal rod-shaped RBCs containing precipitated hemoglobin C crystals PPS 27. Hemolysis workup evidence of hemolysis in serum studies. 1 * no evidence of hemolysis in serum studies. HB electrophoresis. Hemoglobin C, 95% scent hemoglobin C, 50%. Treatment 28. Scent most patients do not require treatment. Consider folic acid supplements in hemoglobin C disease. Consider cholecystectomy in patients with symptomatic gallstones. Splenectomy is rarely indicated. WAOE. LL, hemoglobin Zurich. Pathophysiology copyright replacement of distal histidine in the beta-globin chain with arginine enlargement of the ligand binding space around iron increased affinity for carbon monoxide increased carboxyhemoglobin levels, 3%. Copyright oxidative stress - formation of Heinz body and hemolysis scent clinical features copyright often asymptomatic copyright hemolysis upon exposure to certain drugs. Example sulfonamides, stress and infection scent diagnostics copyright laboratory findings, normocytic anemia, reticulocytosis copyright genetic testing scent treatment copyright avoid triggering agents. Severe hemolytic anemia, blood transfusion, plasmapheresis. References, 29. Back collapse find text outline. Extrinsic hemolytic anemia. Hemolytic anemia that is caused by the destruction of functionally and structurally normal RBCs can be further classified as one of the following based on the mechanism of RBC destruction. Scent antibody-mediated destruction of RBCs copyright alloimmune hemolytic anemia equals hemolytic transfusion reaction equals hemolytic disease of the fetus and newborn autoimmune hemolytic anemia equals cold agglutinin hemolytic anemia equals warm agglutinin hemolytic anemia scent mechanical destruction of RBCs MAHA copyright macroangiopathic hemolytic anemia scent other copyright toxin-mediated RBC destruction, example from a snake bite, oxidizing agents, example dapsone, nitrofurantoin, phenazopyridine, primaquine, 1I, ERBC destruction by intracellular pathogens, example in malaria, babesiosis, bartonellosis, rickettsiosis ERBC destruction due to hypersplenism see respective articles for more detailed information. WA. CE. Lee mechanical destruction of RBCs. Microangiopathic hemolytic anemia, MAHA, 2LL5. Background. Etiology 31 copyright primary MAHA, I equals thrombotic thrombocytopenic purpura, TTP, equals hemolytic uremic syndrome, HUS, copyright secondary MAHA copyright, causes include, equals autoimmune disease, example SLE, equals HELLP syndrome equals hypertensive emergency equals disseminated intravascular coagulation, DIC, equals drug-induced hemolytic anemia, example quinine, trimethoprim/sulfamethoxazole, cyclosporin, scent pathophysiology copyright systemic microthrombi plug small vessels physical intravascular shearing of RBCs that pass through the small vessels intravascular hemolysis, schistocytes, and T-free HB copyright characteristically accompanied by thrombocytopenia. Clinical features. Scent features of anemia, example pallor, fatigue, Sent jaundice organ dysfunction due to microthrombi formation, example renal dysfunction, altered mental status, petechiae due to thrombocytopenia. Diagnostics in suspected MAHA. Sent consider MAHA in patients with the following: ECBC showing anemia and thrombocytopenia, O laboratory evidence of hemolysis with a negative DAT, copyright PBS showing abundant schistocytes, typically equals 2 per high power field, determine if end organ damage and/or a secondary cause of MAHA are present. Management 311 I34. If an evident secondary cause is identified, example HELLP syndrome, hypertensive emergency, DIC, treat accordingly. Sent if suspicion for TTP is high, O refer for urgent plasma exchange. Copyright consider corticosteroid therapy, example prednisone. Registered MAHA is a medical emergency. Back collapse, find text outline. Background. *etiology 31, copyright primary MAHA, 1 equals thrombotic thrombocytopenic purpura, TTP, equals hemolytic uremic syndrome, HUS, copyright secondary MAHA, causes include, equals autoimmune disease, example SLE, HELLP syndrome equals hypertensive emergency disseminated intravascular coagulation, DIC, drug-induced hemolytic anemia, example quinine, trimethoprim/sulfamethoxazole, cyclosporin. Sent pathophysiology, copyright systemic microthrombi plug small vessels, physical intravascular shearing of RBCs that pass through the small vessels, intravascular hemolysis, schistocytes, and 1 free HBE characteristically accompanied by thrombocytopenia. Clinical features. Sent features of anemia, example pallor, fatigue. Sent jaundice, sent organ dysfunction due to microthrombi formation, example renal dysfunction, altered mental status, petechiae due to thrombocytopenia. Diagnostics in suspected MAHA. Sent consider MAHA in patients with the following: ECBC showing anemia and thrombocytopenia, O laboratory evidence of hemolysis with a negative DAT, O PBS showing abundant schistocytes, typically equals 2 per high power field. Sent determine if end organ damage and/or a secondary cause of MAHA are present. Management 311 I34. If an evident secondary cause is identified, example HELLP syndrome, hypertensive emergency, DIC, treat accordingly. If suspicion for TTP is high, copyright refer for urgent plasma exchange. Copyright consider corticosteroid therapy, example prednisone. 6. MAHA is a medical emergency. Macroangiopathic hemolytic anemia. Etiology, copyright congenital cardiovascular anomalies, example bicuspid aortic valve, coarctation of the aorta, 37O moderate and severe aortic stenosis, heart valve replacement usually resolves the anemia. In other patient groups, prosthetic heart valves can cause anemia. Copyright extracorporeal circulation, dialysis O exertional hemoglobinuria, March hemoglobinuria RBC destruction in the feet during strenuous exercise, example running on hard surfaces. Pathophysiology, RBC destruction in the systemic circulation, large vessels, due to mechanical forces applied to RBC membrane, intravascular hemolysis, schistocytes, T-free HB. Sent clinical features, copyright features of anemia, example pallor, fatigue, jaundice. Sent diagnostics, copyright evidence of hemolysis, example T. Indirect bilirubin, TLDH, haptoglobin, reticulocytosis, CBS. Copyright DAT, negative. Copyright blood smear, schistocytes. 138. Copyright consider echocardiography. 589. Sent treatment, copyright address the underlying cause. 139th. WA. And sources. Last updated February 21, 2024. V. Back collapse, find text outline. Jaundice, scleral and dermal icterus, VV. Source, Jaundice by SAB3L3ish, Wikimedia Commons, licensed under CC by 3.0. Modifications, Image cropped. Hemolytic anemia, 1/1. Signs of anemia and hemolysis. Asterisk haptogen degree TLOH copyright indirect/unconjugated bilirubin +1 reticulocytes abnormal peripheral smear. Signs of acute hemolysis or evaluate NS Pani-Umakin. Treat urgently TTP/HUS/PAR-EE plus hemodynamic instability. Asterisk DIG plus acute renal failure. HELLPHB. Direct CUM/VE antiglobulin test, DAT. Immune-mediated non-immune-mediated hemolysis. Consider if nubum, HX of pregnancy, transfusion, or transplantation. Autoimmune hemolytic alloimmune hemolytic extrinsic-intrinsic anemias, AIHAs, anemias, AHAs, RBC defects 1 RBC consider one of the positive DAT recent, N, SI Baptor CAD, EE Ranstagen-Cs Caerpins O and Emmet 2 Borani Papahenian. Consider one of the hemolytic transfusion Re plus RBC transfusion, folate I gloater consider one of the hemolytic disease ins positive, following causes, reactions Perpignan, 2, membrane detects genetic testing, smear, etocytes. Senercan plus acylizumab, iron, folate warm AIHA, E, cold AIHA, /Kudiaine_Pope, blood FIM, blood film, infection, E*, on flow cytometry CH, allo-SCT, smear, RBCs with inclusions. Idiopathic plus malaria, trophozoite ring, I quantitative G6PD deficiency, E*, and I*, plus stop/avoid offending learned created GEPD enzyme, smear, bite cells, Hoynes bodies, agent. 7 Enzyme deficiencies. Disorders pyruvate kinase deficiency, E, *QEE, e.g., CLL, Hodgkin disease, OG, CLL, WM, toxic enzyme activity, smear. Autoimmune disorders infection, lead, basophilic stippling, renal failure, DIG equals. E.g., SLE, e.g., EBV, mycoplasma, UAAAE Fencelatbo-Wise disease HBSS on HO__, sickle cell anemia, E*, and 1, refer to artsy on attention electrophoresis, smear, sickle colds, sickle cell anemia. Drug-induced AIHA delayed hemolytic mechanical, I, hemoglobinopathies HB-con HB, hemoglobin C disease, E, folate supplementation transfusion reaction, I, transfusion reaction, ARI-SPAT-COM. Tadcine evox A equals, cent.g, penicillin, equals E thalassemia, E*, S type 2, immune complex transfusion suggestive of plus splenectomy mediated, 09 urine, posulcdial thalassemia, smear, target colds, plus allo-SCT. Type 3, generation of anti-supportive, 4 fluids, RBCAB, E.9, methiidopa, vasopressors hemolysis plus. Cent IOX IES thrombocytopenia. +1 registered UIN, prednisone mild, warm patient, plus hemodialysis if 2%. Gyn, splenectomy avoid cold hyperkalemia and ECG, children, rituximab plus moderate/severe, changes Carorasi and penny. Plus treat underlying cause rituximab plus repeat type and plus treat underlying cause cross-match *, valvular hemolysis, aortic. Stenosis, mechanical valves. Findings for, intravascular hemolysis, I, extravascular hemolysis, E, I. TIT peripheral smear schistocytes spherocytes atoms 13 bloody diarrhea plus stool 1D dimer/FDP 1PT and pregnancy, scent liver enzymes plus activity. Haptogen decrease/absent mild decrease. Trehus, Dick HELLP others urine hemoglobin plus negative M. Reticulocytes increase systemic * plasma exchange * supportive A plus platelets. Unconjugated bilirubin increase plus rituximab, severe * antimotility agents * PRP prefiatipnonide AEEETMAIOD * plasma exchange plus cryoprecipitate, fibrinogen PPT, and, at etractory. Hemolytic anemia flowchart VV. Copyright Boss. Urohemolytic anemia, 4/14. AAEI Wisplinghoff Laboratories. Overlay. Schistocytes VV. Photomicrograph of peripheral blood smear numerous healthy erythrocytes, E, and several fragmented erythrocytes, black dashed circles, with a normal convex side, colored blue, and a fragmented side that is concave or straight, colored red, can be seen. Schistocytes are a diagnostic finding in microangiopathic hemolytic anemias. These cellular fragments can also result from mechanical damage to erythrocytes, example due to prosthetic heart valves. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urohemolytic anemia, 4/14. 7 or E. Same. AEJ Wisplinghoff Laboratories. Overlay. Schistocytes VV photomicrograph of peripheral blood smear numerous healthy erythrocytes, E, and several fragmented erythrocytes, black dashed circles, with a normal convex side, colored blue, and a fragmented side that is concave or straight, colored red, can be seen. Schistocytes are a diagnostic finding in microangiopathic hemolytic anemias. These cellular fragments can also result from mechanical damage to erythrocytes, example due to prosthetic heart valves. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Overlay. Heinz bodies. Photomicrograph of a peripheral blood smear, May Grunwald-Guillemets stain, multiple erythrocytes are visible, some of which contain small round inclusions, example indicated by yellow overlay. These inclusions consist of denatured hemoglobin and are called Heinz bodies. They are classically associated with G6PD deficiency, but can also be seen in other conditions. Source, Fig 1, in Usefulness of NGS for Diagnosis of Dominant Beta Thalassemia and Unstable Hemoglobinopathies in 5 Clinical Cases by Ritsuto V. Koopman T.T., Blanco Alvarez AETAL, Frontiers in Physiology, licensed under CC by 4.0. Modifications, removal of 4 arrows and the letters A, B, C, D. Overlay. Copyright. Heinz bodies. Photomicrograph of a peripheral blood smear, May Grunwald-Guillemets stain, multiple erythrocytes are visible, some of which contain small round inclusions, example indicated by yellow overlay. These inclusions consist of denatured hemoglobin and are called Heinz bodies. They are classically associated with G6PD deficiency, but can also be seen in other conditions. Source, Fig 1, in Usefulness of NGS for Diagnosis of Dominant Beta Thalassemia and Unstable Hemoglobinopathies in 5 Clinical Cases by Ritsuto V. Koopman T.T., Blanco Alvarez AETAL, Frontiers in Physiology, licensed under CC by 4.0. Modifications, removal of 4 arrows and the letters A, B, C, D. AF oft ROOA asterisk. Asterisk S asterisk. Asterisk hashtag 4 colonnes, 4 and. Re. G. Overlay. Heinz bodies VV. Photomicrograph of a peripheral blood smear numerous erythrocytes are visible. They contain dense aggregates of denatured hemoglobin, Heinz bodies, examples indicated by green overlay, which appear as dark spots. Heinz bodies are found in a number of hematological disorders, most commonly in glucose 6-phosphate dehydrogenase deficiency. Source: Figure 1, B. Peripheral blood smear depicting abundant Heinz bodies in our patient with hemoglobin H disease by Panagiotis Andreatis, Stomatia Theodorodou, Merrily Pasakiatu et al., Case Reports in Hematology Journal, licensed under CC by 3.0. A equals LES. S2 equals Zion copyright, asterisk EA7A equals. Overlay. Heinz bodies VV. Photomicrograph of a peripheral blood smear. Numerous erythrocytes are visible. They contain dense aggregates of denatured hemoglobin, Heinz bodies, examples indicated by green overlay, which appear as dark spots. Heinz bodies are found in a number of hematological disorders, most commonly in glucose 6-phosphate dehydrogenase deficiency. Source: Figure 1, B. Peripheral blood smear depicting abundant Heinz bodies in our patient with hemoglobin H disease by Panagiotis Andreatis, Stomatia Theodorodou, Merrily Pasakiatu et al., Case Reports in Hematology Journal, licensed under CC by 3.0. Hemolytic anemia, 1/14. Number 7. Euro al, _ at CA. SW overlay. Reticulocytes in peripheral blood VV. Photomicrograph of a blood smear, supravital staining, a mixture of cells can be seen, some of which, reticulocytes, contain deep blue granular or meshwork-like cytoplasmic RNA inclusions, red overlay. Reticulocytes, example indicated by yellow overlay, are slightly larger and rounder than mature erythrocytes and usually lack their characteristic central pallor. Multiple mature erythrocytes can also be seen. They feature no cytoplasmic RNA inclusions, usually show distinct central pallor, and are less spherical than reticulocytes. Source: Reticulocytes in peripheral blood, supravital stain, by Ed Uthman, Flickr, licensed under CC by 2.0. OM * copyright * TD, A. Overlay. Reticulocytes in peripheral blood VV. Photomicrograph of a blood smear, supravital staining, a mixture of cells can be seen, some of which, reticulocytes, contain deep blue granular or meshwork-like cytoplasmic RNA inclusions, red overlay. Reticulocytes, example indicated by yellow overlay, are slightly larger and rounder than mature erythrocytes and usually lack their characteristic central pallor. Multiple mature erythrocytes can also be seen. They feature no cytoplasmic RNA inclusions, usually show distinct central pallor, and are less spherical than reticulocytes. Source: Reticulocytes in peripheral blood, supravital stain, by Ed Uthman, Flickr, licensed under CC by 2.0. Overlay. Falciparum malaria, immature trophozoite in Plasmodium falciparum infection compared to other forms of malaria, TRO occlusions. Green overlator than 1 plasmodphozoites of Falciparum malaria are characterized by smaller and finer ring Y. Plasmodium falciparum invades many erythrocytes, and one erythrocyte is typically INV-shaped EM, which is not the case in other forms of malaria. 8x2ers, copyright IMPP. Eurohemolytic anemia, 5/14. AE and copyright 2. Falciparum malaria, immature trophozoite in Plasmodium falciparum infection VV. Compared to other forms of malaria, trophozoites of Falciparum malaria are characterized by smaller and finer ring-shaped inclusions, green overlay. Plasmodium falciparum invades many erythrocytes, and one erythrocyte is typically invaded by more than one plasmodium, which is not the case in other forms of malaria. Source: Copyright IMPP. Overlay. Babesia microti, blood smear, photomicrograph of a peripheral blood smear, Guiamsa stain, very high magnification, The erythrocyte in the center of this blood smear is infected by the protozoan parasite Babesia microti, green overlay. This obligate intracellular pathogen causes babesiosis. Source, ID #538, CDC/Dr. George Healy, Centers for Disease Control and Prevention, CDC, licensed under public domain. Urohemolytic anemia, 7/14. Bartonella bacilliformis infection, Carine disease, v. Photomicrograph of a blood smear, Guiam staining, 1000x magnification, several erythrocytes with pink-stained intracellular Bartonella bacilliformis can be seen, example indicated by white arrow. Other pathogens of Bartonellosis, such as Bartonella hensleyi, cat scratch disease, and Bartonella quintana, trench fever, typically do not invade erythrocytes. Source, Fig. 1, Bacilliformis in an endemic Andean community by Nuria Sanchez Clemente, Cesar Ugartil, Melzer Soliurini, Ciro Magana, David Moore, +1, licensed under CC by 4.0. Modifications, original red marker was replaced with white arrow marker. Urohemolytic anemia, 8/14. EI, Wisplinghoff Laboratories. G overlay. Spherocytosis VV. Photomicrograph of a peripheral blood smear. Multiple spherocytes can be seen, red circles, which have a typical round, rather than biconcave, shape and no central pallor. The erythrocytes vary significantly in size, which is consistent with anisocytosis, red arrows. On electron microscopy, overlay box with drawings based on M appearance, the spherical shape of spherocytes, 1, and normal biconcave erythrocytes, 2, can be seen. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Registered. Copyright 68. Registered. VVEVEE. Copyright 2,0 VEEOSEXX. At BA at %E, E at 8. F /PEE registered SEJ Wisplinghoff Laboratories. Copyright overlay. Spherocytosis VV photomicrograph of a peripheral blood smear. Multiple spherocytes can be seen, red circles, which have a typical round, rather than biconcave, shape and no central pallor. The erythrocytes vary significantly in size, which is consistent with anisocytosis, red arrows. On electron microscopy, overlay box with drawings based on M appearance, the spherical shape of spherocytes, 1, and normal biconcave erythrocytes, 2, can be seen. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Agglutination of erythrocytes VV. Photomicrograph of a peripheral blood smear, high magnification, multiple aggregates of erythrocytes can be seen. This is the typical hematologic appearance of cold agglutinin disease. Source, Figure 1 by Chen, CETAL, Biomed Central, Journal of Medical Case Reports, licensed under CC by 4.0. Urohemolytic anemia, 10/14. €0 VE002 VS 89060 OMOOROE 384 934 1% EO or OE degree OO at R 9 at OE 4 degrees Bo 20,058 SE degree. CS overlay. Erythrocyte morphologies in sickle cell disease VV. Photomicrograph of a peripheral blood smear. Numerous crescent-shaped erythrocytes, known as sickle cells, can be seen, examples indicated by blue overlay. 2 normal erythrocytes are indicated by arrowheads for comparison. Erythrocytes with a red center and a white contouring ring, known as target cells, yellow overlay, CF illustration, are visible at the bottom of the image. Sickle cells are pathognomonic of sickle cell disease. Target cells can be found in sickle cell disease and other hemoglobinopathies. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urohemolytic anemia, 10/14. YWV. OOEUGRO 9 kg. 8 mm so degree. OA and A Wisplinghoff Laboratories. Copyright. Overlay. Erythrocyte morphologies in sickle cell disease VV. Photomicrograph of a peripheral blood smear. Numerous crescent-shaped erythrocytes, known as sickle cells, can be seen, examples indicated by blue overlay. 2 normal erythrocytes are indicated by arrowheads for comparison. Erythrocytes with a red center and a white contouring ring, known as target cells, yellow overlay, CF illustration, are visible at the bottom of the image. Sickle cells are pathognomonic of sickle cell disease. Target cells can be found in sickle cell disease and other hemoglobinopathies. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urohemolytic anemia, 11/14. 0% degree at RRA, OO. $8.09090 at %WMO, S22 slow GF. At RMUPRIESOOVOO, Q50550082 G0 degree SOK, 99958. TE. Degree, 60F degree. Copyright 00,9 YAG copyright. 5 RO. SE- 0. 8, plus bear, 0505 at 8 degrees 00, 9 degrees. OSEO 0 pounds 0 degrees a 20 OE. 300 copyright OEOSEE RE, 2. And RE, 0%, OE 9957, 899, 09057 degree 8000 degree RO. Cade Boz 5900 M 5000 and 999905 006 copyright G9 at 920 of 09. And at 2Z0000.9, GU. 970209 SOGO O at 09% ESSVG0S asterisk 0 OE0, O at 8% 10M. OHSOS0LE copyright BW088Y60 BOP 02 degree roll, zeros on 0, OW 05% CO 80800 degree 9.86 Q 9% 92-.0 degree WL 0 cents. CSSS overlay Y. Target cells, Codocytes, VV. Photomicrograph of a peripheral blood smear. Hypochromic erythrocytes with a dark central area, a pale ring surrounding the center, and a dark outer rim can be seen, dashed red circles on overlay. Due to this bull's-eye appearance on light microscopy, they are called target cells. On electron microscopy, they would appear bell-shaped, overlay illustration, visual axis in light microscopy depicted in red. The finding of target cells is nonspecific and may indicate various hemoglobinopathies, such as thalassemia, liver disease, or asplenia. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Urohemolytic anemia, 11/14. O, 45 WY dons 0 a CS equals A, JUI. 6 ver asterisk copyright. Target cells, Codocytes. Photomicrograph of a peripheral blood smear. Copyright. Overlay. Hypochromic erythrocytes with a dark central area, a pale ring surrounding the center, and a dark outer rim can be seen, dashed red circles on overlay. Due to this bull's-eye appearance on light microscopy, they are called target cells. On electron microscopy, they would appear bell-shaped, overlay illustration, visual axis in light microscopy depicted in red. The finding of target cells is nonspecific and may indicate various hemoglobinopathies, such as thalassemia, liver disease, or asplenia. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Ghana Y00% GS. AG 0.8 registered, 90 L000. 6 degrees 6.0. Copyright I, EEEE 00,06. WTE 170%. O. EG0 fab degree equals E at 0 degree equals 00 phi%, 7, go 09 degree YO. How 9 degrees O degree at 9. Copyright degree 0% 0 copyright 09 SE so 0 degree 30. Yes. O degree CE.29 at 0 G 82 times 10 to the power of 5070 first 46, DAD. C06. O Ogco E712, 3809. 97. QQ&AO by 2. 0,90. OOC O%. 00 GYO or 184.00% QoS. GA0. R plus. Degree. D. Po. $degree 905:80,0209% 0 ORBG 8T0 GU 8.4%. 0. SE. Registered Q 90 cm 9 CEVE, O copyright 6. 32 MyOG. 0 SPE of EE. 7. OO degree. 00 G copyright 9.800. SI. Copyright. O. 0 S528 OSS 90s 0 degree 80, 2 of 5. Her percent. EE009 HMB09 cent. 0 degrees 0,950 EG degree S09 GS degree OS. 3 and 00 E. Overlay. Teardrop-shaped erythrocytes, known as dacrocytes, are found in conditions that involve extramedullary hematopoiesis. Example erythrocytes with a teardrop shape can be seen throughout the image, red overlay. The majority of the erythrocytes appear myelofibrosis, thalassemia, splenomegaly. Round and normal. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Photomicrograph of a peripheral blood smear dacrocytes. Urohemolytic anemia, 13/14. Overlay. Smudge cells in chronic lymphocytic leukemia VV. Photomicrograph of a peripheral blood smear, GIAM stain, high magnification, erythrocytes, a neutrophil, several small lymphocytes, and smudge cells, examples indicated by red overlay, can be seen. Smudge cells, also known as Gump-Recht shadows, are ruptured small neoplastic lymphocytes and are a characteristic but non-specific feature of chronic lymphocytic leukemia. Source, copyright IMPP. Urohemolytic anemia, 13/14. Copyright overlay. Smudge cells in chronic lymphocytic leukemia VV photomicrograph of a peripheral blood smear, GIAM stain, high magnification, erythrocytes, a neutrophil, several small lymphocytes, and smudge cells, examples indicated by red overlay, can be seen. Smudge cells, also known as Gump-Recht shadows, are ruptured small neoplastic lymphocytes and are a characteristic but nonspecific feature of chronic lymphocytic leukemia. Source: Copyright IMPP. Urohemolytic anemia, 14/14. Overlay. Smudge cells in chronic lymphocytic leukemia, CLL, VV. Photomicrograph of a peripheral blood smear, Guillemets stain, high magnification. The smear shows an increase in lymphocytic cells with minimal cytoplasm and dark round nuclei. Some of those cells are fragmented, smudge cells, also referred to as Gump-Recht shadows, red arrowheads. Smudge cells are artificially ruptured neoplastic lymphocytes and are a characteristic, but nonspecific, feature of CLL. Source: smearcells.jpg by Dr. Graham Beards, Wikimedia Commons, licensed under CC by SA 3.0. Urohemolytic anemia, 1/1. Direct-indirect detects ABS on surface of RBCs. Detects ABS in the serum patient's blood. Patient's serum. Test sample. RBC ABS no ABS equals anti-donor RBC ABS no ABS. Ascent to anti-human plus equals OT cent underscore globulin YN $DH donor Coombs reagent RBC's reagent. Agglutination no agglutination no agglutination agglutination QOO copyright underscore degree. WI cent. U. Is A. Registered. PTE, TO asterisk at. Co-DS copyright. Results. Autoimmune hemolysis cross-matching. Direct and indirect Coombs tests VV. A test used to detect hemolytic antibodies bound to RBCs, direct Coombs test, or freely circulating in the serum, indirect Coombs test. 1. The direct Coombs test is used to detect hemolytic antibodies or complement bound to the surface of a patient's erythrocytes. It is used to differentiate between autoimmune and non-immune hemolytic anemias and to diagnose hemolytic diseases of the fetus and newborn. 2. The indirect Coombs test is used to detect hemolytic anti-RBC IgG antibodies, against foreign RBC antigens, present in a patient's serum. It is used to screen for maternal anti-DIgG antibodies, detection of hemolytic disease of the newborn, and to cross-match blood before transfusions. Copyright Boss. X. Acute chest syndrome. Acute chest syndrome, ACS, is a potentially fatal complication of sickle cell anemia caused by vaso-occlusion of the pulmonary vasculature. Symptoms may include chest pain, shortness of breath, and fever. Diagnosis is based on clinical symptoms and chest imaging findings of a new pulmonary infiltrate. Management consists of antibiotics, supportive care with 4 fluids and oxygen, and possibly a blood transfusion. See also sickle cell disease. WA. OE. Definition. Vaso-occlusion of the pulmonary vasculature * triggers include infection, asthma, surgery/general anesthesia. Common cause of death in patients with sickle cell disease. 1. VAOE. Clinical features. Scent chest pain, scent fever, scent respiratory distress, cough, shortness of breath, wheezing. Scent signs of vaso-occlusive crisis, example pain in arms or legs, rib or sternal pain. See also complications below. OSO. CS. Diagnostics. ACS is a clinical diagnosis supported by characteristic clinical features and the presence of new pulmonary infiltrate on imaging. IL laboratory studies. Scent routine. Copyright CBC, anemia, leukocytosis, thrombocytopenia, 5I. Copyright type and screen and cross-match, OBMP and LFTs. Signs of multi-organ failure may be present equals elevated creatinine equals elevated AST and ALT. Copyright sputum and blood cultures. 6L. Copyright arterial blood gas, Gold standard for determining partial pressure of oxygen and carbon dioxide. 17** additional copyright. Consider PCR for viral panel and serologies for respiratory pathogens, example Mycoplasma, Legionella C. pneumonia. Diagnostics. Copyright. Consider troponin to assess for myocardial injury. Imaging. Chest X-ray. 5 Copyright indication. All patients suspected of having ACS. Copyright supportive findings, equals new pulmonary infiltrate equals segmental, lobar, or multilobular consolidation with or without the presence of pleural effusion equals if CXRIS normal, it should be repeated in 24 to 48 hours if there is ongoing clinical suspicion for ACS. 6YS** CT pulmonary angiography, if there is a concern for pulmonary embolism, PE, C. Back collapse. Find text outline. Other. ECG, assess for acute myocardial injury, see diagnosis of myocardial infarction. Stent bronchoscopy with bronchoalveolar lavage, performed in refractory cases and/or in atypical presentations for assessment of viral or bacterial causes. CA. OO. CE. Management. General principles, IL4LL9. Sent all patients. Copyright supportive care. Copyright antibiotics. Copyright evaluation for blood transfusion. Copyright hospital admission with close monitoring and hematology consult. Sent critically ill or rapidly progressing patients. Respiratory and hemodynamic support. Copyright evaluation for urgent exchange transfusion. Admission to the ICU patients with recurrent ACS. Copyright allogenic stem cell transplantation may be indicated. Copyright C. Long-term management of sickle cell disease. 10 Supportive care. Sent respiratory support. Supplemental oxygen, target SPO, 95% C. Copyright identify patients at risk of progression to respiratory failure. 1, equals PEL. O. Avoid overhydration in patients with acute chest syndrome because of the risk of pulmonary edema. Antibiotic therapy, 71. Obtain blood cultures, 2 sets, and sputum cultures before starting antibiotics. Plus start empiric antibiotics, see empiric antibiotic therapy for community-acquired pneumonia. 1E suggested regimen. 3rd generation cephalosporin, example ceftriaxone, 21L13 plus a macrolide, example azithromycin, 4. Blood transfusion. Plus simple blood transfusion /4. Copyright PRBCS indicated if hemoglobin concentration is 1.0 g/dl below baseline. Copyright may not be indicated if the patient's baseline hemoglobin is equals 9 g/dl. Copyright for HBSC or HBS/B thalassemia, consult hematology. Urgent exchange transfusion, 4. Copyright indications equals oxygen saturation. Back collapse. Find text outline. Copyright C. Long-term management of sickle cell disease. 10 Supportive care. Respiratory support. Copyright supplemental oxygen, target SPO, 95% 1 degree. Identify patients at risk of progression to respiratory failure. I equals PEL. For patients with hypovolemia, cautious use of normal saline bolus. 11O bronchodilators, example albuterol, especially in patients with a history of asthma or evidence of acute bronchospasm. Copyright incentive spirometry to prevent atelectasis. OVTE prophylaxis. U1 Copyright treatment of associated complications, see complications. Avoid overhydration in patients with acute chest syndrome because of the risk of pulmonary edema. Urohemolytic anemia. Acute chest syndrome. Acute chest syndrome, ACS, is a potentially fatal complication of sickle cell anemia caused by vaso-occlusion of the pulmonary vasculature. Symptoms may include chest pain, shortness of breath, and fever. Diagnosis is based on clinical symptoms and chest imaging findings of a new pulmonary infiltrate. Management consists of antibiotics, supportive care with 4 fluids and oxygen, and possibly a blood transfusion. See also sickle cell disease. WA. OE. Definition. Vaso-occlusion of the pulmonary vasculature * triggers include infection, asthma, surgery/general anesthesia. Common cause of death in patients with sickle cell disease. 1. VAOE. Clinical features. Scent chest pain, scent fever, scent respiratory distress, cough, shortness of breath, wheezing. Scent signs of vaso-occlusive crisis, example pain in arms or legs, rib or sternal pain. See also complications below. OSO. CS. Diagnostics. ACS is a clinical diagnosis supported by characteristic clinical features and the presence of new pulmonary infiltrate on imaging. IL laboratory studies. Scent routine copyright CBC, anemia, leukocytosis, thrombocytopenia, 5I copyright type and screen and cross-match, OBMP and LFTs. Signs of multi-organ failure may be present elevated creatinine elevated AST and ALT copyright sputum and blood cultures, 6L copyright arterial blood gas, gold standard for determining partial pressure of oxygen and carbon dioxide. 17** additional copyright consider PCR for viral panel and serologies for respiratory pathogens, example Mycoplasma, Legionella C. pneumonia. Diagnostics. Copyright consider troponin to assess for myocardial injury. Imaging. Chest X-ray 5 copyright indication, all patients suspected of having ACS copyright supportive findings, new pulmonary infiltrate segmental, lobar, or multilobular consolidation with or without the presence of pleural effusion if CXRIS normal, it should be repeated in 24 to 48 hours if there is ongoing clinical suspicion for ACS. 6YS** CT pulmonary angiography, if there is a concern for pulmonary embolism, PE, C. Back collapse. Find text outline. Other. ECG, assess for acute myocardial injury, see diagnosis of myocardial infarction. Scent bronchoscopy with bronchoalveolar lavage, performed in refractory cases and/or in atypical presentations for assessment of viral or bacterial causes. CA. OO. CE. Management. General principles, IL4LL9. Scent all patients copyright supportive care copyright antibiotics copyright evaluation for blood transfusion copyright hospital admission with close monitoring and hematology consult scent critically ill or rapidly progressing patients respiratory and hemodynamic support copyright evaluation for urgent exchange transfusion admission to the ICU patients with recurrent ACS copyright allogenic stem cell transplantation may be indicated. Copyright C. Long-term management of sickle cell disease. 10. Supportive care. Scent respiratory support supplemental oxygen, target SPO, 95% C. Copyright identify patients at risk of progression to respiratory failure. 1. PAL. O. Avoid overhydration in patients with acute chest syndrome because of the risk of pulmonary edema. Antibiotic therapy, 71. Obtain blood cultures, 2 sets, and sputum cultures before starting antibiotics. Plus start empiric antibiotics, see empiric antibiotic therapy for community-acquired pneumonia. 1E suggested regimen. A third-generation cephalosporin, example ceftriaxone, 21L13 plus a macrolide, example azithromycin, 4. Blood transfusion. Plus simple blood transfusion /4. Copyright PRBCS indicated if hemoglobin concentration is 1.0 g/dl below baseline. Copyright may not be indicated if the patient's baseline hemoglobin is equals 9 g/dl. Copyright for HBSC or HBS/B thalassemia, consult hematology. Urgent exchange transfusion, 4. Copyright indications equals oxygen saturation. Back collapse. Find text outline. Copyright C. Long-term management of sickle cell disease. 10. Supportive care. Respiratory support copyright supplemental oxygen, target SPO, 95% 1 degree identify patients at risk of progression to respiratory failure. I equals POW. For patients with hypovolemia, cautious use of normal saline bolus 11O bronchodilators, example albuterol, especially in patients with a history of asthma or evidence of acute bronchospasm. Copyright incentive spirometry to prevent atelectasis OVTE prophylaxis U1 copyright treatment of associated complications, see complications. Avoid overhydration in patients with acute chest syndrome because of the risk of pulmonary edema. Antibiotic therapy, 71. Obtain blood cultures, 2 sets, and sputum cultures before starting antibiotics. Start empiric antibiotics, see empiric antibiotic therapy for community-acquired pneumonia. FHO suggested regimen equals a third-generation cephalosporin, example ceftriaxone, 1213 equals plus a macrolide, example azithromycin. 4. Blood transfusion. Simple blood transfusion. 4. Copyright PRBCS indicated if hemoglobin concentration is 1.0 g/dl below baseline. Copyright may not be indicated if the patient's baseline hemoglobin is 9 g/dl. For HBsC or HBs/B thalassemia, consult hematology. Urgent exchange transfusion. 4. Copyright indications equals oxygen saturation. 2*A. Complications. Copyright acute IL-327. Copyright neurological, altered mental status, seizure, stroke, intracranial hemorrhage. TLSEO pulmonary, PE, pulmonary hemorrhage, COR pulmonal. Copyright splenic sequestration causing hypovolemic shock. Copyright multisystem organ failure. Copyright chronic, IISIL-7. Copyright chronic sickle lung disease. EO pulmonary fibrosis. O premature mortality. We list the most important complications. The selection is not exhaustive. EAOSOE. Tips and links. Sources. Back collapse. Find text outline. Overlay. Lung opacities in acute chest syndrome VV. X-ray chest, AP view, of a patient with HBs/B plus thalassemia and symptoms of acute chest syndrome. Lung volumes are low, and bilateral ill-defined opacities, examples indicated by green circles, are seen. Acute chest syndrome is precipitated by a variety of infectious and non-infectious conditions. Opacities from atelectasis or consolidation are frequently more pronounced at the lung bases. Pleural effusion is sometimes present and skeletal abnormalities may be visible. Red lines, endotracheal tube source, figure 1b, in pulmonary edema in HBs/B plus thalassemia patient leading to acute chest syndrome. A case report and review of literature by Chaudhry H., Gillette P., Ashamala M., Hart A., McFarlane S.I. Salafo M., SciPub, licensed under CC by 4.0. Copyright. Overlay. Lung opacities in acute chest syndrome VV. X-ray chest, AP view, of a patient with HBs/B plus thalassemia and symptoms of acute chest syndrome. Lung volumes are low, and bilateral ill-defined opacities, examples indicated by green circles, are seen. Acute chest syndrome is precipitated by a variety of infectious and non-infectious conditions. Opacities from atelectasis or consolidation are frequently more pronounced at the lung bases. Pleural effusion is sometimes present and skeletal abnormalities may be visible. Red lines, endotracheal tube source, figure 1b, in pulmonary edema in HBs/B plus thalassemia patient leading to acute chest syndrome. A case report and review of literature by Chaudhry H., Gillette P., Ashamala M., Hart A., McFarlane S.I. Salafo M., SciPub, licensed under CC by 4.0. Acute chest syndrome, 2 halves. Acute and chronic pulmonary emboli VV. CT chest, with contrast, axial plane, lung window, axial plane, mediastinal window, coronal plane, mediastinal window, of a patient with shortness of breath, post-circulatory collapse, elevated D-dimer, 5086 Ug/L, normal. Multiple intraluminal filling defects in the right and left pulmonary arteries and their lobar, segmental, and subsegmental branches represent pulmonary emboli of different age. The acute emboli are seen as central filling defects, whereas the older emboli are eccentric and show irregular thickening of the arterial wall. Right ventricular and atrial enlargement, septal flattening, and contrast reflux into the hepatic veins are evidence of right ventricular strain. The causes of ground glass opacification in the left upper lobe and misty mesentery with nodes in the upper abdomen are not readily evident. Incidental findings include a hypodense cyst within a small, irregular left kidney and slight deformity of the right sixth rib from a previous fracture. Our great thanks to Nander Faluhalai, University of Pécs, Medical School, for kindly providing this image. X25. EasyRadiology.net. Percent. Position, -185.1 -349.1 image hashtag 36/117 VV -1741, LAN_Syriac, number 7. X23. EasyRadiology.net. VV. Position, -185.1 -349.1 image hashtag 38/117 VV -1701, LAN_Syriac, number 7. X26 EasyRadiology.net. VV. Position, -185.1 -349.1 image hashtag 40/117 VV-1 R241, LAN_Syriac, number 7. X26 EasyRadiology.net. VV. Position, -185.1 -349.1 image hashtag 42/117 VV -1011, LAN_Syriac, number 7. X25. EasyRadiology.net. Patient, P17 January 1, 0001/RAMN abdomen/abdomen. 26. 056. WV. Copyright. Position, -185.1 -349.1 image hashtag 44/117 VV -1071 A Syriac, number 7. X23 EasyRadiology.net. Patient, P17 January 1, 0001/NWRAZM abdomen/abdomen. Equals. Copyright 05. S. M. Bottas G2. FSA, Law, TNWP Emialis, 4. A. F3 TFF. Mabi_Soiter TF pre, ERSIE. Y/. Position, -185.1 -349.1 image hashtag 46/117 VY-9 and 41 I7 Syriac, number 7. X23 EasyRadiology.net. Patient, P17 January 1, 0001/NWRAZM abdomen/abdomen. Equals. Copyright 05. S. OB47E. Y7. MPOWS, 5. Position, -185.1 -349.1 image hashtag 48/117 VY-2 and 01 I, Syriac, number 7. X26 EasyRadiology.net. Patient, P17 January 1, 0001/AKZMN abdomen/abdomen. Copyright 05. BQ. Copyright. Position, -185.1 -3491 image hashtag 50/117 BB host 6, equals LAN _ Seriac, number 7. X23. EasyRadiology.net SE. Patient, P17 January 1st, 0001 /Akazi MN abdomen. Copyright 05. BQ. Copyright. Position, -185.1 -3491 image hashtag 53/117 BB equals I044 equals LAN _ Seriac, number 7. 26 EasyRadiology.net. Patient, P17 January 1st, 0001 /abdomen. Position, -185.1 -349.1 equals ASN4 LAN _ image hashtag 55/117 Seriac, number 7 BB. XX26 EasyRadiology.net. Patient, P17 January 1st, 0001 /Kazi MN abdomen. Copyright 05. BQ. Copyright. Said right ONC entrical. Position, -185.1 -349.1 image hashtag 57/117 BB. BBSIBR equals LAN _ Seriac, number 7. Number 7. X25. EasyRadiology.net SE. Patient, P17 January 1st, 0001 /Akazi MN abdomen. Copyright 05. BQ. Copyright. Ed Wright OC entrical. Position, -185.1 -349.1 image hashtag 60/117 BB -2451 equals LAN _ Seriac, number 7. X25. EasyRadiology.net SE. Patient, P17 January 1st, 0001 /Akazi MN abdomen. Copyright 05. BQ. Copyright. Position, -185.1 -349.1 image hashtag 62/117 BB -2511 equals LAN _ Seriac, number 7. X25. EasyRadiology.net SE. Patient. Patient, P17 January 1st, 0001 /Akazi MN abdomen. Copyright 05. BQ. Copyright. Position, -185.1 -349.1 image hashtag 63/117 BB-5A1 equals LAN _ Seriac, number 7. X23 EasyRadiology.net Patient, P17 January 1st, 0001 /abdomen. 2 Copyright 055H. S Copyright EM_Bolus /SS. Position, -185.1 -349.1 image hashtag 66/117 BY -2441 I7 Val Seriac, number 7. X23 EasyRadiology.net. Patient, P17 January 1st, 0001 /abdomen. 2. Copyright UG5. S. A4. Back collapse fine text outline. N71 equals LAN _ Seriac, number 7. X-glucose-6-phosphate dehydrogenase deficiency. Glucose-6-phosphate dehydrogenase, G6PD, deficiency leads to an impaired regeneration of reduced glutathione, an important antioxidant, which makes RBCs more susceptible to oxidative stress and can result in episodic hemolytic anemia. The condition is inherited in an X-linked recessive pattern and is the most common human enzyme deficiency worldwide. It primarily affects males of African, Asian, and Mediterranean descent. G6PD deficiency is usually asymptomatic, but a sudden surge in oxidative stress, example after infection, consumption of fava beans, or various drugs, may lead to a life-threatening hemolytic crisis. Diagnostic findings include signs of intravascular hemolysis, example normocytic anemia, TLDH, and haptoglobin, Heinz bodies, and white cells on blood smear. Management mainly consists of preventing hemolysis by avoiding triggers. 2*. Epidemiology. Scent G6PD deficiency is the most common human enzyme deficiency. Plus prevalence, 400 million worldwide, 1E affects primarily males of African, Mediterranean, and Asian descent. 2 Epidemiological data refers to the US, unless otherwise specified. O degree. Pathophysiology. X-linked recessive inheritance G6PD is the rate-limiting enzyme of the pentose phosphate pathway, also known as the hexose monophosphate shunt. This pathway yields NAD, which is essential for converting oxidized glutathione back to its reduced form. Reduced glutathione is capable of neutralizing reactive oxygen species, ROS, and free radicals and therefore protecting RBCs from oxidative damage. In the absence of reduced glutathione, example due to G6PD deficiency, RBCs become susceptible to oxidative stress that can damage erythrocyte membranes, resulting in INTR, polar and extraolar hemolysis. Causes of increased oxidative stress are triggers of hemolytic crisis and include degree fava beans drugs, anti-malarial drugs, example chloroquine, primaquine, sulfa drugs, example trimethoprim sulfamethoxazole, nitrofurantoin, isoniazid, dapsone, NSAIDs, ciprofloxacin, chloramphenicol. Bacterial and viral infections, most common cause severe enzymatic deficiency can inhibit respiratory burst activity due to reduced NAD production in phagocytes equals inflammation. During an inflammatory reaction free radicals are produced and can diffuse into RBCs. Metabolic acidosis. Degree. FOP, Co. Clinical features. Scent most patients are asymptomatic. Recurring hemolytic crises may occur, especially following triggers. Copyright arise within 2 to 3 days after increased oxidative stress. 3 sudden onset of back or abdominal pain. Jaundice. Dark urine. Transient splenomegaly. Scent recurrent severe infections causing symptoms of chronic granulomatous disease. Back collapse. Find text outline. XX-glucose-6-phosphate dehydrogenase deficiency. AO. Clinical features. Scent most patients are asymptomatic. Scent recurring hemolytic crises may occur, especially following triggers. Copyright arise within 2 to 3 days after increased oxidative stress. 3 Copyright sudden onset of back or abdominal pain. Jaundice. Dark urine. Degree transient splenomegaly. Scent recurrent severe infections causing symptoms of chronic granulomatous disease. 7 VOCE. Diagnostics. Blood smear. Copyright Heinz bodies. Oxidative stress causes hemoglobin denaturation. Hemoglobin then precipitates as small inclusions within the erythrocytes. Copyright white cells, due to macrophages selectively removing the denatured hemoglobin inclusions of RBCs. Scent signs of intravascular hemolysis. Normocytic anemia. T reticulocyte count. 0% unconjugated bilirubin. TLDH. Haptoglobin. Copyright hemoglobinuria. 2. Scent screening test. Fluorescent spot test copyright add glucose 6-phosphate and NADP measure NAD fluorescence O normal G6PD activity produces fluorescent NAD out of NADP while in G6PD deficiency a lack of fluorescence is seen. Copyright semi-quantitative scent confirmatory test, quantitative G6PD enzyme analysis ideally, both the screening and confirmatory tests should be performed during remission. Copyright stress makes me want to bite into some Heinz ketchup. Oxidative stress in patients with G6PD deficiency may lead to the detection of Heinz bodies and bite cells on the peripheral blood smear. IANA EA66. SE South 90 degrees equals AES. Treatment. Scent avoid triggers, see pathophysiology above. Scent blood transfusions should be performed only in rare, severe cases. OA6. Miscellaneous. Selective advantage in areas of endemic malaria, as with sickle cell anemia, carriers of the G6PD deficiency may be less severely affected by malaria, especially if the disease is caused by Plasmodium falciparum. 4. Back the lab's fine text outline. Uroglucose 6-phosphate dehydrogenase deficiency, 1/1. Symptoms of glucose 6-phosphate dehydrogenase deficiency hemolytic crisis. Epidemiology most commonly affects male individuals of African, 5 jaundice Mediterranean, and Asian descent. Inheritance X-linked recessive. Splenomegaly triggers. Triggers of hemolytic crisis fava beans infections abdominal or drugs that cause oxidative stress, example antimalarials, back pain sulfa drugs. Diagnostics signs of hemolytic anemia, example T reticulocyte count, TT unconjugated bilirubin, histology, bite cells, Heinz bodies confirmatory test, quantitative G6PD enzyme analysis equals ale dark urine. Treatment avoidance of triggers. Reduced form glucose 6P- copyright. 2GSH plus, /NYGE, /N, glucose 6P glutathione dehydrogenase reductase peroxidase _dehydrogenase A equals INAD plus H asterisk. Glucose 6-phosphate dehydrogenase, G6PD, deficiency fact sheet BB. Glucose 6-phosphate dehydrogenase is the rate-limiting enzyme of the pentose phosphate pathway and oxidizes glucose 6P to 6-phosphogluconate while reducing NADP to NAD. NAD is essential for converting oxidized glutathione back to its reduced form, GSH. The reduced glutathione is capable of neutralizing reactive oxygen species, example hydrogen peroxide, and free radicals, thereby protecting red blood cells from oxidative damage. In G6PD deficiency, glutathione cannot be reduced and erythrocytes become susceptible to oxidative stress, resulting in damage to the erythrocyte membrane, and thus intravascular and extravascular hemolysis. Copyright Unpack. Unpack. Uroglucose 6-phosphate dehydrogenase deficiency, 1/1. Ox glucose 6P trademark FOROS2GSHOSA copyright. Glucose 6P glutathione dehydrogenase reductase peroxidase. 6-phosphogluconate 7N NAD plus ICE SE _/A2HO OXRED. Reduction and oxidation reactions of glutathione BB. In its reduced form, GSH, glutathione detoxifies free radicals and peroxides, here hydrogen peroxide, HERTZO, on the right. This reaction is catalyzed by the glutathione peroxidase and results in oxidized glutathione, GSSG, and water, H20. To convert the GSSG back to GSH, the catalyzing enzyme glutathione reductase requires NADPH, nicotinamide adenine dinucleotide phosphate hydrogen. One possible pathway that yields NAD for reductive reactions is the pentose phosphate pathway, hexose monophosphate shunts. The enzyme glucose 6P dehydrogenase, G6PD, Oxidizes glucose 6P to 6-phosphogluconate and reduces NADP to NAD. The reduced glutathione is particularly important for protecting RBCs from oxidative damage. In its absence, example due to G6PD deficiency, RBCs become susceptible to oxidative stress, resulting in hemolytic anemia. Copyright Unpack. Uroglucose 6-phosphate dehydrogenase deficiency, 1/3. Overlay. Heinz bodies. Photomicrograph of a peripheral blood smear, May Grunwald-Guillemets stain, multiple erythrocytes are visible, some of which contain small round inclusions, example indicated by yellow overlay. These inclusions consist of denatured hemoglobin and are called Heinz bodies. They are classically associated with G6PD deficiency, but can also be seen in other conditions. Source, Fig 1, in Usefulness of NGS for Diagnosis of Dominant Beta Thalassemia and Unstable Hemoglobinopathies in 5 Clinical Cases by Ritsuto v. Koopman T.T., Blanco Alvarez A.E.T.A.L., Frontiers in Physiology, licensed under CC by 4.0. Modifications, removal of 4 arrows and the letters A, B, C, D. Uroglucose 6-phosphate dehydrogenase deficiency, 1/3. Overlay. Copyright. Heinz bodies. Photomicrograph of a peripheral blood smear, May Grunwald-Guillemets stain, multiple erythrocytes are visible, some of which contain small round inclusions, example indicated by yellow overlay. These inclusions consist of denatured hemoglobin and are called Heinz bodies. They are classically associated with G6PD deficiency, but can also be seen in other conditions. Source, Fig 1, in Usefulness of NGS for Diagnosis of Dominant Beta Thalassemia and Unstable Hemoglobinopathies in 5 Clinical Cases by Ritsuto v. Koopman T.T., Blanco Alvarez A.E.T.A.L., Frontiers in Physiology, licensed under CC by 4.0. Modifications, removal of 4 arrows and the letters A, B, C, D. Uroglucose 6-phosphate dehydrogenase deficiency, 2/3. AF oft ROOA asterisk. Asterisk S asterisk. Asterisk hashtag 4 colonase, 4 and. Re. G. Overlay. Heinz bodies VV. Photomicrograph of a peripheral blood smear, numerous erythrocytes are visible. They contain dense aggregates of denatured hemoglobin, Heinz bodies, examples indicated by green overlay, which appear as dark spots. Heinz bodies are found in a number of hematological disorders, most commonly in glucose 6-phosphate dehydrogenase deficiency. Source, Figure 1, B. Peripheral blood smear depicting abundant Heinz bodies in our patient with hemoglobin H disease by Panagiotis Andreatis, Stomatia Theodorodou, Marilee Pasacchiatou et.al., Case Reports in Hematology Journal, licensed under CC by 3.0. Uroglucose 6-phosphate dehydrogenase deficiency, 2/3. Asterisk asterisk IAD asterisk EES. S registered yen. A. Plus asterisk cent QEPA at. Equals. Overlay. Heinz bodies VV. Photomicrograph of a peripheral blood smear, numerous erythrocytes are visible. They contain dense aggregates of denatured hemoglobin, Heinz bodies, examples indicated by green overlay, which appear as dark spots. Heinz bodies are found in a number of hematological disorders, most commonly in glucose 6-phosphate dehydrogenase deficiency. Source, Figure 1, B. Peripheral blood smear depicting abundant Heinz bodies in our patient with hemoglobin H disease by Panagiotis Andreatis, Stomatia Theodorodou, Marilee Pasacchiatou et.al., Case Reports in Hematology Journal, licensed under CC by 3.0. Co-glucose 6-phosphate dehydrogenase deficiency, 3/3. Bite cells in glucose 6-phosphate dehydrogenase, G6PD, deficiency. Photomicrograph of a peripheral blood smear, right GIMSA stain, 600x magnification, multiple erythrocytes are visible, some of which have an abnormally shaped membrane due to macrophage-mediated removal of denatured hemoglobin that precipitated at the cell membrane, examples outlined in green. They appear smaller, denser, and more contracted than normal erythrocytes, example outlined in red. These abnormally formed cells are called bite cells and result from oxidative hemolysis, which is seen in G6PD deficiency. Source: Fig 7, in Anemias raras y fallos middleros hereditarios by Vives Corones J, Mahu Pereira MM, Trujillo JP, Sorales J, Sevilla J, Arbor, licensed under CC by 4.0. Modifications, overlay created. Methemoglobinemia. Methemoglobinemia is a condition in which more than 1% of hemoglobin contains iron in its oxidized form and cannot participate in oxygen delivery. Methemoglobinemia can be inherited but is more commonly an acquired condition that follows exposure to local anesthetics, dapsone, nitrates, or other chemicals. Symptoms typically do not begin until methemoglobin makes up over 10% of the total hemoglobin and include cyanosis, fatigue, and tachycardia. Diagnostic findings include decreased conventional pulse oximeter saturation readings that remain fixed around 85%, direct methemoglobin elevation on co-oximetry, and blood that appears dark brown. All patients receive supportive treatment, example oxygen, and for hydration. Patients who are symptomatic and/or have methemoglobin levels 30% are typically treated with methylene blue. O2. Definition 11L2I. Cent methemoglobin copyright a form of hemoglobin in which an iron molecule has been oxidized from a ferrous, Fe, to a ferric, Fe, state. Copyright cannot bind oxygen. Copyright normally. 2 * Re. Etiology. Acquired methemoglobinemia/22324. Acquired methemoglobinemia is the most common form of methemoglobinemia and occurs as a result of exposure to substances that increase methemoglobin levels. Medications scent local anesthetics, benzocaine, lidocaine vasodilators, inhaled nitric oxide, nitroglycerin, isosorbide mono and dinitrate. See also cardiovascular drug toxicity. Anti-infectious agents, dapsone, sulfonamides scent other, phenoxypyridine, metoclopramide, aniline derivatives. Food and water. 81. In the gastrointestinal tract, nitrates are partially converted to nitrites, which catalyze the conversion of oxyhemoglobin to methemoglobin. Scent sodium nitrites, used to cure meat and some cheeses. Scent drinking water contamination, increased nitrate concentration, usually related to nearby agricultural activity. Infants and children have an increased risk of methemoglobinemia after nitrate ingestion because they have lower methemoglobin reductase levels. 019 Hereditary methemoglobinemia/2IL3 scent NADH cytochrome B5 reductase deficiency, autosomal recessive, plus glucose-6-phosphate dehydrogenase, G6PD, deficiency, 11. 7 * CES. Pathophysiology / plus methemoglobin is created when reduced ferrous iron, Fe2, bound to oxyhemoglobin is oxidized to ferric iron, Fe%. Scent ferric iron in methemoglobin cannot bind oxygen. J total blood oxygen content and blood oxygen saturation. Tissue hypoxia. The ferric iron in methemoglobin has a high affinity for cyanide, thus, amyl nitrite-induced methemoglobin is used as a competitive inhibitor in the treatment of cyanide poisoning. /4. So. And. Clinical of anemia. LL21 methemoglobin level signs and symptoms. Symptoms of oxygen deprivation. Copyright confusion. Lightheadedness and/or syncope. 0-00%. Copyright headache, dyspnea, tachycardia. CNS depression, seizures, chest pain, arrhythmias. 50 to 70%. 70% death. The symptoms of methemoglobinemia are similar to those of anemia because the concentration of functioning oxyhemoglobin is decreased in both conditions. 2. Copyright cyanosis typically occurs when methemoglobin levels are equals 1.5 gm/dl, 10% of total hemoglobin. 1 equals backslash yen lngvo. Ruicoccus, c. Diagnostics. The clinical history of a patient with cyanosis and/or hypoxia may lead to a preliminary diagnosis of methemoglobinemia, which can be rapidly confirmed with co-oximetry. E-pulse oximetry. Copyright conventional pulse oximeter, the displayed oxygen saturation is decreased and often fixed 85%. 3. Copyright co-oximeter, direct measurement of methemoglobin ABGO normal PAO2 but decreased total oxygen content, i.e., a saturation gap. 2. IL-131*. Bedside testing, blood appears dark brown, chocolate-colored, and does not turn red with exposure to oxygen. GP your note. AE shall not manage. Treatment. 6. In patients with acquired methemoglobinemia, assess for potential triggers and stop exposure immediately. Methylene blue 21I3I1. Methylene blue is the first-line treatment for acquired methemoglobinemia. 2 indications, acquired methemoglobinemia. Relative contraindications. Copyright G6PD deficiency, may precipitate acute hemolysis. 1, 21-EO MAO inhibitor or selective serotonin uptake inhibitor use, may precipitate serotonin syndrome. 314. Avoid over-administration of methylene blue. Doses equals 7 mg per kilogram can directly oxidize hemoglobin to methemoglobin and worsen methemoglobinemia. IU. Alternative treatments. 2I3. Alternative treatments may be considered if methylene blue is unavailable, ineffective, or contraindicated. Reducing agents, ascorbic acid, vitamin C, or riboflavin. Copyright reduce methemoglobin to hemoglobin, but less efficiently than methylene blue O used primarily for inherited methemoglobinemia or as an adjunct to methylene blue. Back collapse. Fine text outline. Cyanosis secondary to methemoglobinemia VV. Palms and forearms of a 44-year-old female patient presenting with syncope and a 1-week history of local anesthetic gel use for toothache. While the skin of the forearms appears unremarkable, the palms of both hands are cyanotic. Excessive topical anesthetics use may cause methemoglobinemia. This patient's methemoglobin level was found to be 52%, normal range 0 to 3%, explaining her presentation with symptoms of oxygen deprivation. Source: FLG1, in Warm and Blue, A Case of Methemoglobinemia by Biggs D. Castillo DC, J.E. Tem, licensed under CC by 4.0. X. Hereditary spherocytosis. Hereditary spherocytosis, HS, is the most common congenital hemolytic disorder among individuals of Northern European descent. In most cases, it is an autosomal dominant disease that is caused by red blood cell, RBC, membrane protein defects, which render the RBCs more vulnerable to osmotic stress and hemolysis. Clinical presentation ranges from mild HS, which is generally asymptomatic, to severe HS, which can already present in utero with hydrops fetalis. Moderate HS, which is the most common form, usually presents in infancy or childhood with the classic triad of anemia, jaundice, and splenomegaly. Diagnosis is established based on family history, typical laboratory findings, example elevated mean corpuscular hemoglobin concentration and RBC distribution width, and tests, example eosin 5-maleimide binding test, osmotic fragility test. Treatment depends on the severity of the disease and involves acute measures, example red blood cell transfusions, phototherapy, medication. Example folic acid supplementation, and splenectomy. HS patients are also at risk for complications such as hemolytic endoplastic crises, megaloblastic anemia, and gallstone formation. A2. Epidemiology. Plus incidence, 1/5,000 in the USA. Most common inherited hemolytic disease among individuals of Northern European descent. Epidemiological data refers to the US, unless otherwise specified. OSOE. Etiology. Cent congenital RBC membrane protein defect. E inheritance pattern. O autosomal dominant, 75% of cases. O autosomal recessive, 25% of cases. O family history often positive for relatives who required splenectomy and/or developed cholelithiasis at a young age. Cent frequently affected proteins. O spectrin. O ankyrin degree. Band 3 copyright protein 4.2. O degree. Pathophysiology. Genetic mutation defects in RBC membrane proteins, especially spectrin and/or ankyrin, responsible for tying the inner membrane skeleton with the outer lipid bilayer. Continuous loss of lipid bilayer components. Decreased surface area of RBCs in relation to volume. Sphere-shaped RBCs with decreased membrane stability. Inability to change form while going through narrowed vessels. E entrapment within splenic vasculature. Splenomegaly. Cent destruction via splenic macrophages. Extravascular hemolysis. WA. Fe. C. Clinical features. Cent presentation is variable. Copyright mild HS, 20 to 30% of cases often asymptomatic. Copyright moderate HS, 60 to 75% of cases onset of symptoms in infancy or childhood. O severe HS, 5% of cases onset of symptoms in newborns or even in utero. Hydrops fetalis, E anemia and pallor. E jaundice, due to T unconjugated bilirubin. Cent splenomegaly with left upper quadrant pain plus black pigment. Gallstones, made of calcium bilirubinate, may lead to cholecystitis. 5. References 2-3i. Back collapse. Fine text outline. Diagnostics. Laboratory findings. O normocytic anemia, mean cell volume, MCV, within normal range, 80 to 100 FL, or slightly decreased. O increased mean corpuscular hemoglobin concentration, MCHC, 4OT red blood cell distribution with TRDW, 1OT reticulocytes, normal range, 0.5%-1.5% of total RBC count. Copyright findings of hemolytic anemia equals 1 unconjugated bilirubin equals haptoglobin equals TLDHE. Laboratory tests. O eosin 5-maleimide binding test, EMA binding test, equals test of choice, as results are readily available, within 2 hours, equals decreased binding between eosin 5-maleimide, and RBC membrane proteins. Binding is quantified using flow cytometry, which shows decreased mean fluorescence. O other tests may be performed in addition to the EMA binding test. Equals negative Coombs test, to exclude autoimmune hemolytic anemia, positive Coombs test, since spherocytosis is seen in both. Equals positive osmotic fragility test. Equals measures the ability of RBCs to resist hemolysis when exposed to different degrees of salt dilution, example RBCs swell and eventually lyse when incubated. In hypotonic saline due to water influx, equals whether or not RBCs lyse depends on their surface area to volume ratio. This ratio is decreased in patients with HS, so their RBCs are more fragile and more vulnerable to osmotic stress. Equals acidified glycerol lysis test. Equals red blood cells are incubated in a hypotonic solution, to which glycerol is added. Equals the test is positive if the patient's spherocytes lyse more quickly than normal RBCs. Equals has a greater sensitivity than the classic osmotic fragility test. Cent blood smear. Copyright characteristics. Spherocytes, small round cells without central pallor. Copyright potentially anisocytosis. 1 cent ultrasound, to evaluate gallbladder complications, see cholelithiasis, cholecystitis, and cholangitis. References 5. O*. Treatment. Sent non-surgical treatments or phototherapy and/or exchange transfusions may be necessary in neonates, example to avoid kernicterus. Copyright blood transfusions may be required in cases of aplastic or hemolytic crisis, see complications below. Copyright folic acid supplementation to maintain erythropoiesis. Sent splenectomy or sole definitive treatment. 1 Copyright prior to the procedure, vaccinate against Streptococcus pneumoniae, Haemophilus influenza type B, and Neisseria meningitidis, see asplenia. VA 6 Shared notes. Complications. Sent hemolytic crisis, especially as a result of viral infection. Sent aplastic crisis, following infection with parvovirus B19, erythema infectiosum, characterized by a low reticulocyte count. We list the most important complications. The selection is not exhaustive. Back collapse. Fine text outline. At OE. At 8730 VEE essay. EI, Wisplinghoff Laboratories. G overlay. Spherocytosis VV photomicrograph of a peripheral blood smear. Multiple spherocytes can be seen, red circles, which have a typical round, rather than biconcave, shape and no central pallor. The erythrocytes vary significantly in size, which is consistent with anisocytosis, red arrows. On electron microscopy, overlay box with drawings based on M appearance, the spherical shape of spherocytes, 1, and normal biconcave erythrocytes, 2, can be seen. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Hereditary spherocytosis, 1/2. Registered. Copyright. X hemostasis and bleeding disorders. Bleeding disorders are a group of heterogeneous conditions characterized by defects in hemostasis that lead to an increased susceptibility to bleeding, also known as hemorrhagic diathesis. They are classified into disorders of primary hemostasis, when caused by a platelet abnormality, disorders of secondary hemostasis, when caused by defects in the extrinsic and/or intrinsic pathway of the coagulation cascade, and hyperfibrinolysis, when there is increased clot degradation. Although clinical features may overlap, mucocutaneous bleeding, example epistaxis, petechiae, gastrointestinal bleeding, is associated with disorders of primary hemostasis, and bleeding into potential spaces, example hemarthrosis, muscular bleeding, is characteristic of disorders of secondary hemostasis. The diagnostic workup of a bleeding disorder begins with a detailed clinical assessment, the CBC, and a coagulation panel. This typically allows the disorder to be classified as one of primary or secondary hemostasis. Specialized studies are then required to determine the specific etiology so that treatment can be initiated. Treatment may include transfusion of blood products, replacement of specific coagulation factors, or administration of adjuvant medications, example tranexamic acid or desmopressin. WA. OE. Hemostasis. Overview, 11L2. Hemostasis is the physiological process by which a bleeding stops. Its final result is a thrombus, blood clot, which consists of blood cells and fibrin strands. Hemostasis involves the following mechanisms: sent primary hemostasis or vascular hemostasis, transient vasoconstriction and VWF activation following endothelial injury. Copyright platelet hemostasis, adhesion, activation, and aggregation of platelets, which results in the formation of a platelet plug, white thrombus, secondary hemostasis, activation of the coagulation cascade, which results in the formation of a fibrin clot, red thrombus, primary hemostasis. Sent definition, processes involved in the formation of a platelet plug, white thrombus, following endothelial injury. Sent vascular hemostasis. Endothelial injury results in equals neural stimulation reflexes and endothelin release transient vasoconstriction, leading to, equals reduced blood flow equals platelet accumulation at the vessel walls, equals exposure of subendothelial collagen circulating von Willebrand factor binds to the exposed collagen copyright von Willebrand factor, VWF plasma protein. That is synthesized by and stored in endothelial cells, in Weibel-Palade bodies, and platelets, in A granules, equals mediates platelet adhesion and aggregation equals binds factor VIL, and thereby prevents its degradation, sent platelet hemostasis 1. Platelet adhesion, platelets bind to VWF via platelet GPLB receptor at the endothelial injury site equals ristocetin normally activates VWF to bind to glycoprotein IB. 2. Platelet activation, after binding to VWF, platelets change their shape and release mediators that lead to activation of more platelets, positive feedback. These mediators include, equals adenosine diphosphate, ADP promotes adhesion of platelets to endothelium equals thromboxane A2, TXA activates additional platelets and promotes vasoconstriction equals calcium, required for secondary hemostasis equals platelet activating factor, PAF a phospholipid mediator that is produced by platelets and inflammatory cells, example neutrophils, monocytes, macrophages, involved in platelet aggregation and activation and local inflammatory response 3. Platelet aggregation equals mediated by GPLLB/IL receptor and fibrinogen formation of a white thrombus composed of platelets and fibrinogen equals a white thrombus is transient, unstable, and easily dislodged. It stabilizes through the process of secondary hemostasis. Secondary hemostasis. Scent definition, processes that lead to stabilization of the platelet plug, white thrombus, by creating a fibrin network or coagulation cascade, a sequence of events triggered by the activation of the intrinsic or extrinsic pathway of coagulation that results in the formation of a stable thrombus or coagulation factors equals substances that interact with each other to promote blood coagulation equals activated factors are designated with an A, example activated factor 7 equals factor VILA. Scent extrinsic pathway of coagulation, triggered by endothelial injury 1. Tissue factor, factor IL, activates factor 7. Equals tissue factor is expressed on the surface of subendothelial muscle cells and fibroblasts. 1. Back collapse fine text outline. Scent extrinsic pathway of coagulation, triggered by endothelial injury 1. Tissue factor, factor 3, activates factor 7. Equals tissue factor is expressed on the surface of subendothelial muscle cells and fibroblasts. Equals factor 7, vitamin K-dependent coagulation factor produced by the liver 1-2. Factor VILA and tissue factor form a complex, TF-VILA. This step requires calcium, factor 4, found on the surface of fibrocytes and activated platelets. 3 TF-VILA activates factor X and factor 9. Scent intrinsic pathway of coagulation O exposed collagen, kallikrein, and kininogen, HMWK, activate factor 12. Equals factor 12, Hagemann factor coagulation factor that also plays a role in inflammatory response by activating the kallikrein system, which leads to the production of bradykinin equals factor SLA activates factor 11. Copyright thrombin activates factor 11 and factor 8. Copyright factor SLA activates factor 9. O factors VILA and IXA form a complex, mediated by calcium, that activates factor X. Copyright this causes a positive feedback loop of factor X and thrombin activation via the intrinsic pathway. Scent common pathway of coagulation, the extrinsic and intrinsic pathway both end in the common pathway. 1 factor XA and factor VA form a complex, mediated by calcium, that cleaves prothrombin, factor 2, to thrombin, factor ILA. 2 thrombin cleaves fibrinogen, factor, into insoluble fibrin, factor LA, monomers. Three cross-links of the fibrin network are stabilized by factor XI. ILA formation of a fibrin network equals fibrin closely binds to the platelet plug, forming a stable thrombus, secondary thrombus or red thrombus. Factor number I: UT, WT, VE, VIL asterisk, VIL asterisk, 9 asterisk, XE, 11 asterisk, ZIL asterisk, ZIL asterisk. Descriptive name: fibrinogen asterisk active form, La fibrin prothrombin asterisk active form, ILA thrombin. Tissue factor asterisk, TF. Calcium asterisk, Ca2 asterisk. Proxylarin, 1. Proconvertin asterisk. Antihemophilic factor, AHF, 4 plasma thromboplastin component, PTC, Christmas factor. Stewart factor. Plasma thromboplastin antecedent, PDA. Hagemann factor. Fibrin stabilizing factor. Overview of coagulation factors activated by thrombin. Factor XA/VA complex. Endothelial injury. Released by platelets and fibrocytes. Thrombin. Tissue factor. Thrombin. Factor slip. Complexes TF VILA and VILA IXA factor XIL thrombin exposed collagen kallikrein kininogen, HMWK, thrombin. Involvement in pathways: common intrinsic extrinsic VP. VVVV. A. VVV degree Y7. F. V. Up. 7. Asterisk equals preferred term 3T rarely used term. Function. Stabilization of the platelet plug cleaves fibrinogen to fibrin, activates numerous other coagulation factors, activates factor 7 tissue factor and factor VILA, form a complex that activates factor X. Required for complex formation and other reactions in the coagulation cascade. Factors VA and XA form a complex that cleaves prothrombin to thrombin. Factor VILA and tissue factor form a complex that activates factor XX. Factors VILA and IXA form a complex that activates factor X. Factors XA and VA form a complex that cleaves prothrombin to thrombin. Activates factor 9. Activation of copyright factor 11 degree kallikrein system leads to the production of bradykinin, stabilizes the fibrin network by introducing cross-links. The coagulation cascade requires the presence of calcium ions, factor 4. A helpful way of remembering the coagulation factors of the extrinsic pathway is 3 plus 7 equals 10, tissue factor, factor 3, and factor 7 form a complex that activates factor X of the common pathway. A helpful way of remembering the coagulation factors of the common pathway is 10/5 equals 2x1, factors XA and VA form a complex that cleaves prothrombin, factor IL, to thrombin, ILA. Factor ILA then cleaves fibrinogen, I, into insoluble fibrin monomers, LA. Inhibition of hemostasis. A. Find text. A. Outline. Inhibition of hemostasis. In order to prevent hypercoagulability as well as excessive bleeding, activation of the coagulation cascade and the processes that inhibit it occur simultaneously in the circulatory system. Procoagulant-anticoagulant balance. Scent tissue factor pathway inhibitor, inhibits tissue factor protein C and protein S. Activated protein C and its cofactor protein S form the activated protein C complex, APC complex, which inhibits factors VA and VILA. O. Vitamin K dependent synthesis in the liver. Copyright shorter half-life than vitamin K dependent coagulation factors, relevant for treatment with vitamin K antagonists, example warfarin. Copyright clinical relevance equals APC resistance equals factor V Leiden equals protein C deficiency, protein S deficiency. Scent antithrombin. O degrades thrombin and factors IXA and XA. Copyright activates tissue plasminogen activator, TPA, Copyright clinical relevance, antithrombin 3 deficiency, example due to liver failure or kidney failure. Scent nonspecific inhibitors, protease inhibitors in plasma, example alpha-1 antitrypsin, alpha-2 macroglobulin. Scent drug-induced, anticoagulant treatment, see oral anticoagulants and parenteral anticoagulants, others. Copyright protein Z, factor X inhibitor, copyright heparin-like glycosaminoglycans, boosts antithrombin, copyright heparin cofactor 2, requires heparin for activation. Diseases that affect the inhibitors of the coagulation cascade may lead to hypercoagulability. 7-6. Fibrinolysis. Overview 21. Scent definition, degradation of the fibrin network of thrombi by the enzyme plasmin mechanism. Copyright tissue injury leads to the release and activation of plasminogen activators, which convert plasminogen to its active form plasmin. Tissue plasminogen activator, TPA, urokinase, see fibrinolytics. Copyright plasmin breaks down and deactivates fibrin and fibrinogen release of fibrin degradation products, E.G, D-dimers, scent regulation. Copyright plasminogen activator inhibitors, example Pi1, inhibit TPA. Copyright plasmin inhibitors, example PPIC. Fibrinolytic therapy /41. Scent agents, fibrinolytics promote the degradation of thrombi by activating plasminogen to plasmin. Copyright fibrin-specific agents, tissue plasminogen activator, TPA, recombinant plasminogen activators, RTPA-TPAs that are produced by recombinant biotechnology techniques. Alteplase reteplase, RPA, equals tenecteplase, TNK-TPA, degree non-fibrin-specific agents. 1 equals streptokinase, enzyme produced by group A streptococcide, catalyzes the conversion of plasminogen to plasmin. Urokinase, serine protease found in plasma, urine, and various types of tissue that is also used in fibrinolytic therapy. Mechanism of action, directly or indirectly increase the concentration of plasmin. Cleavage of thrombin and fibrin. I5e laboratory findings. OTPTOF PIT. Copyright normal platelet count. Scent adverse effects. Copyright bleeding, example intracranial hemorrhage. Copyright hypersensitivity reactions, especially to streptokinase. 6. Back collapse. Find text outline. Scent indications. Early steaming. Alteplase is a synthetic tissue plasminogen activator that converts plasminogen to plasmin. It is used in the treatment of STEMI, massive pulmonary embolism, and ischemic stroke. Disorders of fibrinolysis. Hypoplasminogenemia, 71. Scent definition, inherited genetic condition characterized by abnormally low levels of plasminogen, which results in a buildup of fibrin. Epidemiology, rare disease, prevalence is estimated to be approximate 1:625,000. Etiology, autosomal recessive inherited mutations in the PLG gene. Pathophysiology, mutations of the PLG gene. J concentrations and/or functional impairment of plasminogen. Plasmin J. Fibrinolysis, accumulation of fibrin. Clinical features, usually manifest in early infancy. Formation of inflamed, thick, wood-like growths, lignear pseudomembranes, on mucous membranes, especially the conjunctiva, that appear white, yellow, or red. CJ. Copyright other areas that can be affected, skin, CNS, gingiva, gastrointestinal tract, lungs, female genital tract, example fallopian tubes. Not associated with thrombophilia. Diagnostics. Initially, clinical presentation, laboratory tests for plasminogen activity. Copyright genetic testing confirms the diagnosis. Differential diagnosis, infections, most common, but also conditions such as allergies, GERD, IBD, endometriosis, depending on the area affected. Treatment. Copyright intravenous injection of replazine 8 equals plasma-derived human plasminogen used in the treatment of hypoplasminogenemia. Adverse effects include gastrointestinal upset, extremity pain, and hemorrhage. Copyright surgical removal of growths is usually not recommended due to rapid regrowth. Complications: copyright corneal scarring, loss of vision, copyright duodenal ulcers, copyright occlusive hydrocephalus, copyright can reduce fertility, copyright impaired wound healing. OOOE. Etiology. Hemorrhagic diathesis is the abnormally increased susceptibility to bleeding. Back collapse. Fine text outline. Disorders of primary hemostasis. Plus platelet disorders. Copyright platelet deficiency, see etiology in thrombocytopenia, O platelet dysfunction, thrombocytopathy, disorders that lead to dysfunctional adhesion or aggregation of platelets inherited to von Willebrand disease Bernard-Soulier syndrome Glanzmann thrombasthenia acquired drug-induced, example aspirin, NSAID, clopidogrel immune thrombocytopenic purpura chronic kidney disease, cardiopulmonary bypass 5/0. See also differential diagnosis of platelet disorders. Scent disorders affecting the vessel wall. Copyright vascular hemorrhagic diathesis, example IgA vasculitis, hereditary hemorrhagic telangiectasia, copyright thrombotic microangiopathy, example HUS and TTP, copyright conditions with impaired collagen synthesis, example scurvy, Ehlers-Danlos syndrome. Disorders of secondary hemostasis, disorders of the coagulation cascade. Scent intrinsic pathway. Copyright factor 8 deficiency, hemophilia A, copyright factor 9 deficiency, hemophilia B, copyright factor 11 deficiency, hemophilia C, scent extrinsic pathway, factor 7 deficiency, autosomal recessive bleeding disorder caused by mutation of the F7 gene, scent both pathways. Copyright deficiency or inhibition of vitamin K-dependent coagulation factors 2, 7, 9, and X5, equals vitamin K deficiency, example malabsorption syndrome, depletion of gut flora, example following antibiotic administration. Vitamin K deficiency bleeding of the newborn equals vitamin K antagonist therapy, example warfarin. Copyright inhibition of coagulation factors by autoantibodies, most commonly anti-factor 8, 11. Copyright disseminated intravascular coagulation, DIC. Copyright impaired hepatic production of coagulation factors, example cirrhosis, O fibrinogen deficiency. Copyright anticoagulant treatment. In disorders of primary hemostasis, platelet aggregation is impaired, whereas in disorders of secondary hemostasis it is the coagulation cascade that is impaired. Hyperfibrinolysis, 121. Scent definition, excessive fibrinolytic activity, resulting in increased bleeding. Scent etiology, O disseminated intravascular coagulation, secondary to liver dysfunction, sepsis, etc. Copyright peripartum complications. Copyright treatment with fibrinolytics. Copyright surgery in TPA-rich organs such as the prostate and uterus. Copyright prostate carcinoma, paraneoplastic, pathophysiology, excessive plasmin activity, increased fibrin degradation, thrombus instability and dissolution shortly after formation. 1 Scent treatment, antifibrinolytic agents, example tranexamic acid, if DIC has been excluded. Hypofibrinolysis. Scent definition, abnormally low fibrinolytic activity, resulting in thrombosis. Etiology. Copyright TPA or UPA deficiency. Copyright overexpression of PI1 or TAFI. Hypofibrinogenemia, 13. Back collapse. Fine text outline. Hypofibrinogenemia, 31. Scent definition, a disorder characterized by low plasma fibrinogen levels. Scent etiology. Copyright congenital, mutation of fibrinogen genes, FGA, FGB, FGG, on chromosome 4 degree acquired, associated with liver failure, disseminated intravascular coagulation, DIC, liver transplantation, massive blood transfusion, hemodilution, consumption of clotting factors. 141 Scent pathophysiology. Copyright congenital, mutation, lack of functional fibrinogen glycoprotein production of fibrinogen. Hemorrhagic Diathesis copyright acquired, fibrinogen concentration, various causes, hemorrhagic diathesis symptoms and findings, epistaxis, gastrointestinal hemorrhage, gingival bleeding scent treatment, fresh frozen plasma. 7 CE. Clinical features. ABA disorders ILETEL clinical of. Disorder characteristics of bleeding manifestations bleeding of mucous membranes, e.g., copyright epistaxis copyright bleeding gums copyright gastrointestinal bleeding cutaneous and subcutaneous bleeding, e.g., primary hemostasis disorders, degree * onset, immediately after trauma opaticales copyright purpura degree superficial ecchymosis copyright easy bruising menorrhagia prolonged and excessive bleeding after surgery. Deep tissue bleeding, e.g., eohemarthrosis, especially in hemophilia, dairy H is disordered * onset, delayed, minutes to hours after trauma, O Berry-Sturz. Large, palpable ecchymosis LS. Bleeding symptoms may include, degree petechial bleeding CDI scent variable, depends on underlying cause, degree ecchymosis copyright oozing of blood from surgical wounds and intravenous line symptoms of hypercoagulation, see clinical features in DIC. A thorough physical examination is essential for diagnosing bleeding disorders and should include the inspection of the entire skin, mucosa, especially oral cavity, and joints. Watch out for signs of physical abuse, which may produce patterns of bruising that resemble those of bleeding disorders. Signs of physical abuse include, copyright inconsistency of clinical findings and history copyright atypical bruising patterns, example on back, forehead, ears, neck, and / or retinal hemorrhages in children. At superficial, petechial bleeding indicates defects of primary hemostasis, whereas large, palpable ecchymosis and deep tissue bleeding suggest defects of secondary hemostasis. And S. Diagnostics. Clinical assessment and basic laboratory testing are used to differentiate between primary and secondary disorders of hemostasis. Advanced testing is used to identify the specific disorder. Clinical assessment, 171 I-18-219. Scent symptoms ask about features of mucosal, skin, and deep tissue bleeding, see clinical features. Copyright quantify bleeding severity with a bleeding assessment tool. Back collapse find text outline. Scent features associated with bleeding disorders copyright known bleeding disorder in a family member, copyright chronic illness, example chronic kidney disease, liver disease, malignancy, autoimmune diseases, malabsorption copyright acute illness, example recent infections, use of mechanical circulatory support, 1 copyright poor nutritional status 1 pregnancy. Sepsis. Use of medications copyright antithrombotic agents, anticoagulants, antiplatelet agents copyright other drugs that can affect platelet function and / or count, including, equals chemotherapeutic agents equals NSAIDs equals phosphodiesterase inhibitors, example silostazol, sildenafil, theophylline, equals beta-lactam antibiotics equals antimycotics and antibiotics, example miconazole, nitrofurantoin, equals nitrates equals antidepressants. Most bleeding disorders are acquired, i.e., secondary to medications or associated with acute or chronic illness. 17. Women presenting with menorrhagia should also be evaluated by a gynecologist. Initial laboratory studies, 180-120 L1927. Scent indications copyright history or physical examination suggestive of a bleeding disorder * studies. OCBC, BMP liver chemistries O peripheral blood smear. Equals platelet clumping, suggests pseudothrombocytopenia equals schistocytes or other fragmented cells, consistent with microangiopathic hemolytic anemia, example thrombotic thrombocytopenic purpura, equals identification of blasts, suggests hematologic malignancies. Copyright coagulation panel including fibrinogen level, elevated PT/INR and/or APTT are suggestive of disorders of secondary hemostasis. O platelet function analysis, PFA abnormal platelet function, or, if not available, a prolonged bleeding time, suggests a disorder of primary hemostasis. A19O VWF antigen and VWF activity, VWF ristocedin activity for diagnosis of VWDA. Copyright von Willebrand disease is the most common inherited bleeding disorder, affecting up to 1% of the population. Von Willebrand factor concentration and VWF activity are now commonly part of initial diagnostic studies, 20127. Interpretation of laboratory findings in bleeding disorders, 8 Lee 201I28. Platelet PFA or bleeding defective pathway disorders count tingle PT/INRAPTT. Thrombocytopenia ed. Foot cent normal * normal disorders of primary H platelet dysfunction, example aspirin therapy chronic kidney cent normal, foot * normal. Extrinsic pathway, example factor 7 deficiency, * normal, F normal. D. Earstatia intrinsic pathway, example hemophilia, heparin therapy, normal cent normal 7. Intrinsic and extrinsic P, example I of 6 in K depend normal * normal, 7 T coagulation factors. Normal /T1 von Willebrand disease normal, TT cent normal 7 disorders of primary and secondary hemostasis D1 Laschen, DIC, EJF77F. 3. DIC is characterized by thrombosis, hemorrhage, and organ dysfunction and can be a medical emergency that requires immediate treatment. Copyright A detailed clinical assessment and initial laboratory studies are sufficient to diagnose the most common disorders of hemostasis, example platelet dysfunction secondary to medications or bleeding disorders associated with acute or chronic disease. OFE, XE. Treatment. Treatment should be guided by a specialist and target the specific cause of the bleeding. Occasionally, the transfusion of blood products may be indicated. For patients with acute or major bleeding, see management of acute bleeding below. Back collapse fine text outline. Disorders of primary hemostasis 331I34. Platelet transfusion. Scent used in the treatment of both thrombocytopenia and platelet dysfunction. Scent indications. Copyright active bleeding. Copyright prevention of bleeding during invasive procedures. Copyright prophylactically in patients with extremely low platelet count. 180L contraindications, uremic platelet dysfunction. Disease-specific treatment. Plus uremic platelet dysfunction 35. O preventative measures include dialysis, erythropoietin, and conjugated estrogens. 36 CE desmopressin, may be used prior to invasive procedures or to treat active bleeding. Copyright platelet transfusion is not indicated due to rapid inactivation of transfused platelets plus drug-related platelet dysfunction. 3 Copyright discontinue medications causing dysfunction. Copyright consider desmopressin. 1 Immune thrombocytopenia, treatment may include corticosteroids and IVIG. Platelet transfusion is typically ineffectual. Scent heparin-induced thrombocytopenia, stop all heparin and initiate an alternative form of anticoagulation. Scent HELLP syndrome, consult obstetrician immediately for specific management. Copyright 1 Random donor platelet unit typically increases platelet count by 5,000-10,000/mm in a 70 kg patient. 1 apheresis unit, the equivalent of 6 to 8 single units, increases platelet count by 30,000-40,000/mm, 37. Disorders of secondary hemostasis. Inherited coagulation factor deficiency 271. Scent depending on the etiology, treatment can include one or more of the following. Copyright blood product transfusions or replacement of specific coagulation factors, e.g., equals factors 8, 9, or 11, example for hemophilia, equals concentrates containing VWF and factor 8, for VWD, Copyright pharmacological therapy, example desmopressin, antifibrinolytics, see treatment in hemophilia and in von Willebrand disease for specific recommendations. Acquired coagulation factor deficiency plus vitamin K deficiency, 3-degree copyright dietary deficiency equals vitamin K replacement, phytonadione equals optimize enteral or parenteral nutrition. Copyright associated with anticoagulant use, see anticoagulant reversal for specific recommendations. Plus liver disease, complex management 891L40141 copyright consider vitamin K replacement for patients with abnormal coagulation studies. 1421/40. The effect of liver disease on hemostasis is complex. The clinical effects of thrombocytopenia and reduced coagulation factor synthesis are often negated by a simultaneous decrease in the production of profibrinolytic factors. Bleeding often does not occur, even if the laboratory values of hemostasis are markedly abnormal. 39. WA. OOES. Lee management of acute bleeding. Management, 171. Scent start ABCDE approach and stabilize the patient as needed. Scent assess the need for anticoagulant reversal, discontinue ongoing anticoagulants and platelet inhibitors, unless contraindicated. Scent start transfusion of blood products if needed, see also massive transfusion. Copyright PRBCS, target HB using a liberal or restrictive transfusion strategy. O platelet transfusion, for thrombocytopenia or as part of a massive transfusion protocol. O fresh frozen plasma, FFP, cryoprecipitate-1, as part of massive transfusi WWE FA art. Back collapse fine text outline. Rotocol or to replace coagulation factors and / or fibrinogen. Disorders of secondary hemostasis. Inherited coagulation factor deficiency 271. Scent depending on the etiology, treatment can include one or more of the following: copyright blood product transfusions or replacement of specific coagulation factors, e.g., equals factors 8, 9, or 11, example for hemophilia, equals concentrates containing VWF and factor 8, for VWD, copyright pharmacological therapy, example desmopressin, antifibrinolytics, Scent see treatment in hemophilia and in von Willebrand disease for specific recommendations. Acquired coagulation factor deficiency plus vitamin K deficiency, 38 copyright dietary deficiency equals vitamin K replacement, phytonadione equals optimize enteral or parenteral nutrition. Copyright associated with anticoagulant use, see anticoagulant reversal for specific recommendations. Liver disease, complex management 891L40LL41 copyright consider vitamin K replacement for patients with abnormal coagulation studies. 1421I40. The effect of liver disease on hemostasis is complex. The clinical effects of thrombocytopenia and reduced coagulation factor synthesis are often negated by a simultaneous decrease in the production of profibrinolytic factors. Bleeding often does not occur, even if the laboratory values of hemostasis are markedly abnormal. 82. GPVU. 5. LL, management of acute bleeding. Management, 171. Start ABCDE approach and stabilize the patient as needed. Assess the need for anticoagulant reversal, discontinue ongoing anticoagulants and platelet inhibitors, unless contraindicated. Copyright PRBCS, target HB using a liberal or restrictive transfusion strategy. Copyright platelet transfusion, for thrombocytopenia or as part of a massive transfusion protocol. O fresh frozen plasma, FFP, cryoprecipitate-1, as part of massive transfusion protocol or to replace coagulation factors and / or fibrinogen. Copyright prothrombin complex concentrate, 44145 consider replacement of specific coagulation factors. Copyright known hemophilia, factors 8, 9, or X. Copyright known von Willebrand disease, VWD concentrates containing VWF and factor 8 consider adjuvant drug. Therapy depending on suspected etiology. Copyright anticoagulant reversal, example vitamin K, phytonadione, 38. Copyright desmopressin 1/4 cents. Copyright antifibrinolytics, example for hyperfibrinolysis. Registered diagnostics should not delay factor replacement therapy in patients with known bleeding disorders presenting with major bleeding. 471, 481-49. Copyright patients with a suspected disorder of secondary hemostasis presenting with major bleeding can benefit from the transfusion of fresh frozen plasma while diagnostic studies are performed. 17. Diagnostics, 171. Routine testing OECBC with blood smear, BMP liver chemistries, and type and cross-copyright coagulation studies. Obtain a coagulation panel and measure VWF and VWF activity. YS, VHA is a point-of-care test with rapid results that provides a comprehensive assessment of hemostatic function, 50 LLS 11L52I. Back collapse. Fine text outline. Urohemostasis and bleeding disorders, 1/4. Registered initiation at activation at aggregation Y. II vasoconstrictor GE platelet WF1 ACOVE, COCOX ES, MTXA, damaged vascular /JAWPI endothelium /4/Follianon. IF promotes /SPLLB /platelet ADP, P2Yen12, RU exposed collagen H /NGN aggregation plus. 2. Adhesion ADIPAF equals N_YGPIBRWY. VL. VL equals CAE equals E, and PEBSA. SWS platelet plug 4, equals. Primary hemostasis VV. 1. Tissue injury results in the release of von Willebrand factor, VWF, from Weibel-Palade bodies, WPB, in endothelium and granules in platelets. VWF subsequently binds to exposed collagen at the site of injury. Vasoconstriction, not shown here, occurs through both a neural stimulation reflex and a release of endothelin from damaged endothelial cells. 2. Platelets bind to exposed VWF at the site of injury and undergo a conformational change. 3. Activated platelets release a combination of factors, including adenosine diphosphate, ADP, calcium ions, Ca2*, and platelet activating factor, PAF. ADP binds to P2Y12 receptors on platelets, inducing a translocation of GPLLB/ILA receptors to the cell surface. These receptors are promoted by Ca2* ions. 4. The expression of GPLLB/ILA receptors allows activated platelets to cross-link with fibrinogen as an intermediary. The action of PAF along with thromboxane A2, TXA2, further promotes platelet aggregation. Platelet pluas are reinforced with fibrin during a secondary hemostasis. Binding to VWF thrombin. 1 Shape of inactive and active platelet. VV sketches of platelets as seen on electron microscopy. Prior to activation, platelets have a discoid shape. When platelets become activated by von Willebrand factor or thrombin, they develop cytoplasmic, dendritic projections, which are called pseudopodia. They increase the platelet's surface area, which facilitates adhesion to endothelial lesions. Copyright Unpack. Extrinsic pathway. Intrinsic pathway 7x9x /LA-XL trauma collagen, basement membrane, activated platelets. Tissue SLA. Villa WM, 9 and phospholipids required 8 combined pathway activation by VV thrombin. XA_VAJ. 7 fibrinogen prothrombin thrombin. Y fibrin AL, equals ALA equals. Cross-linked fibrin. Secondary hemostasis VV. Copyright Unpack. And hemostasis and bleeding disorders, 4/4. Anticoagulation procoagulation VVVIT811X** equals X*. Cascade of clotting factors. Prothrombin ** prothrombin. C. Heparin. Antithrombin 3. APC complex and equals CRA. Protein S seals. Protein C, APC. Thrombin. TF. QEOS. Y//fibrinogen VL degradation. TPA plus. Urokinase 4. A. Plasminogen. Procoagulation-anticoagulation balance. Thrombomodulin. Protein C fibrin degradation products. Asterisk vitamin K-dependent synthesis in liver. Clotting homeostasis is maintained through a balance of procoagulation, purple, and anticoagulation, gray, processes. The procoagulation pathway ultimately results in the enzymatic conversion of fibrinogen into fibrin, which is an integral part of blood clot formation. The procoagulation pathway is physiologically inhibited through two distinct anticoagulation pathways, using either antithrombin 3 or the APC complex. Antithrombin IL inactivates factors 9, X, and thrombin. This process is accelerated in the presence of heparin. Additionally, antithrombin IL indirectly increases the activation of plasmin through the action of tissue plasminogen activator, TPA, resulting in the degradation of both fibrinogen and fibrin. The APC complex pathway involves the activity of thrombomodulin, a membrane protein expressed on endothelial cells that activates protein C. Activated protein C then binds to protein S to form the APC complex, which inactivates procoagulation factors V and 8. The procoagulation factor thrombin can also activate protein C, which results in a negative feedback loop on the procoagulation pathway. It physiologically used pharmacologically. Plasminogen. TPA, alteplase, copyright. Pi, plasminogen activator inhibitor. Urokinase, plus. 4-SELLASVS prekallikrein equals kallikrein. Prurokinase. WEESAIMIA N4XNRs 3F // fibrinogen degradation products A / of. Mechanism of action, thrombolytic drugs. Copyright Boss. J. Plasmin. Equals LLA, Zilla. 4. RTPA, reteplase, tenecteplase. ROA2 antiplasmin. Fibrin degradation products AR. Adhesion. Bernard-Soulier syndrome IES27 NVL, damaged vascular /S $equals 2Y endothelium of 4s, X von Willebrand, smiley face, 16 GPBRA at disease. SE, O exposed collagen. Aggregation fibrinogen sent /Glanzman, /thrombasthenia GPLLB/ILA R. WYLAA, ES. W7. Congenital disorders affecting primary hemostasis VV red indicators link syndromes with their associated defective or absent molecules, according to which phase of primary hemostasis is affected, i.e., adhesion or aggregation. Copyright Boss. INCC Antadhere NRE Dean. Hemophilia B. Intrinsic pathway liver AE. Uncarboxylated, precursor factors vil liver cirrhosis O-IL, 7, 9, XIL, 7, 9, X. New York, XL. Y-glutamine vila carboxylase equals XA. Hemophilia C combined pathway vila vitamin K EAENEE/OUH oxidized vitamin K reduced vitamin K deficiency, inactive, active, 7XA7 hemophilia A. Epoxide reductase prothrombin thrombin LLA fibrinogen. Fibrin law. Disorders of secondary hemostasis VV. Copyright Boss. Hemostasis and bleeding disorders, 1/2. Petechial bleeding due to thrombocytopenia. Source, copyright IMPP. Urohemostasis and bleeding disorders, 2/2. Impaired secondary hemostasis in lupus erythematosus VV. Diffuse ecchymoses are visible on the radial aspect of the forearm. The hemorrhage is extensive and diffuse, which indicates an impairment of secondary hemostasis. Specific antibodies that reduce factor VIII activity inhibit secondary hemostasis in individuals with systemic lupus erythematosus. Source: Copyright IMPP. MMGS $. And 60R, EAL. A 40 GOE. EE 320 plus 2 cents ESOOIM. Minus 207. 40 plus CT and Terry's CFT 60 plus. MCF 1 TT plus TT 0 15 30 45 60 75 90. Thromboelastogram, TEG, VV. Normal thromboelastogram with parameters. For thromboelastography, activators are added to a blood sample in order to induce and measure coagulation. Then firmness and elasticity of the clot are measured over time. Clotting time, CT, is the time until initial clot formation. Clot formation time, CFT, is the time from initial clot formation until reaching 20 mm in strength. The alpha angle is a measure of the pace of clot strengthening. The maximum clot strength is described by the maximum clot firmness, MCF. The parameters are used to examine blood coagulation. Source: Thromboelastometry Rotem by A1B2 Commons, Wikimedia Commons, licensed under CC by SA 4.0. Min. X. Thrombocytopenia. Thrombocytopenia is a platelet count below the normal range. Diagnosis should be confirmed with repeat testing, to rule out pseudothrombocytopenia, and underlying causes should be investigated and treated. Patients with active bleeding or neurological symptoms require emergency platelet transfusion, and in cases of immune-mediated etiologies, IVIG. Observation may be sufficient for patients who have stable medium-low platelet levels and no serious underlying condition. Patients with suspected ITP and low platelet counts, example. See also immune thrombocytopenia. OOAO. Etiology. Impaired platelet production in bone marrow. Bone marrow conditions megakaryocytes thrombopoiesis. Bone marrow failure, aplastic anemia, paroxysmal nocturnal hemoglobinuria, bone marrow suppression, drugs, example linezolid, daptomycin, valproic acid, valacyclovir, chemotherapy, radiation. Congenital thrombocytopenias, Wiskott-Aldrich syndrome, Alport syndrome, Bernard-Soulier syndrome, Fanconi anemia, von Willebrand disease. Other congenital conditions, Gaucher disease infection, CMV, EBV, hepatitis C virus, HIV, mumps and rubella, parvovirus B19, rickettsia, VZV, dengue. Malignancy, leukemia, lymphoma, bone marrow infiltration, myelodysplastic syndrome. Nutritional deficiency, vitamin B12 deficiency and/or folate deficiency, example in chronic alcohol abuse. One other, necrotizing enterocolitis. If platelet production is impaired, the number of megakaryocytes on bone marrow biopsy will also be decreased. Increased platelet turnover in the periphery. Immune thrombocytopenia, ITP, and other autoimmune diseases, example systemic lupus erythematosus, rheumatoid arthritis, disseminated intravascular coagulation, DIC, and sepsis. Thrombotic thrombocytopenic purpura, TTP, and hemolytic uremic syndrome, HUS, drug-induced immune thrombocytopenia, DITP. Platelet activating antibodies cause a hypercoagulable state and simultaneous reduction in platelet count. Copyright. The following drugs are most likely to be associated with DITP: L2F3 equals sodium channel blockers, quinine, class antiarrhythmics, example quinidine, valproate, carbamazepine equals calcium channel blockers, amlodipine equals antibiotics, linezolid, vancomycin, TMPSMX, penicillin, ceftriaxone, rifampin equals antiviral agents, ganciclovir, protease inhibitors, Example indinavir, zidovudine equals antithrombotic agents, glycoprotein IIB/ILA inhibitors, example abciximab, heparin equals others, oxaliplatin. Suramin, ibuprofen, mirtazapine OC also heparin-induced thrombocytopenia, HIT. Pregnancy, preeclampsia and HELLP syndrome, infection, see above, post-transfusion thrombocytopenia mechanical damage due to artificial cardiac valves or extracorporeal circulation, example dialysis. And increased peripheral turnover also increases numbers of megakaryocytes on bone marrow biopsy. Redistribution, dilution, and other causes. Liver disease and chronic alcohol abuse, decreased production of thrombopoietin in the liver, sent splenomegaly, sent gestational thrombocytopenia * thrombocytopenia following transfusion or fluid resuscitation pulmonary embolism or pulmonary hypertension 1. Primary homontony 3 references, 4 IL Alice IIS I8 11 I7 I8 equals QL. Collapse fine text outline. Clinical features. Clinical features according to platelet count 9 platelet count symptoms 91 mild * 70,000-149,999/mm. Typically, no abnormal bleeding, i.e., asymptomatic thrombocytopenia. Prolonged bleeding following surgery or trauma moderate * 20,000-70,000/mm. Easy bruising occasionally, petechiae and purpurae. Spontaneous bruising, ecchymosis, petechiae and purpura bleeding from the mucosa, example bleeding gums, or after minimal trauma increased risk of spontaneous, life-threatening bleeding severe AE, 20,000/mm. Plus see also clinical features of bleeding disorders, example bleeding gums, epistaxis, petechiae. Diagnostics. Approach, 1. Sent confirm the diagnosis in all patients, repeat CBC and compare with previous platelet counts. 1. Copyright consider peripheral blood smear to exclude pseudothrombocytopenia. Investigate for underlying causes with a thorough history and routine laboratory studies. If the etiology remains unclear, evaluate recent medication, see etiology. Copyright order additional investigations based on clinical suspicion, example evaluation for MDS or other malignancies in patients 60 years old with new-onset thrombocytopenia. Sent CITP if isolated thrombocytopenia with no other underlying cause detected. Do not delay treatment for diagnostic testing in patients with significant bleeding or new neurological symptoms. Routine laboratory studies 1. Sent CBC, J platelet count. Registered a rapidly falling platelet count is worrisome, even if it is within the normal range, example in HIT. G your note C registered shared. Differential diagnoses. See differential diagnosis of platelet disorders for a comparison of findings in various etiologies of thrombocytopenia. Plus pseudothrombocytopenia, a spuriously low platelet count due to platelet clumping in vitro, L121L13O platelet clumping can occur secondary to 14 pre-analysis collection factors. 1. Example sampling technique, choice of anticoagulant used in collection tubes 1. Delays in analysis, improper storage equals QL. Collapse fine text outline. C. A rapidly falling platelet count is worrisome, even if it is within the normal range, example in HIT. GFFO, so. Differential diagnoses. See differential diagnosis of platelet disorders for a comparison of findings in various etiologies of thrombocytopenia. Plus pseudothrombocytopenia, a spuriously low platelet count due to platelet clumping in vitro, L121L13. Copyright platelet clumping can occur secondary to 14 equals pre-analysis collection factors. 1. Example sampling technique 1. Choice of anticoagulant used in collection tubes _ 1. Delays in analysis, improper storage disease factors 1. Example presence of antibodies to EDTA anticoagulant, autoimmune and inflammatory conditions, example cold agglutinin disease, neoplastic disease, example multiple myeloma, viral infections, drugs, example chemotherapeutic agents, scent dilutional thrombocytopenia. Falsely low platelet concentration due to volume overload, typically affects all other cell counts, i.e., associated dilutional anemia and leukopenia. The differential diagnoses listed here are not exhaustive. PV. Shat. Treatment. Patients with thrombocytopenia may be asymptomatic or acutely unwell if the thrombocytopenia is a feature of a wider syndrome such as DIC or TTP. Management depends on symptoms, initial platelet count, and the underlying condition. Approach, 115. Send all patients copyright treat any significant bleeding, see emergency management of thrombocytopenia. O treat underlying cause, see etiology. Equals immediately treat serious or life-threatening underlying illnesses, see treatment in TTP, HIT, HUS, and DIC. Equals benign or mild illnesses may resolve spontaneously. Copyright consider empiric treatment for ITP, example corticosteroids, IVIG, if platelet count. Emergency management of thrombocytopenia, 76-15. Sent indications copyright neurological symptoms OE anticipated urgent surgery or invasive procedures copyright significant bleeding sent treatment O if there is bleeding, attempt hemostatic control. 10 urgently replace platelets. Equals immediate platelet transfusion equals if an immune cause is suspected, administer IVIG, prior to transfusion. 1. DS. Tips and links. Sources. Last updated November 9, 2023 equals AL. Collapse fine text outline. Petechial bleeding due to thrombocytopenia. Source, copyright IMPP. Purpura in Waterhouse-Friderichsen syndrome. Purple non-blanching macules of various sizes, consistent with purpura, larger macules, and petechiae, smaller macules, is visible. These findings are consistent with purpura in Waterhouse-Friderichsen syndrome. Source, copyright IMPP. Urothrombocytopenia, 1/1. Copyright overlay. Pseudothrombocytopenia microscopic image of a blood smear from EDTA blood of a patient with isolated thrombocytopenia in addition to individual platelets, arrowhead, further platelets are visible clustered and clumped together, highlighted in red. These findings are typical of EDTA-induced pseudothrombocytopenia. Source, Fig 2b, in Pseudothrombocytopenia due to platelet clumping, a case report and brief review of the literature by Geok-Chin Tan, Melissa Stalling, Gretchen Dennis, Maria Nunez, Samir B. Kawash, Hindawi, licensed under CC by 4.0. X. Immune thrombocytopenia. Immune thrombocytopenia, ITP, is a type of thrombocytopenia involving the formation of autoantibodies against platelets. ITP may be a primary disease or occur secondary to a known trigger, example SLE, HIV, hepatitis C, medications. It is commonly seen in children as a self-limiting illness following a viral infection, and in adults as a chronic illness. Most patients are asymptomatic, however, patients may occasionally present with minor mucocutaneous bleeding, example petechiae, purpura, epistaxis, or, rarely, with severe bleeding, example gastrointestinal or intracranial hemorrhage. Treatment recommendations vary depending on the presence and severity of symptoms. First-line medical therapy consists of corticosteroids, IVIG, or anti-D immunoglobulin, and is indicated for patients with non-life-threatening symptoms affecting their quality of life, and for adults with little to no symptoms and platelet counts below 30,000/mm. Children with little to no symptoms can typically be managed with observation alone regardless of platelet count. Second-line treatments, i.e., thrombopoietin receptor agonists, rituximab, splenectomy, may be required for refractory, persistent, or chronic cases. Patients with life-threatening hemorrhage, neurological symptoms, or those requiring urgent surgical interventions should receive immediate combination medical therapy, i.e., corticosteroids plus IVIG, along with platelet transfusions and hemostatic control interventions when necessary. See also thrombocytopenia. OOFA, Cs. Definition. Immune thrombocytopenia has previously been referred to as idiopathic thrombocytopenic purpura, however, this term is outdated. J. Sent primary immune thrombocytopenia, an autoimmune disorder characterized by isolated thrombocytopenia, 12 months. OOCE. Epidemiology. Plus prevalence, up to 10 per 100,000, 3,141 copyright 2003 cent children copyright highest prevalence in children 55 years of age 3 copyright 80% of patients develop chronic ITP. 5 copyright an incidental finding on a routine CBC in 25% of cases 6 epidemiological data refers to the US, unless otherwise specified. WR. OE. Etiology. Sent primary ITP, idiopathic, most common, 17 cent secondary ITP associated with, O autoimmune disorders, SLE, antiphospholipid syndrome O malignancy, lymphoma, leukemia, particularly CLL, copyright infection, HIV, HCV/O drugs, example quinine, beta-lactam antibiotics, carbamazepine, heparin, vaccines, linezolid, sulfonamides, vancomycin, TMPSMX, antiepileptics, 8. OOE. Pathophysiology. Antiplatelet antibodies, mostly IgG directed against, example GPLLB/ILA, GPLB/9, bind to surface proteins on platelet sequestration by spleen and liver platelet count bone marrow megakaryocytes and platelet production increase in response, in most cases, -9. Back collapse find text outline. Clinical features. Clinical features can correlate with platelet count, see also clinical features of thrombocytopenia and clinical features of bleeding disorders. Most commonly asymptomatic copyright splenomegaly is typically absent. 20 minor mucocutaneous bleeding, less common, O subcutaneous, example bruising, petechiae, purpura copyright mucosal, example mild epistaxis, gingival bleeding sent other types of bleeding, rare, copyright gastrointestinal, E.G., melena copyright genitourinary, example hematuria, menorrhagia copyright CNS, example features of intracranial hemorrhage copyright prolonged or excessive traumatic or surgical bleeding. And splenomegaly is very unusual in ITP and makes other diagnoses more likely. QB There should be suspicion for ITP in a child with thrombocytopenia and petechiae following a viral illness. WAOOAO. Diagnostics. ITP is a diagnosis of exclusion. Patients typically have a low platelet count with no other abnormalities. 5 laboratory studies, 11 I10L12. Routine. *CBC, platelet count. Additional investigations. All adults, HIV and HCV screening, sent bone marrow biopsy copyright consider in atypical cases or if there is diagnostic uncertainty, copyright findings, normal or T megakaryocytes 5 additional testing as required, consider in suspected secondary ITP example anti-nuclear antibodies in SLE or H. pylori testing if the patient has GI symptoms or is from a high prevalence area. O. Differential diagnoses. See differential diagnosis of platelet disorders. The differential diagnoses listed here are not exhaustive. OOE. Treatment. Approach. These recommendations are consistent with the 2019 American Society of Hematology ITP guidelines and the 2019 International Consensus Report on Primary ITP Investigation and Management. 1. 4LL15. Management approach for ITP. 14 IIS management newly diagnosed ITP persistent or chronic ITP. Back collapse fine text outline. Approach. These recommendations are consistent with the 2019 American Society of Hematology ITP guidelines and the 2019 International Consensus Report on Primary ITP Investigation and Management. 1. 4LL15. Management approach for ITP. 14T5 management newly diagnosed ITP persistent or chronic ITP. Identify and treat underlying causes. All patients consider stopping medications that impair platelet function, example NSAIDs. Attempt hemostatic control if bleeding is present. Patients requiring emergency treatment, EQG/EVA. Start combination therapy, 7 life-threatening bleeding. Copyright corticosteroids, example methylprednisolone. Degree acute neurological features. Degree plus intravenous immunoglobulin, IVIG, plus anticipated urgent surgery or invasive. Copyright plus platelet transfusions as needed. EDI, proficient. If no response, consider a thrombopoietin receptor agonist, TPORA, example romiplastim. Conservative management preferred for patients with copyright adults with a platelet count equals 30,000/mm. No symptoms. Copyright children with any platelet count degree only. Minor mucocutaneous bleeding. First line medical therapy, indicated for adults with platelet count. Copyright indicated for adults. Copyright can be considered in children. Consider subsequent therapeutic options if refractory to first line medical therapy. Conservative management, 41I15. Sent indications for observation. Copyright children, no symptoms or only mild mucocutaneous bleeding with any platelet count Adults, no symptoms or minor mucocutaneous bleeding with a platelet count of equals 30,000/mm. Plus all patients, refer to hematology for regular monitoring and counseling on bleeding risks. First line medical therapy, 14I15. Plus preferred, corticosteroids, 17-eodexamethasone. Copyright or prednisone plus alternatives, if contraindication, non-response, or intolerance to corticosteroids. Copyright intravenous immunoglobulin, IVIG, copyright or anti-Ro-D, immunoglobulin. Anti-Ro-D, immunoglobulin can cause potentially fatal intravascular hemolysis in patients with ITP. Close monitoring is recommended. Subsequent therapeutic options, 15. The following options should be considered in consultation with a specialist for patients with newly diagnosed ITP refractory to first-line medical therapy, or persistent/chronic ITP. Thrombopoietin receptor agonists, TPORAs, copyright romiplastim. Copyright L-thrombopoxent rituximab. Splenectomy. Copyright indications. Treatment-resistant thrombocytopenia lasting 12 months, equals severe bleeding that does not respond to any other treatment. Copyright procedure, minimally invasive laparoscopic surgery is preferred. OE complications, see asplenic sepsis. Copyright prevention of complications, see management of asplenic patients. OE. Tips and links. Sources. Last updated September 11, 2023. Back collapse fine text outline. X. Hemophilia. Hemophilias are disorders of blood clotting and consequently may lead to serious bleeding. In the majority of cases, these disorders are hereditary. There are 3 types of hemophilia, determined based on which clotting factor is deficient: hemophilia A, factor 8, hemophilia B, factor 9, and hemophilia C, factor 11. All types result in impaired secondary hemostasis, plasmatic coagulation, that manifests as increased activated partial thromboplastin time, APTT. Hemophilia presents with hemarthrosis, bleeding into joints, and muscular or soft tissue hematomas. Depending on the remaining clotting factor activity, Bleeding may occur spontaneously or in response to trauma of varying severity. Repeated hemarthrosis can eventually lead to joint destruction, a serious long-term complication of hemophilia. Diagnosis is based on patient history and a mix of semi-quantitative and quantitative measurements of clotting factor activity. Severe hemophilia, enzyme activity. With prophylactic substitution of clotting factors, whereas mild hemophilia A, in particular, can also be treated with desmopressin, a synthetic vasopressin analog. O. Epidemiology. Affects 1/5,000 male births. Average age at diagnosis is 1 month for people with severe hemophilia, 8 months for people with moderate hemophilia, and 36 months for people with mild hemophilia. Epidemiological data refers to the U.S., unless otherwise specified. WY/OE. Etiology. Hemophilia is caused by an X-linked recessive defect, inherited or spontaneous mutation, or antibody production against clotting factors. Hemophilia A, factor VIII deficiency 80% of cases sent. Hemophilia B, factor IX deficiency 20% of cases. Hemophilia C, factor XI deficiency very rare, increased frequency in the Ashkenazi Jewish population, caused by an autosomal recessive defect. And hemophilia usually affects males, as it is primarily an X-linked recessive disease. Clinical features: spontaneous bleeding or delayed onset bleeding, joints, muscular and soft tissue, mucosa, in response to different degrees of trauma or repeated hemarthrosis, example knee joint, hemophilic arthropathy, i.e., destruction of the joint due to repeated hemarthrosis, equals typically develops by early adulthood, equals most commonly involves the knees, ankles, and elbows. Copyright recurrent bruising or hematoma formation. O. Oral mucosa bleeding, epistaxis, excessive bleeding following small procedures, example dentist procedures. O. Hemophilia C does not typically manifest with spontaneous bleeding, hemarthrosis, or deep tissue bleeding. 2e. Further signs/symptoms of hemorrhage, OCNS, example headache, neck stiffness, copyright gastrointestinal tract, example melena, hematmesis, copyright genitourinary system, example hematuria. Female carriers may show mild symptoms. The degree of bleeding and, therefore, severity of hemophilia depends on residual factor activity levels. Normal reference activity is 50%. Severity. Clinical signs: factor VIII or IX activity, mild hemophilia, hematomas following severe trauma 5% to C2. Petechial bleeding is a common sign of platelet disorders, but not of coagulation disorders such as hemophilia. SE4. Back collapse. Find text outline. Further sites/symptoms of hemorrhage, copyright CNS, example headache, neck stiffness, gastrointestinal tract, example melena, hematmesis, copyright genitourinary system, example hematuria. Female carriers may show mild symptoms. The degree of bleeding and, therefore, severity of hemophilia depends on residual factor activity levels. Normal reference activity is 50%. Severity. Clinical signs: factor VIII or IX activity, mild hemophilia, hematomas following severe trauma 5% to QB. Petechial bleeding is a common sign of platelet disorders, but not of coagulation disorders such as hemophilia. Diagnostics. Patient and family history. Genetic testing. 1e. Screening. Copyright prothrombin time, normal. Copyright platelet count, normal. Copyright activated partial thromboplastin time, APTT usually prolonged plus if APTT prolonged. Mixing study, if mixing study is positive, or if patient/family history are strongly positive. Quantitative assessment of factor activity levels. Differential diagnosis. See diagnostics in hemostasis and bleeding disorders. WA. CES. Treatment. Substitution of clotting factors. Copyright mild or moderate hemophilia, when needed, example trauma or surgery. Copyright severe hemophilia, prophylactic, Additional substitution may be needed in, example trauma, copyright substitution of Factor 8 concentrate for hemophilia A, 3 Factor 9 concentrate for hemophilia B, Factor 11 concentrate for hemophilia C. Desmopressin equals indication, mild hemophilia A equals synthetic analog of vasopressin equals triggers the release of BWF from endothelial cells, which leads to an increase in Factor 8 plasma concentration CF. 4. Scent antifibrinolytic therapy, example S-aminocaproic acid, tranexamic acid, used in addition to factor substitution, example if surgery is performed. In the oral cavity, copyright inhibits the breakdown of clots to reduce the risk of bleeding. Scent emicizumab description, a humanized monoclonal bispecific antibody that reduces the risk of bleeding events. Copyright therapeutic use, hemophilia A mechanism of action, bridges activated factor 9 and factor X by binding to both factors, thereby replacing the deficient factor 8. Activation of factor X restored clotting cascade. A degree. Sources. Last updated March 23, 2022. Back collapse fine text outline. RAR ETE settles 5. Hemophilia B. Intrinsic pathway liver extrinsic pathway, Zilla 12. Uncarboxylated A. Precursor factors Factorsville. Liver cirrhosis O-IL, 7, 9, XIL, VIL, 9, XSV XLA XL. Y-glutamyl carboxylase IXA. Hemophilia C. Combined pathway VIL vitamin K ARPTase OE deficiency O oxidized vitamin K reduced vitamin K, inactive, active. XA-VIL, hemophilia A. Epoxide reductase prothrombin plus thrombin LLA fibrinogen. Fibrin law. Disorders of secondary hemostasis VV. Copyright Boss. Hemarthrosis of the knee VV. The left knee is grossly enlarged with purple-brown discoloration. There is also an oblique scar spanning lateral to medial, likely due to previous knee replacement surgery. These findings are consistent with a periprosthetic hemarthrosis. Source, Figure 2, severe hemarthrosis of the left knee after 16 days of tigecycline administration by Theodore Balfusias, Alexandros P. Apostolopoulos, Stavros Angelos, Spiridon Maris, Athanasios Papanikolaou, The Curious Journal of Medical Science, licensed under CC by 3.0. Urohemophilia, 2 halves. UD date. IRN, study date. DY time, study year. MRN, _, LA, C7121A/43900. Hemarthrosis in hemophilia BV. MRI knee, T2 weighted, left, coronal plane, right, sagittal plane. A large joint effusion with suprapatellar extension is accompanied by high signal intensity representing hemorrhage, black arrows, and intermediate to low signal intensity representing synovial thickening, white arrow. Hemarthrosis is a common occurrence in patients with severe hemophilia. Source, Figure 1. Prevention of the musculoskeletal complications of hemophilia by E.C. Rodriguez Merchan, Advances in Preventive Medicine Journal, licensed under CC by 3.0. Modifications, image cropped. Acute leukemia. Acute leukemias are malignant neoplastic diseases that arise from either the lymphoid or myeloid cell line. Acute lymphoblastic leukemia, ALL, is the most common childhood malignancy, whereas acute myeloid leukemia, AML, primarily affects adults. The underlying cause of acute leukemia is rarely identifiable, but risk factors include prior chemotherapy and radiation therapy, and hereditary syndromes such as Down syndrome. AML is also associated with pre-existing hematologic disorders, example myelodysplastic disorder, myeloproliferative disorders. Acute leukemias are characterized by the proliferation of immature, non-functional WBCs, blasts, in the bone marrow, which impairs normal hematopoiesis. This leads to pancytopenia, which manifests with symptoms and signs of anemia, decreased RBCs, clotting disorders, decreased platelets, and immunocompromise, decreased fully functional, mature WBCs. Patients with acute leukemia, especially those with AML, may develop extremely high WBC counts, increasing the risk of leukostasis and disseminated intravascular coagulation, DIC. Leukemic cells can also infiltrate extramedullary organs, resulting in hepatosplenomegaly, renal impairment, meningeal leukemia, and, less commonly, involvement of the skin and/or testicles. The first diagnostic steps include a complete blood count and peripheral blood smear to determine the patient's WBC count and assess for the presence of blasts. Bone marrow aspiration and biopsy are typically used to confirm the diagnosis, and subsequent cytogenetic analysis and immunophenotyping are used to identify subtypes and specific mutations. A chemotherapy regimen consisting of high-dose, induction, and low-dose, consolidation and maintenance cycles is the mainstay of treatment. Additional measures, such as allogeneic stem cell transplantation, may be indicated in patients with poor prognostic factors, example unfavorable cytogenetics, or if initial chemotherapy fails. CE. Epidemiology. Acute lymphoblastic leukemia I, peak incidence, 2 to 5 years. Most common malignant disease in children. 80% of acute leukemias during childhood are lymphoblastic. OD. Acute myeloid leukemia 2 peak incidence, 65 years. Copyright 80% of acute leukemias during adulthood are myelogenous. Epidemiological data refers to the U.S., unless otherwise specified. OOE. Etiology. Acute lymphoblastic leukemia, all. No identifiable cause or risk factors in most cases. * Prior bone marrow damage due to alkylating chemotherapy or ionizing radiation, plus adult T-cell leukemia/lymphoma is linked to infection with HTLV. SIL4LL5 sent genetic or chromosomal factors. Down syndrome, risk of all is, like that of AML, 10 to 20 times higher in patients with Down syndrome compared to the general population. 6LL7 Copyright neurofibromatosis type 1 Copyright ataxia telangiectasia. Acute myeloid leukemia, AML. Sent no identifiable cause or risk factors in most cases plus pre-existing hematopoietic disorder, most common identifiable cause, 8L. Myelodysplastic syndromes Copyright aplastic anemia. Myeloproliferative disorders, example osteomyelofibrosis, CML. Plus environmental factors 2, alkylating chemotherapy Copyright ionizing radiation. Benzene exposure degree Tobacco scent genetic or chromosomal factors. Down syndrome, the risk of AML is, like that of all, 10 to 20 times higher in patients with Down syndrome compared to the general population. 7 Fanconi anemia. Back collapse. Fine text outline. Classification. All. French American British, FAB, historical classification of all. OL1 all with small cells, 20 to 30%. OL2 all with heterogeneous large cells, 70%. OL3 all with large cells, i.e., Burkitt lymphoma, 1 to 2%. Plus the current WHO classification, 2016, classifies all into subtypes of precursor lymphoblastic leukemia/lymphoma based on morphologic and genetic factors. Copyright B lymphoblastic leukemia with recurrent genetic abnormalities equals all with BCRABL equals all with T, V, 11Q23, equals all with T, 1, 19, Q23, P13.3, equals all with T, 12, 21, P13, Q22, equals hyperdiploid 50 equals hypodiploid equals T, 5, 14, Q31, Q32, copyright B lymphoblastic leukemia, not otherwise specified. O precursor T lymphoblastic leukemia/lymphoma sent. Immunophenotype classification of all, based on the origin, B cell or T cell, and maturity of the leukemic cells. Copyright B cell all, 80 to 85% of cases, 11 equals early, pro B, all equals common, all equals precursor B, all equals mature B cell all, also known as Burkitt leukemia, 10 T cell all, 15 to 20% of cases, equals early, pro T, all equals intermediate T, all equals mature T cell all. www. AML. Sent the French-American-British, FAB, classification distinguishes between 8 subtypes of AML, according to the histopathological appearance of the cells. FAB classification for AML: MO AML acute myeloblastic leukemia without maturation, M1 AML acute myeloblastic leukemia with minimal granulocyte maturation, M2 AML acute myeloblastic leukemia with granulocyte maturation, M3 AML acute promyelocytic leukemia, APL, M4 AML acute myelomonocytic leukemia, M5 AML acute monocytic leukemia, M6 AML acute erythroid leukemia, M7 AML acute megakaryoblast leukemia. The WHO classification is based on various factors, example presence of genetic abnormalities or associations to prior chemotherapy/radiation. OAML with recurrent genetic abnormalities, example translocations, co-AML with myelodysplasia-related changes. Copyright therapy-related AML, OAML not otherwise specified, O myeloid sarcoma, O myeloid leukemia associated with Down syndrome. References, 81L121. OO. CE. Pathophysiology. Acquired somatic mutations, chromosomal translocations and other genetic abnormalities, in early hematopoietic precursors, clonal proliferation of A. Back collapse. Find text outline. Pathophysiology. Plus acquired somatic mutations, chromosomal translocations and other genetic abnormalities, in early hematopoietic precursors for, clonal proliferation of a lymphoid or myeloid stem cell line. Copyright and arrest in cell differentiation and maturation in early stages of hematopoiesis. Rapid proliferation of abnormal and dysfunctional blasts, with impaired apoptosis pathways, accumulation of leukemic white blood cells in the bone marrow. Disrupted normal hematopoiesis. Leukopenia, 1 risk of infections, thrombocytopenia, 1 bleeding, and anemia. Immature blasts enter the bloodstream equals infiltration of other organs, particularly the CNS, testes, liver, and skin. Clinical features. Clinical features are either related to bone marrow failure, infiltration of organs by leukemic cells, or a combination of both. Of acute, sudden onset of symptoms and rapid progression, days to weeks, OA anemia, fatigue, pallor, weakness. Thrombocytopenia, epistaxis, bleeding gums, petechiae, purpura. Immature leukocytes, frequent infections, fever. Hepatosplenomegaly, caused, 2, by leukemic infiltration. A. Oncologic emergencies can be the first sign of leukemia, example an elderly patient presenting with priapism or DIC may have leukostasis, more common in AML than all. See oncologic emergencies for further details. Clinical features of all clinical features of AML. Fever, night sweats, unexplained weight loss. OA. Painless lymphadenopathy plus bone pain, presenting as limping or refusal to bear weight in children, leukemia cutis, or myeloid sarcoma. Nodular skin lesions with airway obstruction, stridor, difficulty breathing, due to mediastinal or thymic infiltration, primarily in T cell all, 15, purple or gray-blue color loss. 16 *. Gingival hyperplasia, AML subtype M4 and M5, features of SVC syndrome. Signs of CNS involvement, example headache, visual field changes. Meningeal leukemia, or leukemic meningitis, plus headache, neck stiffness, visual field changes, or other CNS, uncommon, symptoms, caused by CNS involvement. Canine testicular enlargement, rare finding. At-end fever and lymphadenopathy are rare in AML, but can be common first signs in all. Diagnostics. Approach. Sent initial evaluation O suspect acute leukemia in patients with suggestive clinical or laboratory features. Copyright confirm the diagnosis with a morphological assessment. A. Sent further diagnostic studies, immunophenotype, cytogenetics, and molecular genetic testing should be obtained in order to identify the subtype of acute leukemia. At. In order to choose the best treatment strategy, the morphological assessment, immunophenotype, and genetic studies should be as comprehensive as possible. Back collapse fine text outline. Initial studies 18I191L20. Routine laboratory studies. Findings on initial laboratory studies are usually nonspecific but may help to identify potentially life-threatening acute complications. Sent complete blood count and peripheral blood smear. Degree platelets, typically mild to severe thrombocytopenia, 1. Hemoglobin, typically anemia peripheral blood smear, presence of blasts, immature WBCs, degree. Leukocytes, the white blood cell count, WBC, may be elevated, normal, or low and is not a reliable diagnostic marker. FF. Sent liver chemistries and renal function tests, may be abnormal, example secondary to disease infiltration, comprehensive metabolic panel and other metabolic studies O often abnormal due to increased cell lysis, see also tumor lysis syndrome. Copyright common findings include derangements of, equals sodium, hyponatremia or hypernatremia, 211L221 potassium, hypokalemia 5 or hyperkalemia 29 calcium, hypocalcemia 1 or hypercalcemia 1201L23, equals phosphate, hypophosphatemia 5 or hyperphosphatemia, 24 equals TLDH equals 1 uric acid sent coagulation studies, mild coagulopathy may be present. Studies may also help to identify features of DIC. Copyright unit. The identification of DIC suggests APL, which is a medical emergency. Consult hematology and/or oncology immediately and transfer the patient to a critical care. Confirmatory diagnostic tests, 181 250 120. Histopathological features should be assessed using bone marrow aspiration and biopsy. If unavailable, a peripheral blood smear may be sufficient. Histopathological features of acute leukemia all SS. Blasts, in bone marrow or peripheral blood, T1826*20% lymphoblasts. Small to intermediate-sized blasts 271 blasts with large, irregular nuclei, high nuclear cytoplasmic ratio cell morphology 25 atop. AD inconspicuous nucleoli coarse granules. No hour rods. AMLI. 20% myeloblasts presence of recurrent genetic abnormalities, regardless of the blast percentage copyright AML, T, 8, 21, INV, 16, or T, 16, 16, copyright APL, T, 15, 17. Large blasts, 2 to 4 times the size of an RBC, blasts with round or kidney-shaped nuclei that contain more cytoplasm than the blasts in all prominent nucleoli fine granules leukemic hiatus, the presence of blasts and mature leukocytes but no intermediate form CL. Some subtypes, especially M3, or APL, exhibit hour rods. A copyright pink-red, rod-shaped granular cytoplasmic inclusion bodies in malignant immature myeloblasts or promyelocytes. Degree myeloperoxidase, MPO, positive. Copyright selecting a treatment. Cell morphology can confirm the diagnosis of acute leukemia, but in most cases, it is necessary to complete immunophenotype and genetic studies before. Mysios murderiocyte, RE. Specialized studies. These studies are used to further characterize the cell line involved. Some characteristics may be associated with a better response to certain therapies. These studies should be ordered in consultation with a specialist. Immunophenotype and genetic studies 251L28LL191I20. equals PE and in acute findings in all findings in AML plus MPO negative MPO positive I high, HYTE deoxynucleotide Phi, TDT, positive asterisk TDT negative. IHEAP and G dyes in acute findings in all findings in AML. Cent MPO negative asterisk MPO positive Y asterisk terminal deoxyidal FF, TDT, positive asterisk TDT negative cent periodic acid SHIF, PA often positive asterisk PA negative. Immunophenotype B all is usually positive for 28 copyright CD10, Kala marker for immature B lymphocytes, pre-B, flow cytometry degree CD19 degree CD20. The majority of subtypes are positive for CD13, CD33, CD34, CD117, and HLA-DR. T all is usually positive for CD2, CD8, especially CD3. Philadelphia translocation, present in 20 to 30% of adults with all but only 5% of children with all BS, 29, equals, SAIGHEGAEERE and CENT-T, 1517, especially in acute promyelocytic leukemia cytogenetics, karyotype, EANS, M3AML, FISH, copyright T, 12, 21 most common specific abnormality, Philadelphia translocation, rare, 301 copyright trisomy 4 and 10, associated with a good prognosis genetic studies hyperdiploidy is common in pre-B all. BCRABL1 in confirmed or suspected B all potential findings in childhood B all include, copyright T, 12, 21, P13.2, Q22.1, copyright ETV6 RUNX1. FLT3-ITD, associated with a poor prognosis 1 PML rara in patients with APL molecular testing, PCR, HAL. And myelogenous leukemias are myeloperoxidase positive. Screening for extramedullary disease, 181-191 I31. Consider the following studies to detect extramedullary disease based on the subtype of acute leukemia and clinical evaluation of the patient. Asterisk CNS infiltration, common in all, 21 perform a lumbar puncture and obtain CSF flow cytometry. Copyright consider brain and spine CT or MRI. Cent testicular infiltration, relatively common in all testicular ultrasound. Cent thymic infiltration, primarily in T-cell all chest X-ray or CT chest may show a mediastinal mass. Cent hepatosplenic infiltration, abdominal CT or ultrasound may show organ enlargement. Cent other forms of extramedullary disease, consider PET CT and or lymph node biopsy. All patients with all should undergo screening for CNS infiltration. 7. 8. Treatment. Approach 251 I32 I33. The treatment of acute leukemia is decided by a hematologist-oncologist specialist depending on the specific subtype and results of molecular testing. Cent pre-treatment, all patients should have pre-chemotherapy screening as part of preparation for cancer treatment. Cent chemotherapy. Copyright systemic chemotherapy, the regimen of choice is based on individual patient and disease factors. 1. Copyright intrathecal chemotherapy, commonly used. Consider adding for patients with or at high risk of CNS infiltration, example all patients with all. Copyright targeted chemotherapy, consider adding for leukemias with specific immunophenotype and genetic profiles, example Philadelphia translocation. Cent adjunctive treatment, example radiation therapy, immunotherapy, or stem cell transplantation, SCT. Consider based on individual evaluation. Cent supportive care, provide holistic care to reduce symptoms and support patients and carers, see principles of cancer care. Management of complications, initiate monitoring, prevention, and early aggressive treatment as needed for infection, bleeding, pancytopenia, and oncologic emergencies, see management of complications. Early and aggressive chemotherapy improves the prognosis, example 80 to 90% of patients with all achieve complete remission with chemotherapy. 25. Systemic chemotherapy 221-331. Regimens vary depending on the subtype of leukemia, the age of the patient, and immunophenotype and genetic study results. Asterisk induction chemotherapy. Average duration for an adult with all is 4 to 8 weeks. Reinduction therapy may be required in case of relapse or failure of primary induction. Asterisk consolidation chemotherapy. Average duration for an adult with all is 4 to 8 months. Maintenance chemotherapy. Average duration for an adult with all is 2 to 3 years. Common agents used in CH-PI-REG for acute back collapse. Find text outline. IG 1825 120 32 133. Common agents used in CH-PI-REG for acute IA 1825 120 132 33. Alkylating agents, example cyclophosphamide anthracyclines, example daunorubicin, doxorubicin. Antimetabolites, example cytarabine, methotrexate, 6-mercaptopurine. Enzyme therapy, example L-asparaginase alkaloids, example vincristine glucocorticoids, example prednisone, dexamethasone. All anthracyclines, example idarubicin, high-dose daunorubicin. Antimetabolites, example cymethotrexate, hypomethylating agents, example azacitidine, AML. Differentiation agents, to induce the maturation of immature malignant WBCs. Atra, all-trans-retinoic acid, AEE. Copyright arsenic trioxide chemotherapy with anthracyclines, example idarubicin. QNAPL, the T15, 17, translocation and subsequent formation of the PML rare fusion gene can inhibit myeloblast differentiation under physiological levels of retinoic acid. High doses of Atra, a vitamin A derivative, may induce myeloblast differentiation and promote remission. Management of CNS infiltration 4113-1132. Sent intrathecal chemotherapy, administration of chemotherapeutic agents, example triple therapy with methotrexate, cytarabine, and hydrocortisone, directly into the subarachnoid space via lumbar puncture or using an intraventricular catheter with a reservoir placed under the scalp. Copyright indications in all. Prevention of leukemic meningitis in all patients at the time of diagnosis. 1, 18 LL33 IL20. Copyright indications in AML equals treatment of patients with confirmed CNS infiltration. Prevention in patients with high-risk APL35 sent CNS radiotherapy. Consider directed radiation therapy alongside intrathecal chemotherapy in select patients. Advanced therapies 31125. Sent targeted therapy, non-standard chemotherapy or immunotherapy is indicated if certain mutations or markers are detected. Copyright tyrosine kinase inhibitors, TKIs, equals Philadelphia chromosome positive all, BCRA Blutkiss, example imatinib, ponatinib, FLT3 ITDAML, consider midostaurin, S-Cent. Autologous or allogeneic stem cell transplantation, indications include patients with poor prognostic factors, example unfavorable cytogenetics, and those who do not achieve remission with chemotherapy. See transplantation for more information. 25. Management of complications, 25. Sent oncologic emergencies. Copyright tumor lysis syndrome, TLS, equals management, typically includes fluid therapy, oral or 4, and rasburicase equals prophylaxis, consider hydration, and urate lowering therapy, i.e., allopurinol or rasburicase. Leukostasis, example due to hyperleukocytosis, consider for fluid resuscitation and or cytoreductive therapy. Copyright see oncologic emergencies for details. Sent treatment-related complications. Copyright anti-cancer therapy-induced myelosuppression, anemia, thrombocytopenia, and neutropenia. 7 balls 8, degree mucositis 89. Copyright see anti-cancer treatment-related complications and neutropenic fever for details. Sent secondary hyperuricemia. Copyright can lead to acute gout, uric acid stones, and urate nephropathy. Copyright consider hydration, fluid administration, and urate lowering therapy, example allopurinol and rasburicase, as prophylaxis prior to chemotherapy. OOS. Complications. Scent tumor lysis syndrome, scent leukostasis, scent see also. Degree oncologic emergencies, complications of cancer, complications of anti-cancer therapy. Copyright neutropenic fever. Degree. We list the most important complications. The selection is not exhaustive. Back collapse, find text outline. X acute leukemia. Oncologic emergencies. Copyright tumor lysis syndrome, TLS, equals management, typically includes fluid therapy, oral or 4, and rasburicase equals prophylaxis, consider hydration, and urate lowering therapy, i.e., allopurinol or rasburicase. Copyright leukostasis, example due to hyperleukocytosis, consider 4 fluid resuscitation and / or cytoreductive therapy. EC oncologic emergencies for details. Scent treatment related complications, anti-cancer therapy induced myelosuppression, anemia - thrombocytopenia, and neutropenia. 3738 mucositis 89 OC anti-cancer treatment related complications and neutropenic fever for details. Scent secondary hyperuricemia. Copyright can lead to acute gout, uric acid stones, and urate nephropathy. Copyright consider hydration, fluid administration, and urate lowering therapy, example allopurinol and rasburicase, as prophylaxis prior to chemotherapy. 47. CE. Complications. Scent tumor lysis syndrome, scent leukostasis, scent see also. Degree oncologic emergencies, complications of cancer, complications of anti-cancer therapy. O neutropenic fever. Degree. We list the most important complications. The selection is not exhaustive. OI, 4L. OAO. Prognosis. 5-year survival rate following treatment. Scent all. The 5-year survival rate is generally higher compared to AML, varies from 20% in elderly patients to 80% in children and adolescents. Scent AML, 30%, but it varies according to the patient's age. The survival time has increased more recently due to improvements in treatment. Unfavorable prognostic factors. All AML. Age * 10 years greater than 60 years. WBC count 50,000/mm $1 LDH disease features 4 CNS involvement at diagnosis Fab M7, acute megakaryocytic leukemia. Various translocations, example T6, 9, karyotype abnormalities, example trisomy 8, monosomy 5 or 7, FLT3 gene mutation, complex pattern of aberrations, i.e., 3 aberrations. Philadelphia chromosome T9, 22, 1 hypoploidy, complex pattern of aberrations, 3 aberrations, cytogenetics. / mature B cell all 1 * CD34 genotyping scent precursor T cell all MDR1. Favorable prognostic factors. All AML *. QB to remember that translocation T12, 21, commonly manifests with pediatric B-ALL and usually has a favorable outcome. Think, kids flip back to health. The number 12 is 21 flipped around. References 41 Lajlaslialiasi 4. Back collapse, find text outline. Euroacute leukemia, 1/5. E8. 5 pounds AEI Wisplinghoff Laboratories. Copyright. Overlay. B-cell acute lymphoblastic leukemia VV. Photomicrographs of a peripheral blood smear, H&E stain, very high magnification. The large basophilic cell in the center of each photomicrograph is a lymphoblast, identifiable by its large spherical nucleus surrounded by a thin rim of cytoplasm, high nucleocytoplasmic ratio. The nucleus of the lymphoblasts is often indented, green arrows, and shows fine loose, non-condensed, chromatin. Lymphoblasts differ from lymphocytes, which are smaller in size with smaller nuclei, condensed chromatin, and more cytoplasm. The presence of numerous lymphoblasts in a peripheral blood smear is indicative of lymphoblastic leukemia. The diagnosis of B-cell ALL was confirmed on immunophenotyping. Note: basophilic remnants, Howell-Jolly bodies, are visible within the erythrocytes in the last photomicrograph, indicating, in this case, increased hematopoiesis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. E.J. Wisplinghoff Laboratories. T-cell acute lymphoblastic leukemia VV. Photomicrographs of a peripheral blood smear, H&E stain, very high magnification. The basophilic cell clusters in the center of each photomicrograph are mainly composed of lymphoblasts, identifiable by their large size, large spherical nucleus that is surrounded by a thin rim of cytoplasm, high nucleocytoplasmic ratio. The nucleus of the lymphoblasts is often indented and shows fine loose, non-condensed, chromatin. Lymphoblasts differ from lymphocytes, which are smaller in size with smaller nuclei, condensed chromatin, and more cytoplasm. The presence of numerous lymphoblasts in a peripheral blood smear is indicative of lymphoblastic leukemia. The diagnosis of T-cell ALL was confirmed on immunophenotyping. Note: basophilic remnants, Howell-Jolly bodies, are visible within some of the erythrocytes, indicating, in this case, increased hematopoiesis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euroacute leukemia, 3/5. E.S. E.J. Wisplinghoff Laboratories. Overlay. Acute monocytic leukemia VV photomicrographs of a bone marrow smear, H&E stain, very high magnification. The large basophilic cell visible in each photomicrograph is a monocyte, identifiable by its large size, folded or lobed nucleus with fine chromatin and prominent nucleoli, green overlay, and abundant granular cytoplasm with cytoplasmic vacuoles. Numerous monocytes on bone marrow biopsy is characteristically seen in acute monocytic leukemia. The diagnosis is confirmed on immunophenotyping. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euroacute leukemia, 3/5. E. E.J. Wisplinghoff Laboratories. Copyright overlay. Acute monocytic leukemia VV photomicrographs of a bone marrow smear, H&E stain, very high magnification. The large basophilic cell visible in each photomicrograph is a monocyte, identifiable by its large size, folded or lobed nucleus with fine chromatin and prominent nucleoli, green overlay, and abundant granular cytoplasm with cytoplasmic vacuoles. Numerous monocytes on bone marrow biopsy is characteristically seen in acute monocytic leukemia. The diagnosis is confirmed on immunophenotyping. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euroacute leukemia, 4/5. *Y at copyright Wisplinghoff Laboratories. Acute promyelocytic leukemia VV. Photomicrographs of a peripheral blood smear, H&E stain, very high magnification. The large basophilic cells are promyelocytes, identifiable by their eccentric nuclei and abundant basophilic cytoplasm containing numerous Auer rods, rod-like intracytoplasmic inclusion bodies. This type of hypergranular leukemic promyelocyte is often still referred to as a faggot cell for the resemblance of accumulation of Auer rods to a bundle of sticks, although the term is typically avoided today due to its derogatory associations. The presence of promyelocytes containing Auer rods in a peripheral blood smear is characteristic of acute promyelocytic leukemia. Note: basophilic remnants, Howell-Jolly bodies, are visible within most of the erythrocytes, indicating, in this case, increased hematopoiesis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Acute leukemia, 5/5. Stem cell R. Lymphatic stem cell. 37/ degree equals 00I degree 10 pound. E at E at E. RANK cell B cell T cell I3CEA. Plasma cell. Hematopoiesis. 5. Myeloid stem cell. A. X-yen, myeloblast. Monoblast. N. Megakaryoblast erythroblast. Megakaryocyte reticulocyte. Dendritic mast cell basophil eosinophil neutrophil monocyte thrombocytes erythrocyte cell. Leukopoiesis. Macrophage thrombopoiesis erythropoiesis. The stages of hematopoiesis, a process by which pluripotent hematopoietic stem cells in the bone marrow differentiate into two main types of precursor cells, myeloid and lymphoid. Myeloid precursor cells differentiate into erythrocytes, leukocytes, and thrombocytes. Lymphoid precursor cells differentiate into natural killer cells, NK cells, and B and T lymphocytes. Dendritic cells, which are antigen-presenting cells, develop from both myeloid and lymphoid precursors. Copyright Boss. Acute leukemia, 1/1. Stem cell R. Lymphatic stem cell. 37/ degree equals 00I degree 10 pound. E at E at E. RANK cell B cell T cell I3CEA. Plasma cell. Hematopoiesis. 5. Myeloid stem cell. A. X-yen, myeloblast. Monoblast. N. Megakaryoblast erythroblast. Megakaryocyte reticulocyte. Dendritic mast cell basophil eosinophil neutrophil monocyte thrombocytes erythrocyte cell. Leukopoiesis. Macrophage thrombopoiesis erythropoiesis. The stages of hematopoiesis, a process by which pluripotent hematopoietic stem cells in the bone marrow differentiate into two main types of precursor cells, myeloid and lymphoid. Myeloid precursor cells differentiate into erythrocytes, leukocytes, and thrombocytes. Lymphoid precursor cells differentiate into natural killer cells, NK cells, and B and T lymphocytes. Dendritic cells, which are antigen-presenting cells, develop from both myeloid and lymphoid precursors. Copyright Boss. Leukemia cutis VV. Multiple erythematous papules and nodules are seen on the face and neck of this patient as a result of infiltrating malignant neoplastic cells accumulating in the dermis. Source, Figure 2, in Salvage chemotherapy for the treatment of leukemia cutis in a patient with acute monocytic leukemia by Merdad Payande, Afshin Karami, Norodin Karami, Sudi Inayati, Murnish Ianfar, Biomedical Research and Therapy, licensed under CC by 4.0. Euro acute leukemia, 4/11. @-98-0-6. Myeloblast promyelocyte myelocyte metamyelocyte band segmented neutrophil physiological. Chronic myeloid leukemia. Leukemic hiatus acute myeloid leukemia. Leukemic hiatus VV. Myeloblasts differentiate within the bone marrow into mature neutrophils that then enter circulation. Physiologically, only the mature band and segmented neutrophils are visible on a normal peripheral blood smear, PBS. In chronic myeloid leukemia, CML, myeloid precursor cells and mature neutrophils are visible on a PBS. Whereas in acute myeloid leukemia, AML, the predominant myeloid cells on a PBS are myeloblasts and mature neutrophils. The absence of the intermediate myeloid precursor cells in AML is referred to as leukemic hiatus and is useful to differentiate AML from CML. Copyright Boss. Acute lymphoblastic leukemia, ALL, VV. Photomicrograph of bone marrow ASP irate smear, right staining, 1000x magnification, intermediate-sized blasts with dispersed chromatin, a moderate amount of cytoplasm, and indistinct nucleoli are seen alongside pale-stained erythrocytes. These findings are consistent with precursor B-cell ALL. Source: Acute Leukemia ALL by Vashidonsk, Wikimedia Commons, licensed under CC by SA 3.0. Acute leukemia, 2/11. At acute myeloid leukemia VV. Photomicrograph of a bone marrow smear, H&E stain, multiple myeloblasts are visible. These are identifiable as large basophilic cells with abundant non-granular cytoplasm and a large curved C-shaped nucleus with fine chromatin and prominent nucleoli. The presence of 20% of myeloblasts within a bone marrow smear is diagnostic of acute myeloid leukemia. The cells surrounding the myeloblasts are erythroid precursors and mature erythrocytes. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: Copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, Professor Dr. Karl Anton Kreutzer, Facharzt für Innere Medizin, Hematology und Oncology. X Smart Zoom Viewer. Powered by Smart Zoom. Copyright 2023 Smart in Media. X Smart Zoom Viewer. Register. SA. SN. Blast cell in AML-M2X. AA asterisk, PFS. And OE registered. 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 And SN. 6 registered. 2. 2 SSLDESN 0, B powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. Blast cell in AML-M2X. Powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. Blast cell in AML-M2X. Powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. Blast cell in AML-M2F. Powered by Smart Zoom. Copyright 2023 Smart in Media. Acute lymphoblastic leukemia VV. Photomicrograph of bone marrow smear, H&E stain, multiple lymphoblasts, identifiable as large basophilic cells with abundant granular cytoplasm and a large round nucleus with clumpy chromatin and prominent nucleoli, can be seen. The presence of 20% of lymphoblasts within a bone marrow smear is diagnostic of acute lymphoblastic leukemia. The cells surrounding the lymphoblasts are erythroid precursors, mature erythrocytes, and mature neutrophils. Click on the microscope icon to view the entire specimen through a virtual microscope. Source: Copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, Professor Dr. Karl Anton Kreutzer, Facharzt für Innere Medizin, Hematology und Oncology. X Smart Zoom Viewer. Powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. At %. L2 blast cell XL2 blasts are usually big blast cells with a variable nuclear structure, fine chromatin and multiple nucleoli. The medium-wide cytoplasm displays a distinctive basophilia, azurophilic granules may be present. The peroxidase reaction is negative. Staining is no longer relevant in all diagnostics. O/AZ at 4E. SF. Powered by Smart Zoom. Copyright 2023 Smart in Media. Acute leukemia, 5/11. ECIECTIATS SES EDFET. Overlay. Our rods VV. Photomicrograph of a peripheral blood smear, Guillain-Barré stain, high magnification, 2 red rod-like intracytoplasmic inclusions, blue overlay, are visible within the myeloblast, which is the large basophilic cell in the center of the image with an eccentric, indented nucleus and abundant cytoplasm. These rod-like cytoplasmic inclusions are known as our rods, and they are typically seen in acute myeloid leukemia, example acute promyelocytic leukemia, and in myelodysplastic syndromes. Source, copyright IMPP. Acute leukemia, 5/11. Overlay. Our rods VV. Photomicrograph of a peripheral blood smear, Guiam sustain, high magnification, 2 red rod-like intracytoplasmic inclusions, blue overlay, are visible within the myeloblast, which is the large basophilic cell in the center of the image with an eccentric, indented nucleus and abundant cytoplasm. These rod-like cytoplasmic inclusions are known as our rods, and they are typically seen in acute myeloid leukemia, example acute promyelocytic leukemia, and in myelodysplastic syndromes. Source, copyright IMPP. Acute leukemia, 6/11. Overlay. Our rods in acute promyelocytic leukemia, APL, VV. Photomicrograph of a bone marrow smear, right Guiam sustain, high magnification, promyelocytes with azurophilic granules can be seen as well as a myeloblast containing multiple violet, rod-like intracytoplasmic inclusion bodies, known as our rods, examples indicated by yellow lines. Our rods are typically seen in certain types of acute myeloid leukemia, example APL, and in myelodysplastic syndromes. Source, Figure 2, in promyelocytic leukemia with no retinoic acid receptor alpha abnormality but with RUNX1T1 insertion to chromosome 7q, a classification and management dilemma by K. Overholt, T. L. Ginepro, N. A. Hirama ETAL, Indawi, Case Reports in Hematology, licensed under CC by 3.0. Modifications, remove arrow. Acute leukemia, 6/11. Overlay. Our rods in acute promyelocytic leukemia, APL, VV. Photomicrograph of a bone marrow smear, right Guiam sustain, high magnification, promyelocytes with azurophilic granules can be seen as well as a myeloblast containing multiple violet, rod-like intracytoplasmic inclusion bodies, known as our rods, examples indicated by yellow lines. Our rods are typically seen in certain types of acute myeloid leukemia, example APL, and in myelodysplastic syndromes. Source, Figure 2, in promyelocytic leukemia with no retinoic acid receptor alpha abnormality but with RUNX1T1 insertion to chromosome 7q, a classification and management dilemma by K. Overholt, T. L. Ginepro, N. A. Hirama ETAL, Indawi, Case Reports in Hematology, licensed under CC by 3.0. Modifications, remove arrow. Acute leukemia, 7/11. Overlay. Our rods in acute myeloblastic leukemia. Photomicrograph of a peripheral blood smear, Pappenheim stain, high magnification, multiple red rod-like intracytoplasmic inclusions. Our rods, highlighted by gray overlay, are visible within a myeloblast, the large basophilic cell, marked by arrow, with an eccentric, indented nucleus, marked by black outline, and a prominent nucleolus, green overlay. Our rods are typically seen in acute myeloblastic leukemia and acute promyelocytic leukemia. Source, copyright IMPP. Acute leukemia, 7/11. Our rods in acute myeloblastic leukemia. Photomicrograph of a peripheral blood smear, Pappenheim stain, high magnification, multiple red rod-like intracytoplasmic inclusions. Our rods, highlighted by gray overlay, are visible within a myeloblast, Verlay large basophilic cell, marked by arrow, with an eccentric, indented nucleus, marked by black outline, and a prominent nucleolus, green overlay. Our rods are typically seen in acute myeloblastic leukemia and acute promyelocytic leukemia. Source, copyright IMPP. Acute leukemia, 8/11. Asterisk Y at copyright Wisplinghoff Laboratories. Acute promyelocytic leukemia BV. Photomicrographs of a peripheral blood smear, HNE stain, very high magnification. The large basophilic cells are promyelocytes, identifiable by their eccentric nuclei and abundant basophilic cytoplasm containing numerous Auer rods, rod-like intracytoplasmic inclusion bodies. This type of hypergranular leukemic promyelocyte is often still referred to as a faggot cell for the resemblance of accumulation of Auer rods to a bundle of sticks, although the term is typically avoided today due to its derogatory associations. The presence of promyelocytes containing Auer rods in a peripheral blood smear is characteristic of acute promyelocytic leukemia. Note: basophilic remnants, Howell-Jolly bodies, are visible within most of the erythrocytes, indicating, in this case, increased hematopoiesis. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euroacute leukemia, 9/11. Overlay. Acute promyelocytic leukemia. Photomicrograph of a peripheral blood smear of a patient with anemia and thrombocytopenia. The most numerous cells in the smear are promyelocytes, which are identifiable as large basophilic cells with a large nucleus, prominent nucleoli, and cytoplasm containing azurophilic granules that fuse to form Auer rods. Red overlay. A peripheral blood smear in which promyelocytes predominate and Auer rods are present is characteristic of acute promyelocytic leukemia. Source: Copyright IMPP. Euroacute leukemia, 9/11. Overlay. Acute promyelocytic leukemia. Photomicrograph of a peripheral blood smear of a patient with anemia and thrombocytopenia. The most numerous cells in the smear are promyelocytes, which are identifiable as large basophilic cells with a large nucleus, prominent nucleoli, and cytoplasm containing azurophilic granules that fuse to form Auer rods. Red overlay. A peripheral blood smear in which promyelocytes predominate and Auer rods are present is characteristic of acute promyelocytic leukemia. Source: Copyright IMPP. Euroacute leukemia, 10/11. E.S. E.J. Wisplinghoff Laboratories. Overlay. Acute monocytic leukemia VV photomicrographs of a bone marrow smear, H&E stain, very high magnification. The large basophilic cell visible in each photomicrograph is a monocyte, identifiable by its large size, folded or lobed nucleus with fine chromatin and prominent nucleoli, green overlay, and abundant granular cytoplasm with cytoplasmic vacuoles. Numerous monocytes on bone marrow biopsy is characteristically seen in acute monocytic leukemia. The diagnosis is confirmed on immunophenotyping. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euroacute leukemia, 10/11. E.J. Wisplinghoff Laboratories. Copyright overlay. Acute monocytic leukemia VV photomicrographs of a bone marrow smear, H&E stain, very high magnification. The large basophilic cell visible in each photomicrograph is a monocyte, identifiable by its large size, folded or lobed nucleus with fine chromatin and prominent nucleoli, green overlay, and abundant granular cytoplasm with cytoplasmic vacuoles. Numerous monocytes on bone marrow biopsy is characteristically seen in acute monocytic leukemia. The diagnosis is confirmed on immunophenotyping. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Euro. Normal translocation gene product. _WY. _BCR gene, 7. ADP /copyright 22Q11.2 BCRABL 7 fusion gene WY CHR9 CHR22 CHR9Q plus PH CHR22Q degree BCRABL stem cell fusion protein. Overlay. Philadelphia chromosome and pathophysiological consequences VV. Strand breaks in the ABL gene on chromosome 9 and in the BCR gene on chromosome 22 result in the translocation of fragments between both genes, reciprocal translocation. As a result, chromosome 9 is extended, 9Q+, and chromosome 22 is shortened, Philadelphia chromosome, 22q. The ABL gene fuses with the BCR gene on chromosome 22 to form the BCR-ABL fusion gene. ABL is a tyrosine kinase, whose regulatory unit is lost during translocation, red area on chromosome 9q+. The BRCA-ABL gene displays uncontrolled tyrosine kinase activity and influences cell division and differentiation, which is the cause of several leukemias, especially CML and partially all. The BCR gene is the chromosome 22 breakpoint site, BCR equals breakpoint cluster region. Overlay, imatinib, a tyrosine kinase inhibitor, binds to the ATP binding site of the fusion protein, therefore inhibiting uncontrolled cell division. Copyright Boss. Euro. Normal translocation gene product. Imatinib. ATF BCR gene ABL gene Elvin BCR ABL-P fusion gene. CHR9 CHR22. CHR9Q plus PH.CHR22Q BCR ABL, stem cell fusion protein. Overlay. Philadelphia chromosome and pathophysiological consequences VV. Strand breaks in the ABL gene on chromosome 9 and in the BCR gene on chromosome 22 result in the translocation of fragments between both genes, reciprocal translocation. As a result, chromosome 9 is extended, 9q+, and chromosome 22 is shortened, Philadelphia chromosome, 22q. The ABL gene fuses with the BCR gene on chromosome 22 to form the BCR-ABL fusion gene. ABL is a tyrosine kinase, whose regulatory unit is lost during translocation, red area on chromosome 9q+. The BRCA-ABL gene displays uncontrolled tyrosine kinase activity and influences cell division and differentiation, which is the cause of several leukemias, especially CML and partially all. The BCR gene is the chromosome 22 breakpoint site, BCR equals breakpoint cluster region. Overlay, imatinib, a tyrosine kinase inhibitor, binds to the ATP binding site of the fusion protein, therefore inhibiting uncontrolled cell division. Copyright Boss. X. Oncologic emergencies. Oncologic emergencies are a group of potentially life-threatening conditions that can manifest as a result of malignant disease and/or their treatment. These conditions include, but are not limited to, leukostasis, tumor lysis syndrome, TLS, superior vena cava, SVC, syndrome, malignant hypercalcemia, and neutropenic fever. Symptomatic patients must be rapidly assessed with early specialist intervention. Therapeutic goals in the treatment of the underlying oncologic condition, example palliative care, should always be taken into account during management. TLS results from rapid destruction of tumor cells releasing intracellular components into the bloodstream that can damage the kidneys and cause potentially fatal electrolyte imbalances. Management of TLS consists of hydration, correction of electrolyte disturbances and reduction of serum uric acid to preserve kidney function. Leukostasis results from massive amounts of leukocytes that cause microcirculatory obstruction leading to organ ischemia and failure. Management of leukostasis consists of cytoreduction, hydration, and prophylaxis against TLS. SVC syndrome results from impaired blood flow from the SVC into the heart, which leads to venous congestion in the head and upper extremities. Management of SVC syndrome depends on the underlying etiology and is aimed at reducing symptoms, example fluid restriction, treating complications, example cerebral edema, and restoring blood flow pharmacologically, radiologically, or mechanically. This article covers tumor lysis syndrome, leukostasis, and superior vena cava syndrome. Neutropenic fever and hypercalcemia are discussed in separate articles. WA. CE. Tumor lysis syndrome. Definition, L2. A potentially life-threatening oncologic emergency resulting from the rapid destruction of tumor cells, which leads to a massive release of intracellular components, example potassium, K+, phosphate, Po*, and uric acid, that can damage the kidneys and cause renal failure. Etiology, L2L. TLS most commonly occurs after initiating cytotoxic treatment in patients with hematologic malignancies, example ALL, AML, or NHL. SENT can also manifest unrelated to therapy in patients with a very high tumor burden pathophysiology. SENT tumor cell lysis release of intracellular components, example K, Po, nucleic acids, into the bloodstream. Copyright T nucleic acid conversion to uric acid hyperuricemia urate nephropathy and risk of acute kidney injury. Copyright CA, secondary to Po binding hypocalcemia neuronal excitability risk of seizures. O hyperphosphatemia, Po binds Ca2 and forms calcium phosphate crystals that obstruct renal tubules. Acute kidney injury. O hyperkalemia, changes in resting membrane. Potential risk of cardiac arrhythmias. Think of puke calcium to remember the electrolytes affected in tumor lysis syndrome. Phosphorus, uric acid, and potassium, K*, are elevated, calcium is decreased. Clinical features. 3. Signs and symptoms are closely related to the degree of electrolyte abnormalities and acute kidney injury. SENT renal failure, example edema, lethargy, oliguria e hyperkalemia, example cardiac arrhythmias, nausea, vomiting, and diarrhea e hypocalcemia, example tetany, muscle cramps, seizures. Registered electrolyte abnormalities in TLS can lead to seizures, cardiac arrhythmias, and sudden cardiac death. Diagnostics. Consider TLS in any patient with hematological malignancies and hyperleukocytosis who have electrolyte imbalances, kidney failure, or recently initiated cytotoxic therapy. Management of TLS, 2-2-4. Identify patients with established TLS and those at high risk, example hematological malignancy, chemotherapy, SENT start intensive fluid therapy, uric acid reduction, and correction of electrolyte imbalances. SENT consider notifying ICU, nephrology, and oncology early on. Copyright renal replacement therapy is indicated if the following complications are intractable: fluid overload, electrolyte imbalances, or hyperuricemia. Fluid management. Back collapse. Find text outline. Fluid management. Hydration is the mainstay of TLS prophylaxis and treatment. Hydration is the most effective preventive measure. Avoid nephrotoxic drugs, example NSAIDs, and fluids with added potassium due to the risk of hyperkalemia. Electrolyte imbalances. Monitor electrolytes regularly, as they can also be affected by fluid therapy. Hyperkalemia, cardiac monitoring and standard therapy for hyperkalemia if K*= 6 milliequivalent/L, example glucose and insulin, rapid action, SENT hyperphosphatemia, hydration and possibly oral phosphate binders, example sevelamer. SENT hypocalcemia, treat only if symptomatic and give the lowest calcium dose to relieve symptoms, see hypocalcemia. Hyperuricemia. SENT allopurinol. Copyright indicated as prophylaxis in patients at low to intermediate risk plus RAS uricase, recombinant uricase that catalyzes the breakdown of uric acid to allantoin. Copyright indications equals treatment of established TLS equals prophylaxis for intermediate to high risk patients. Copyright contraindications, G6PD deficiency, which can precipitate hemolytic anemia * urinary alkalinization, no longer routinely recommended. 1. RAS uricase is indicated for patients with established TLS or those at intermediate to high risk for TLS. G. Leukostasis. Definitions, 81. SENT leukostasis, a medical emergency characterized by tissue hypoxia and hypercoagulability due to an excessive number of immature leukocytes causing microvascular obstruction. SENT hyperleukocytosis, a highly increased number of leukocytes, commonly defined as a WBC to 100,000/mm*, that may or may not be accompanied by leukostasis. Etiology 8IL9. E most commonly occurs in acute leukemia, more common in AML than all. 0 Copyright AML, with WBC 150,000/mm. Copyright all, with WBC 400,000/mm. Scent rarely seen in chronic leukemia EOCML, almost exclusively in accelerated phases or blast crisis. Copyright CLL, with extremely high WBC, 1,000,000/mm. Pathophysiology. Very high number of leukemic blasts, increased viscosity of blood, increased risk of vascular obstruction, tissue hypoxemia and infarction. Clinical features of leukostasis plus contributing factors, endothelial activation and high metabolic activity of the dividing immature leukocytes. 5. Clinical features, 91I5. Clinical features depend on the affected system or organ. Although the lungs and the CNS are most commonly affected, leukostasis can also cause TLS and DIC, a frequent complication of APL. Plus respiratory, E dyspnea and tachypnea, E pulmonary crackles, O hypoxemic respiratory failure, scent neurological, E headache, confusion. Copyright dizziness, vertigo, focal neurological deficits, O seizures, scent ophthalmological, blurry vision, retinal hemorrhages, papilledema, scent others. Back collapse, fine text outline. Scent others, O fever, common. Copyright acute kidney injury symptoms, O deep venous thrombosis, myocardial infarction, priapism, O symptoms of concomitant TLS or DIC. Diagnostics, 91I5. Scent leukostasis is primarily a clinical diagnosis. 1. Scent high index of suspicion in oncologic patients with clinical features suggestive of end organ damage. E hyperleukocytosis is commonly present but not mandatory for diagnosis. Treatment, 9. 8. Cytoreduction. Scent induction chemotherapy, treatment of choice for curative intent. Toll scent leukapheresis plus hydroxyurea, IL-5. Additional measures. Plus intravenous fluid resuscitation with 4 isotonic crystalloids. 1 Scent TLS prophylaxis according to risk, see tumor lysis syndrome, and monitoring for DIC. Scent avoid blood cell transfusions, if possible. WA. OOES. Superior vena cava syndrome. Definition 121.
3년쯤 전에
Venous
그 코로나
congestion
한창
of the
유행할 때
head,
우리
neck,
미국 여행
and
갔었죠.
upper extremities resulting from impaired venous flow through the superior vena cava, SVC, to the right atrium. O and equals to equals dash equals equals. Etiology, 13. Conditions that obstruct the SVC intraluminally, example neoplastic invasion, thrombosis, or due to extraluminal compression, example Pancoast tumors, mediastinal masses. The etiology of SVC syndrome is the basis for its classification. Plus malignant SVC syndrome, most common, 12-14. Copyright the following entities account for 80% of all SVC syndrome cases, equals non-small cell lung cancer, NSCLC, equals small cell lung cancer, SCLC, equals non-Hodgkin lymphoma, NHL, O less common, metastatic cancer, usually breast cancer, germ cell tumors, thymoma, mesothelioma plus non-malignant SVC syndrome, 3. O most commonly caused by thrombosis associated with an intravascular device, example dialysis catheter, pacemaker wire, 13. Copyright can also be due to other conditions that cause compression of the SVC1. Clinical features, 151, 120, 114. Symptoms usually progress over weeks, but rapid deterioration causing emergency presentation can occur. Evaluate patients for signs of increased ICP. Hemodynamic symptoms: O edema of the upper extremities and face, facial plethora, O prominent venous pattern on the chest, face, and upper extremities. O jugular venous distension. Copyright orthostatic hypotension. O syncope. O renal failure. Scent symptoms and signs of congestion of the neck. O dyspnea. O cough and hoarseness. Back collapse. Fine text outline. Copyright. The following entities account for 80% of all SVC syndrome cases: non-small cell lung cancer, NSCLC, small cell lung cancer, SCLC, non-Hodgkin lymphoma, NHL, O less common, metastatic cancer, usually breast cancer, germ cell tumors, thymoma, mesothelioma plus non-malignant SVC syndrome. 3. Copyright. Most commonly caused by thrombosis associated with an intravascular device, example dialysis catheter, pacemaker wire. 113. Copyright can also be due to other conditions that cause compression of the SVC1. Clinical features. 151L12I14. Symptoms usually progress over weeks, but rapid deterioration causing emergency presentation can occur. Evaluate patients for signs of increased ICP. Scent. Hemodynamic symptoms. O edema of the upper extremities and face, facial plethora. Copyright. Prominent venous pattern on the chest, face, and upper extremities. O jugular venous distension. Copyright orthostatic hypotension. Copyright syncope. O renal failure. Symptoms and signs of congestion of the neck. O dyspnea. Copyright cough and hoarseness. Copyright stridor. O dysphagia *. Neurological symptoms. 16. O headache. O dizziness. Copyright confusion and mental obtundation. O visual impairment. Evaluate frequently for signs of laryngeal edema, hemodynamic instability, and TICP. Diagnostics. 131I14. Plus unstable or severely symptomatic patients. Invasive venography with or without stent placement, gold standard, * stable patients. Copyright CT chest with CT venography, modality of choice for most patients. 17. O Doppler ultrasound, initial investigation for suspected catheter-associated thrombosis. 118. Management. 131I20. Plus patients with severe symptoms, usually require emergency endovascular treatment. 5. Scent. Definitive treatment depends on the underlying condition. O malignant SVC syndrome, tumor-specific management. O non-malignant SVC syndrome, directed therapy if possible, anticoagulation if thrombosis is present. Scent. Specialists should be involved early to provide an individualized treatment strategy. Patients with severe or life-threatening SVC syndrome require emergency treatment, example invasive venography with stent placement. OOE. Tips and links. Sources. Last updated September 11, 2023. Back collapse. Fine text outline. Uro-oncologic emergencies, 2 halves. Tumor cell lysis plus nucleic acids plus POSTK. Precipitation, with Ca2 * purines allopurinol. Hypoxanthine/6 calcium phosphate 2 plus xanthine crystals 1 Ca xanthine oxidase uric acid _ plus uric acid crystals equals plus at -rasp uricase allanto in acute kidney seizures, tetany, abnormal ECG findings, muscle injury, muscle cramps, arrhythmias, weakness. Tumor lysis syndrome. Tumor lysis syndrome results from the rapid destruction of tumor cells and subsequent massive release of intracellular components. It occurs most commonly in patients with hematologic malignancies, example ALL, AML, or NHL, at the beginning of cytotoxic treatment, but may also occur spontaneously. The accumulation of uric acid crystals can cause acute kidney injury, and the electrolyte imbalances can have life-threatening consequences such as cardiac arrhythmias and seizures. Copyright Boss. Co-oncologic emergencies, 1/2. Uric acid crystals. Photomicrograph of a urine sample with a pH of 5, phase contrast microscopy, high magnification, multiple crystals of varying sizes and shapes can be seen, blue overlay. Their diamond-shaped, rhomboid form is one of the characteristic appearances of uric acid crystals, which only form in urine samples with a pH Uro-oncologic emergencies, 1/3. Pathophysiology symptoms. Edema of a brain, headache, dizziness OM. Face of facial plethora. Jugular venous distension, neck OLL/stridor, dyspnea, SVC obstruction, upper ndiffy dysphagia, example due to lung tumor, extremities. Chest, upper venous congestion. Increased drainage via collateral veins. Superior vena cava syndrome VV. Superior vena cava, SVC, syndrome is caused by obstruction of the SVC, example due to malignancy or intraluminal thrombosis, resulting in impaired blood flow from the SVC into the right atrium. As a consequence, drainage occurs increasingly into the inferior vena cava via collateral veins, resulting in a prominent venous patterning on the upper body. Venous congestion proximally to the obstruction results in edema of the upper extremities, neck, and face. SVC syndrome can become life-threatening if cerebral edema, leading to increased intracranial pressure, or laryngeal edema develop. Copyright Unpack. Oncologic emergencies, 2/3. Superior vena cava obstruction VV. Multiple dilated, tortuous, subcutaneous veins are visible over the anterior thorax and proximal arms. This pattern of thoracic subcutaneous venous dilation not extending to the abdomen is pathognomonic for superior vena cava obstruction. Source: Copyright IMPP. Overlay. Superior vena cava obstruction VV. CT chest, with contrast, axial plane, of a patient with metastatic adenocarcinoma of the lung and infiltrating mediastinal mass, green overlay, encases the superior vena cava and right upper lobe pulmonary artery and extends to the left and right main bronchi, right upper lobe bronchus, aorta, and esophagus. A small amount of intervening fat remains visible along the course of the left pulmonary artery. The superior vena cava is displaced anteriorly, and its lumen is markedly attenuated. A. Ascending aorta, D. Descending aorta, E. Esophagus, LMB, left main bronchus, LPA, left pulmonary artery, RMB, right main bronchus, RULPA, right upper lobe pulmonary artery, SVC, superior vena cava source, Figure 1, in a rare case of syndrome of inappropriate antidiuretic hormone in non-small cell lung cancer presenting as superior vena cava syndrome by Reese Ishihara, Catherine Stews, Sunil Jagdesh, Chem Nguyen, Curious, licensed under CC by 3.0. X. Hemolytic uremic syndrome. Hemolytic uremic syndrome, HUS, is a thrombotic microangiopathy in which microthrombi, consisting primarily of platelets, form and occlude the arterioles and capillaries. These occlusions result in the simultaneous occurrence of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, AKI. HUS predominantly affects children and is caused by bacterial toxins, most commonly the Shiga-like toxin of enterohemorrhagic Escherichia coli, E. coli, 0157H7. If there is a strong suspicion of HUS based on clinical presentation and initial laboratory tests, treatment should begin immediately, as the condition may result in renal failure. Patients receive symptomatic treatment for renal symptoms, anemia, and complications affecting other organs, such as the brain and GL tract. Thrombotic thrombocytopenic purpura, TTP, the other main type of thrombotic angiopathy, is discussed in the respective article. 2*. Epidemiology. Mainly children. OO. And etiology. Plus bacterial exotoxins. 1 Copyright Shiga-like toxin, virotoxin, equals from enterohemorrhagic E. coli, EHEC, strain 0157H7 equals usually transmitted via contaminated foods, example undercooked beef or raw leafy vegetables. Copyright Shiga toxin produced by Shigella dysentery sense Streptococcus pneumoniae infection atypical hemolytic uremic syndrome, complement dysregulation, hereditary or acquired, accounts for approximate 5% of HUS cases with non-infectious etiologies, referred to as atypical HUS, AHUS. 3. And approximate 15% of children infected with E. coli 0157H7 will go on to develop HUS. O. Pathophysiology. HUS is a thrombotic microangiopathy, a condition characterized by the formation of microthrombi occluding the microvasculature. The other main thrombotic microangiopathy is thrombotic thrombocytopenic purpura, TTP. The two conditions have some pathophysiology and clinical findings in common, but different etiologies. HUS is caused by bacterial toxins. 4.1. Infection with enterohemorrhagic E. coli, EHEC, or another causative organism. 2. Mucosal inflammation facilitates bacterial toxins entering systemic circulation. 3. Toxins cause endothelial cell damage, especially in the glomerulus. 4. Damaged endothelial cells secrete cytokines that promote vasoconstriction and platelet microthrombus formation at the site of damage, intravascular coagulopathy, thrombocytopenia, consumption of platelets. 5. RBCs are mechanically destroyed as they pass through the platelet microthrombi occluding small blood vessels, i.e., arterioles, capillaries, hemolysis. Schistocytes, and end organ ischemia and damage, especially in the kidneys. Decreased glomerular filtration rate, GFR. Q. E. coli 0157H7 infection. Shiga-like toxin in systemic circulation. Toxin-mediated endothelial injury. Microthrombus formation. Blockage of small vessels. RBC fragmentation, hemolysis, and end organ damage. OOFA, Cs. Clinical features. A diarrheal illness, usually bloody, for the past 5 to 10 days precedes the onset of HUS symptoms in many children. The triad of clinical findings occurring in HUS consists of LJ-cent thrombocytopenia o petechiae, purpura. Back collapse. Fine text outline. Plus thrombocytopenia. Copyright petechiae, purpura. E. Mucosal bleeding. Copyright prolonged bleeding after minor cuts. Cent microangiopathic hemolytic anemia. OE fatigue, dyspnea, and pallor. Degree jaundice. Cent impaired renal function. OE hematuria, proteinuria. Copyright oliguria, anuria. Re. The typical HUS patient is a preschooler who has had a diarrheal illness for the past 5 to 10 days and presents with petechiae, jaundice, and oliguria. Diagnostics. Hematology. Degree hemolytic markers. Hemoglobin equals haptoglobin equals T. Indirect bilirubin 1 reticulocytes 1 LDH T. Schistocytes on blood smear, up to 10% of RBCs. Copyright coagulation profile. Platelets 1 normal/slightly elevated prothrombin time, PT, and activated partial thromboplastin time, APTT, in contrast to DIC. See differential diagnoses below, equals normal/slightly elevated fibrin degradation products and D-dimer levels. OTWBC count - O negative Coombs test. Asterisk serum chemistry, T-bun and F-creatinine, impaired renal function, E. urinalysis, hematuria, proteinuria. Differential diagnoses. HUS. Pathophysiology. Typical presentation. Back. Endothelial cell dysfunction due to bacterial toxins. Toddler or preschooler with history of diarrheal illness presents with petechiae, jaundice, and oliguria. ADAMTS 13 deficiency. Previously healthy adult, sometimes associated with triggers, example infection, surgery, pregnancy, presents with mental status changes, fever, petechiae, fatigue, and pallor. Is of disseminated intravascular coagulation, DIC. Systemic coagulation activation. Platelet and coagulation factor consumption, mixed disorder. Patient with a history of serious underlying illness, example sepsis, trauma, malignancy, presents with thrombosis. Feedback. Immune thrombocytopenic Beimert-Sully or GL purpura, IDP. Adhesion disorder, plus aggregation disorder, asterisk antiplatelet SSRE deficient platelet GPILB antibodies, anti-CEILG/LILA, AM plus autosomal asterisk autosomal recessive. Asymptomatic or presenting with petechiae, purpura, epistaxis, menorrhagia, gingival bleeding embolism, organ dysfunction, and or bleeding. Fossa collapse. A. Find text. A. Outline. Parenheral asterisk plus schistocytes plus schistocytes irreferral SMP ear. Platelets sent J platelets. PT, INR, and a PTT equals normal / increased increased. D-dimer, fibrin degradation normal / increased increased products. Other platelet disorders von Willebrand disease acquired disorders of platelet function, example drugs such as aspirin, NSAIDs, uremia, paraproteins, see also thrombocytopenia and heparin-induced thrombocytopenia. The differential diagnoses listed here are not exhaustive. Treatment plus supportive care 2. Sent giant platelets normal platelet J platelets morphology abnormal 1 platelets ristocetin cofactor assay. Normal. Avoid antibiotics and antimotility agents, may increase the likelihood of HUS in suspected infection with EHEC. Copyright monitor and correct fluid status abnormalities. For more information, see clinical assessment of volume status, equals electrolyte disturbances. For more information, see electrolyte metabolism, equals acid-base disorders equals blood pressure, due to hypertension or septic shock, equals RBC transfusions 10 anti-epileptic drugs, example diazepam, phenytoin, in patients with seizures. Sent dialysis, as indicated for AKI up to 50% of HUS patients require dialysis. Asterisk plasma exchange therapy, only in refractory cases, sent eculizumab. O effective for the treatment of AHUS 5. Copyright may be beneficial in HUS with neurological symptoms, 6. Plus normal platelets asterisk abnormal results on platelet aggregation testing confirm the diagnosis. Post-diarrheal HUS is a nationally notifiable condition. 7. Copyright platelet transfusions should be administered with caution unless patients are bleeding or require an invasive procedure. Some studies suggest that they can exacerbate microangiopathy. Complications. HUS can result in microthrombus formation and complications in various organs, CNS1. Seizures oparesis copyright stroke degree coma sent GL tract EO hemorrhagic colitis copyright bowel necrosis, perforation, stricture copyright peritonitis copyright intussusception sent heart, ischemia and fluid overload sent pancreas, transient or permanent diabetes mellitus sent liver, hepatomegaly, transaminase elevations plus kidney. Hypertension copyright chronic kidney disease, CKD, copyright end-stage renal disease, ESRD. V. Back collapse. A. Find text. Al. Outline. X hemolytic uremic syndrome. Plus supportive care 2 copyright avoid antibiotics and antimotility agents, may increase the likelihood of HUS in suspected infection with EHEC. Copyright monitor and correct fluid status abnormalities. For more information, see clinical assessment of volume status, equals electrolyte disturbances. For more information, see electrolyte metabolism, equals acid-base disorders equals blood pressure, due to hypertension or septic shock, equals RBC transfusions 1 copyright anti-epileptic drugs, example diazepam, phenytoin, in patients with seizures sent dialysis, as indicated for AKI up to 50% of HUS patients require dialysis. Plus plasma exchange therapy, only in refractory cases, sent eculizumab copyright effective for the treatment of AHUS, 5L copyright may be beneficial in HUS with neurological symptoms. 6. At, post-diarrheal HUS is a nationally notifiable condition. 7. Copyright platelet transfusions should be administered with caution unless patients are bleeding or require an invasive procedure. Some studies suggest that they can exacerbate microangiopathy. WA. Or complications. HUS can result in microthrombus formation and complications in various organs, degree CNS, O seizures copyright paresis copyright stroke O coma sent GL tract EO hemorrhagic colitis copyright bowel necrosis, perforation, stricture copyright peritonitis copyright intussusception sent heart, ischemia and fluid overload sent pancreas, transient or permanent diabetes mellitus liver, hepatomegaly, transaminase elevations * kidney O hypertension copyright chronic kidney disease, CKD, end-stage renal disease, ESRD. We list the most important complications. The selection is not exhaustive. Why? And prognosis. The prognosis depends primarily on prompt initiation of treatment. Timely treatment can prevent acute complications, AKI, coma, and death, as well as progression to chronic renal failure. Sent with treatment, the mortality rate of HUS is low. Back collapse fine text outline. Urohemolytic uremic syndrome, 1/1. Hemolytic uremic syndrome, HUS, thrombotic thrombocytopenic purpura, TTP. Pallor, jaundice 6 mucosal bleeding. History of, sent. Petechiae, purpura, bruises NS, LHEO. At. Bloody diarrhea due to E. coli strain 0157H7G2 swab iadini, produces Shiga toxin, ***. Neurological symptoms, example headache, confusion, seizure, fever WYX. Laboratory findings BW-NA. E. hemolytic anemia E. thrombocytopenia vom E. T. creatinine / E. schistocytes on blood smear E. TTP, ADAMTS 13 activity NEN. Hemolytic uremic syndrome and thrombotic thrombocytopenic purpura VV. Copyright Boss. AAEI Wisplinghoff Laboratories. Overlay. Schistocytes VV. Photomicrograph of peripheral blood smear numerous healthy erythrocytes, E, and several fragmented erythrocytes, black dashed circles, with a normal convex side, colored blue, and a fragmented side that is concave or straight, colored red, can be seen. Schistocytes are a diagnostic finding in microangiopathic hemolytic anemias. These cellular fragments can also result from mechanical damage to erythrocytes, example due to prosthetic heart valves. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. 7 or EE. Same. AEJ Wisplinghoff Laboratories. Overlay. Schistocytes VV photomicrograph of peripheral blood smear numerous healthy erythrocytes, E, and several fragmented erythrocytes, black dashed circles, with a normal convex side, colored blue, and a fragmented side that is concave or straight, colored red, can be seen. Schistocytes are a diagnostic finding in microangiopathic hemolytic anemias. These cellular fragments can also result from mechanical damage to erythrocytes, example due to prosthetic heart valves. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Schistocytes in hemolytic uremic syndrome VV. Photomicrographs of a peripheral blood smear erythrocytes with a convex and a concave side can be seen among the normal erythrocytes. These fragmented erythrocytes are known as schistocytes, black circles. Schistocytes are a diagnostic finding of hemolytic uremic syndrome, HUS. They may also be caused by other forms of microangiopathic hemolytic anemia or mechanical damage to erythrocytes. Source: Copyright IMPP. Talbi El Oler Detasit Hist, with a allo. R. In B seen th. H. Verlag 9 typic diagnostic find. Order on the Urohemolytic uremic syndrome, 4/4. 0% QSQ09%.F6,000%. Schistocytes VV. Photomicrograph of a peripheral blood smear fragmented erythrocytes, which are convex on one side, examples indicated by blue lines, and concave on the other, examples indicated by yellow lines, can be seen among the normal erythrocytes. These fragmented erythrocytes are referred to as schistocytes. Schistocytes are a diagnostic finding in patients with microangiopathic hemolytic anemias and those with mechanical damage to erythrocytes, example from artificial heart valves. Source: Schistocytes by Professor Osiro Haber, Wikimedia Commons, licensed under CC 01.0. Modifications: cropped the image as there was some bad quality scale in the right lower edge. Urohemolytic uremic syndrome, 4/4. 10% 9SQ080.96,000%. Overlay. Schistocytes VV. Photomicrograph of a peripheral blood smear fragmented erythrocytes, which are convex on one side, examples indicated by blue lines, and concave on the other, examples indicated by yellow lines, can be seen among the normal erythrocytes. These fragmented erythrocytes are referred to as schistocytes. Schistocytes are a diagnostic finding in patients with microangiopathic hemolytic anemias and those with mechanical damage to erythrocytes, example from artificial heart valves. Source: Schistocytes by Professor Osiro Haber, Wikimedia Commons, licensed under CC 01.0. Modifications: cropped the image as there was some bad quality scale in the right lower edge. Hemolytic uremic syndrome, 1/1. Nephrosclerosis following hemolytic uremic syndrome, HUS, VV. Photomicrograph of renal tissue, H&E stain, high magnification. The renal corpuscle in the center of the image is surrounded by numerous atrophic tubules, examples indicated by blue overlay, and partly occluded vessels with eosinophil hyaline material, fibrin and platelet aggregates, indicated by green overlay. Also, interstitial fibrosis, examples indicated by red overlay, and interstitial edema, examples indicated by yellow overlay, can be seen within the surrounding tissue. The amount of interstitial fibrosis indicates nephrosclerosis. Source: copyright IMPP. Hemolytic uremic syndrome, 1/1. Nephrosclerosis following hemolytic uremic syndrome, HUS, VV. Photomicrograph of renal tissue, H&E stain, high magnification. The renal corpuscle in the center of the image is surrounded by numerous atrophic tubules, examples indicated by blue overlay, and partly occluded vessels with eosinophil hyaline material, fibrin and platelet aggregates, indicated by green overlay. Also, interstitial fibrosis, examples indicated by red overlay, and interstitial edema, examples indicated by yellow overlay, can be seen within the surrounding tissue. The amount of interstitial fibrosis indicates